Assalamu alaikum wa rahmatullahi wa barakatuh. Uh, it is my pleasure to invite you all to our ninth International Conference in Pediatric Emergency Medicine. This conference this time is hosted by the Society of Pediatric Emergency Medicine in Kingdom of Saudi Arabia, and with collaboration and partnership of Al Faisal University and the Saudi Pediatric Association, and collaboration with our colleagues in the United States of America, American Academy of Pediatrics, and American College of Emergency Physician. I would like to make few announcements, if you allow me, please, regarding, first of all, the chat features. The chat features in Zoom has been disabled to ensure full attention to the conference. Okay, and also please, you don't have to write your name or your Momaris number or anything, because once you are in, you are automatically registered. You have to attend more than 70% of the total conference duration. This is very important to have the CME hours of this conference, which is 24 hours. Also, I would like to ask you for any questions or comments or any query, you can go over the question and answer area. Certificates of the conference or of attendance will be given to you and issued within 3 to 4 business days after the end of the conference. I hope this will answer all your questions. I'm going to talk about the history of pediatric emergency. We'll start with this first lecture. I usually give this lecture every time just to update our colleagues and our attendees of the history of the pediatric emergency and also an emergency medicine in Saudi Arabia in general. As you know, I have no disclosure or nothing to disclose or to mention. I start with this map of Saudi Arabia, just to give you an idea of that Saudi Arabia, it is more than 13 regions. It's about 2.4 million square kilometers, and it is a rapidly growing population. And expected population in 2025, this year, reach more than 37 million, Saudi and non-Saudi. With 80% of population, they are living mainly in the urban area, which is the major city, like Riyadh, Mecca, Jeddah, Eastern region. Okay, and this made it difficult for our emergency services to expand to all the areas of Saudi Arabia, especially the rural area. Here you can see this pyramid graph, which can show if you look closer, the percentage of pediatric population, it's around 34%, while those who are under 60 years, about 55%. And this made our nation or our country, it is a young country. When we go to the health delivery system in Saudi Arabia, this is, I consider this is about more than 2-3 years slide, which showed that in Saudi Arabia, it is predominantly provided the health by the Ministry of Health, about 60%. The Ministry of Health will operate, uh, and while the government agencies like King Faisal Hospital, National Guard Hospital, Ministry of Defense Hospital, Ministry of Interior, or Ministry of Education Hospital, they will cover their own employee around 20%, while the private sector will have the remaining 20%. Nowadays, in the last few years, we have growing in the private sector, which almost reached like around more than 30%. Just to give you a history where I did actually did my residency program. This was in King Fahad Hospital and National Guard, and where I went for a scholarship from this hospital. And after I finished my fellowship program, I came back to this hospital. This was in the early 2000, in 2001. After that, we this is just a picture. I really like it. It is more than 20 years old picture, and it showed interesting people here. I feel proud working with them, and maybe you know some of them. This is, as you can see here, in the to my left. Uh, Dr. Alula, who is infectious disease consultant, and Dr. Al-Hajiri Ahmed, who is a colleague and a senior pediatric emergency consultant. And next to him is Dr. Muhammad Al-Hussein, who is a well-known senior pediatric emergency, and now he's working in King Faisal Hospital. We'll go to this picture. Then in 2007, I went to King Faisal Hospital. This is the building of King Faisal Hospital at that time in 2007. Uh, After in 2015, King Salman inaugurated the opening of King Abdullah Children's Specialist Hospital in National Guard. And as you can see, it is a state-of-the-art building where it has all the specialties. They are doing the major operation, the senior the twin separation here in this hospital. And before that, actually, we National Guard considered the first center established the pediatric emergency department in their facility. While I was working in while I was working in King Faisal Hospital in 2015, King Salman also opened the King Abdullah Center for liver transplant and organ transplant, and it's a state-of-the-art transplanted center which committed to advance medical care in oncology cases. Maybe. Also, 2 years later, in 2017, it was opened the emergency department in King Faisal, and it was opened by the governor of Riyadh, and it was one of the best departments in the whole region. Now, let me talk about our nature in Saudi Arabia and what we are unique in, and what is the uniqueness of Saudi Arabia. As you can see, and know that uh, unfortunately in our country, we are one of the countries that has a high rate of traffic accident. Thanks, voice is clear. Uh, as we mentioned, and consider one of the high rate of accident in the world, which cost a lot of money and efforts. But thanks to Vision 2030 and for the new regulations and the enforcement of the new regulations that force uh, the importance of the traffic rules and made uh, this one is, I'm sorry, they said the voice is not clear. Okay, am I clear now? Okay, okay. Now, as I told you, we have a very high rate of traffic accident in Saudi Arabia, and but with the Vision 2030, with enforcing the traffic regulation, uh, luckily this number of was the rate of accident has been decreased by 34%. This was announced by the Minister of the Interior. Uh, and this is very good news. And I think this was announced about a few years ago, and I'm sure this number will be decreased more and more. Also, if you go over the uh, you know what, that we have more than in Saudi Arabia, uh, most of the people they wish to go to the emergency department for any problems compared to other, yeah, major countries like in the United States. If you take 100%, only 30 to 40 will go to visit emergency department for emergency situation. While in Saudi Arabia, if you take 100%, they will go all of them to the emergency because the easy access and the easy services there. Uh, but according to the Vision 2030, they concentrate more in the primary care because, as you know, why the people, most of them, they are going to the emergency department because we don't have yet a strong and a very good established primary care center. And this is the Vision 2030, and hopefully they start doing this. And with the time, the number of cases going to the emergency department will be decreased dramatically and will go to the primary care center and leave the emergency department for the emergency cases. Also here, we are proud, and one of our uniqueness in the pandemic COVID-19, that our experience has already strengthened and make us very strong during COVID-19, and we are proud to have very effective taking very effective measures during the COVID-19, and we have the lowest morbidity and mortality compared to major countries. And we consider this as a major achievement. And thanks to the Ministry of Health and all the people working during that time. We are also unique in uh, uh, as a religious place, Mecca and Al Medina, and we are having and hosting more than 3 million pilgrims annually. And despite the challenges, our emergency system ensure the safety of all these pilgrims and all the visitor to Mecca or Al Medina. And as you know, this is within a small area, but the kingdom considered to be very successful in managing these mass gatherings, and we are a leader in mass gathering medicine, as you know. When we go now to also according to Vision 2030, Riyadh considered to be now one of the top destination, thanks to 2030 vision. The city attracts major global activities, events, and now, as you know, the Saudi Arabia now heading to the future. And with Vision 2030, we will have this Expo 2030, and we will have also the World Cup in 2034. And the healthcare specialty, especially the emergency care, must raise at a higher level and higher global standard to meet and for these major events. Okay. Here's just some picture of Riyadh. This is also the financial center, Riyadh King Abdullah Financial Center, which is actually the top destination for major global companies and banks in the region and in the world. Also, not to forget, Saudi Arabia, it has also a historic places. This is Al Ula, north of Saudi Arabia, close to Al Medina. And when I visited Al Ula, I was really feel like it is a journey through the history of nature. And the first striking sight you can see is the massive temple carved into the rocks by Madain Saleh people at that time, and the ancient engraving, as you can see, which is more than 2,000 years, okay, dating back to what we call it Al-Anbat, Nabatean civilization, Asr al-Anbat, and depicted stories of strength and antiquity. Walking through these areas, yani, you feel like just to imagine the life at that time. This is like a graves for their people, as you can see these halls for their important people and the kings and at that time. Also, if you can see, this is called the Elephant Mountain. It's shaped like an elephant, and you see now people they are going there visiting this area. Okay, and you see during the sunset the beautiful of the. Also in Saudi Arabia, we are lucky because of the huge land area of Saudi Arabia. During summertime in the center, we have in the southwest very nice weather, for example, in Abha, in Khamis and Sheikh, and in Namas, and also in Haifa. You can, the weather there is very nice, and there is a lot of tourists going there. I don't want to talk about the Saudi Arabia, so let me talk more now. We'll go and talk about the history of emergency in Saudi Arabia. As you, let's just zoom and to how to see how the pediatric emergency medicine evolved globally. As you know, American Academy of Pediatrics were founded in 1930, more than 38 years after, followed by ACEP, American College of Emergency Physician. And then 20 years later, the section of pediatric emergency medicine was established in ACEP. We are lucky in Saudi Arabia. Dr. Al Hudayb, he is the one who established the emergency board in 2000. It was at that time under the surgery. Okay, by 2005, the Saudi Commission for Health Specialties approved the Saudi Board in Emergency Medicine to work independent specialty. And that during this period in 2004, actually, we submit our proposal for pediatric emergency fellowship program. I'm proud to be one of those who established this program in National Dartmouth Hospital, where it was the first place to have the fellowship program in addition to King Faisal Hospital. Later on, in 2008, SASM was established, okay, and recently, in the beginning of the year, we established our Society of Pediatric Emergency, and we feel honored for this achievement. This is just briefly the Saudi Board of Emergency Medicine started in 2000 with a number of only 4 trainees. This is one of their meetings. This was during that time, as you can see here, some of our colleagues at that time. Uh, Now, the Saudi Board of Emergency Medicine has more than 22 centers around the kingdom. Okay, most of it in Riyadh and other areas. And trainee graduated more than 600 trainees, and the current adult emergency medicine training now in the training program around 300. For the Pediatric Emergency Fellowship Program, as I mentioned, the proposal was submitted by 2003. In 2004, the Saudi Commission approved the fellowship program, and it was under the Saudi Board of Emergency Medicine. In 2005, we started the program in National Guard, King Abdulaziz Medical City, and King Faisal. And at that time, we have three only like fellows. Okay, and by 2007, it was the first graduation and first examination were conducted. As you know, the Saudi Board for Pediatric Emergency Medicine, they are allowed to join the Pediatric Emergency Fellowship through a pediatrics training program or emergency training program. This is one picture was provided to me by Dr. Al-Akkam, Dr. Akkam, who is one of the leader in Saudi Commission for Pediatric Emergency Medicine. As you can see, he's here in the center next to Dr. Tariq Tabeti and Dr. also Amal Yusuf there. And here you can see there is a lot of fellows taken some activities in the University of King Saud. So what is the data so far in the fellowship program? Nowadays, we have around 20 centers all over the kingdom, and F1 fellowship, F1 fellows, 107, F2 67, with graduated around 300 graduates, more than 300 actually. I think it's 312, and currently 174, which is a very good number. And by this activity, I'm sure that we can reach to our meet our need soon, inshallah. Also, it is very, I think I'm honored, I'm happy with my colleagues to establish and release the Society of Pediatric Emergency Medicine. And it was a major achievement. It was a dream for me and my colleagues, Dr. Hamad Al-Madi, Dr. Salih Al-Shihri, Dr. Abdullah Al-Malki, Dr. Alawi Ba'aboud, Dr. Wafa Talul, Dr. Al-Qarni, Dr. and Dr. Muhammad Al-Na'mi, Dr. Al-Rawi, and Dr. Fahad, Dr. Abdullah Tamimi. So it was a great achievement. We meet for over the last 2 years, and we've been working hard to release this society and to help all the people practicing pediatrics and pediatric emergency with the training, with the data, with the knowledge, and also for society, for parents. It is not only for the physician, okay? And now we are working in the, as you can see in the website, and soon it will be released. It will be one of the state-of-the-art society. It has, you can ask questions, you can communicate with the leader in the pediatric emergency system in Saudi Arabia. Uh, And after this, I think the last slide I should put it, which I feel it's very important for us and for the society and for the Ministry of Health, that we should concentrate more on improving the primary health care quality of care, so to reduce the number of people going to the emergency department, because I'm sure if they have very good, they will have uh, they will go to the primary care center instead of going to the emergency, because now our emergency department is overcrowded. We need also educating the patient through the media, the need and the real need for the emergency department. You don't have to go to emergency for simple cough or for simple complaint. Also, we have to improve the hospital and primary care center efficiency and patient flow, especially in the emergency department. Uh, and a coordinated, regionalized, accountable system should be with increased resources. And we should invest more and more in training centers and courses like this courses. Thank you very much. If you have any question, you can send it please to question and answer area. And I hope also this is my Twitter. You can send me anything, anytime I can answer you. Thank you very much.
Thank you, Dr. Muhammad. It is really is excellent presentation. He go through pediatric emergency and how it's established and started. By the way, he's one of the founder of that pediatric emergency in Saudi Arabia, Dr. Muhammad Al-Fayfi. Thank you. Also, thank you for to have me in that big and important conference for pediatric emergency. It is my pleasure to introduce Aaron Jensen. He's associate professor of surgery. He is associate director of the pediatric surgery fellowship and in University of California, San Francisco. He's associate trauma medical director. Uh, he's UCSF Benioff Children's Hospital, Oakland, in California. Dr. Iron, he's a pediatric and trauma surgeon who's focused on providing emergency care for children. He has training in trauma and surgical critical cares. He will speak about sorting of out pediatric multi-system trauma and how to be initial stabilization of life-threatening injury. Welcome, Dr. Aaron. The mic with you.
have massive transfusions in children, even if you aren't planning on we should all understand how to identify triggers for patient evidence. And finally, yeah, and then we have it. Do you remember all this? Probably not. So I'll provide. This is the EMSC Innovation Improvement Center's Pediatric Education and Advocacy Kit. It's available online. You can see all of the various trauma toolkits, but also other pediatric emergency medicine toolkits, and some of my publications also talk about. I'll focus on the trauma resources today. We're going to talk about the importance of recognizing patients that exceed their capability, protecting the brain from additional injury. Don't wait for hypotension. Kids compensate and they compensate and they compensate. If you wait for hypotension, it's probably too late. Balanced ratio transfusion is important as it is in adults and kids. And one tidbit, and I think this is often misunderstood, the equivalent of giving an adult 1 unit of red blood cells, which would be expected to improve the hemoglobin by 1 gram per deciliter. It's like giving a child 5 cc's per kilo of red blood cells. So understanding the expected response to transfusion in kids is important to identify. If you don't have a pediatric massive transfusion protocol, you're probably going to have an imbalanced transfusion. You don't have a lot of time to make decisions, so don't rely on your brain. Have just-in-time resources refer to mistakes. We won't be talking about any equations, calculating vitals, sizes. I really emphasize using objective reference criteria. So resuscitation priorities for kids with pediatric trauma are the same. Airway reentry, condition, and disability, and reminder that C is not resuscitation. Self-bleed is part of C. If you just get blood and don't stop bleeding, that's all. At times, there's brain. The brain is under pressure and needs to be decompressed. You need to get to the count. ATLS is not just the same. It's all these things. There are some differences in recognizing physiologic change. There are some differences in medications and transfusions of tubes. So for the most part, ATLS works kids. So let's talk about a 7-year-old boy from Oxford School. I think it's why schools. New staff is allowed chance to write inside themselves. The mom thinks about the bottom directly to your lunch department by private. You might not be a pediatric trauma center, and sign out for an onset trauma center should not represent. A triage patient is male, school, he's diaphoretic. Mom still throws a lot of blood on the ground. The heart rate's 150, his blood pressure is 153. For teens, he was very afraid of this. But I was significantly. I think we were 6. This patient was detected. Mom told us one significant. In the triple A, used to be second party. GCS is 14 without any trauma, so starting to see that that's story mechanism for shock. See diminished, really have to worry about the future. And I need to place it is there's solid bullets. There's no active external agency at this point. And what should we do next? So again, let's do ACLS. CLS works for kids, just like it works for adults. But more importantly, ask yourself, is this child staying or senses? If not, start thinking about whether or not if this kid's health now and if it's for he needs further stabilization so that he survives the Alzheimer's brain. So see these questions are, is this child staying or not? This is the first resource for all today. It will take 6 feet and But this is the initial stage of it's shifts, activities, less than circulation, and exposure. You will see that it references some additional substitutions of health. There's also some tips that I'll recognize critically ill children. How do you recognize shock? How do you recognize rescue? And how do you recognize certain? There are considerations you need to have, like how you get those kids right. Use a link face tape. Talk to the pediatric drugs perhaps see a phone or something help you resuscitation and decision about what transfer. If you can't manage the injuries, you should not guarantee work. You should transfer out to the centers and everybody. Finally, think about what you can offer surgical capabilities. This patient has a quick energy their chest. Perhaps you can something you may have some pediatrics the patient's results out. So you might need arrangements for transfer out to these patients administration. Consulted about other things that might transfer considerations, such as blood bank hospitals. So we go back to our case. The airway is intact. Patient's on a non-recover. He has diminished breath sound. As she says, still 14, but now his blood pressure dropped. I'll point out that guy's solid blood pressure is very high. Sadie's child is very close to being IHS. His heart rate is 107. His respirations are 42. His point of care hemoglobin is 31, and there's no active. His abdominal mass is positive. His chest X-ray is clear. He's intubated. He has a left chest and chest X-ray. The yellow arrow marks for status. He's in a good position and good position without this. Besides, who's at this 7 years. You know, if you're doing math, you're looking at a computer that works. So I would argue that really you should have just in time resources in order to identify appropriate expenses and teach this. You can see here how we're coded chart is based on the length-based weight tape. Also, you can have a vital sign recognition against color coded. You want to be able to recognize average vital signs. You can have a pre-specified medication dose available in a commercial being kits. So all this is pre-drawn up, or you can have with individual doses and volumes. You should always weigh children in kilograms and make sure weight-based calculation of resuscitation fluids, blood, medications, blood sugars. So if you have a resource, maybe you have a PDF just like this. You have a book on the top, page for each of the colors. You have a link-based tape. You have a way to use in real time in order to tell you what size AT to use, what medication to use, and what medication. All of this is written down. You should not be here's an institute charts. This uses a score mechanism for certain calculation. But remember, the age over 4 plus 4 is for an uncuffed tooth. In trauma, we always use cuffed tooths in children, so downside by a half. So you can see here, each tooth size is on the color-coded link-based tape, as are many of the code dose medications, the milligrams, CCs, you can standardize medication patients. So have resources available to help these calculations and recommendations. So back to my kids. Do you know how to transfuse them? You have to recognize the position. Besides the temperature sensor. Again, remember, 5 cc's per kilo in a kid, and give you the same response as giving a 70 kilo pill. It should be treated by 1 gram. So these 4 units, if you were to give me 4 units of blood, that's the same as giving kids 2 children 20 cc's per kilo. So a lot of people say, oh, we give them 20 cc per kilo. Well, at your transfusion level, so you can recognize this is the hemorrhagic shock recognition toolkit. Again, it will free computers. There's a QR code right there. I'll go through this one test. So first is this science that can recognize the image. Don't wait for attention. Kids compensating. time when we're traveling or out playing or at the park, we're quite far from a pediatric trauma center. And if they were to get injured, and they do have many high-risk behaviors that they like to take on, particularly at the park, if they get injured, they're going to be taken to a non-pediatric or adult trauma center. And I'd like to ask everybody, are you ready to resuscitate these two kids when they inevitably show up in your trauma bay? With their traumatic brain injury or their severe hemorrhagic shock, will you know how to transfuse them? Will you know how to treat them with neuroprotective measures in order to have optimal outcomes? Kids are just little adults, but they are a little bit different, particularly when it relates to imaging of children, which we will talk about in a separate lecture. My objectives for this talk are to have the audience recognize the importance of recognizing injuries that exceed the capabilities of the center that you're working at and initiate the transfer process early. Recognize hemorrhage in kids, very important. Describe massive transfusion in children, even if you aren't planning on having a child show up to your center that will need massive transfusion. We should all understand how to identify triggers for activation of an MTP in kids. And finally, identification of severe TBI and knowing how to implement appropriate neuroprotective measures. Can you remember all this? Probably not. So I'll provide some resources, particularly if you don't take care of kids every day. I'll provide some free resources and just-in-time algorithms that you can use at the time of resuscitation if necessary. This is the EMSC Innovation and Improvement Center's Pediatric Education and Advocacy Kit. It's available online, and you can see all of the various trauma toolkits, but also other pediatric emergency medicine toolkits that some of my co-presenters also will be talking about. I'll focus on the trauma resources here today. We're going to talk about the importance of recognizing patients that exceed your capability, protecting the brain from additional injury. Don't wait for hypotension. Kids compensate, and they compensate, and they compensate. If you wait for hypotension, it's probably going to be too late. Balanced ratio transfusion is as important as it is in adults and kids. And one tidbit, and I think this is often misunderstood, the equivalent of giving an adult 1 unit of red blood cells, which would be expected to improve the hemoglobin by 1 gram per deciliter, is like giving a child 5 cc's per kilo of red blood cells. So understanding the expected response to transfusion in kids is important to identify bleeding. If you don't have a pediatric massive transfusion protocol, you're probably going to have an unbalanced transfusion. You don't have a lot of time to make decisions, so don't rely on your brain. Have just-in-time resources that you can refer to so you don't make mistakes. We won't be talking about any equations to calculate vitals, tube sizes. I'm really going to emphasize using objective reference materials that you can use in real time. So resuscitation priorities for kids in pediatric trauma are the same: airway, breathing, circulation, and disability. And a reminder that C is not for CT. Stop the bleed is part of C. If you just give blood and don't stop the bleeding, that's a problem. And time is brain, right? If the brain is under pressure and it needs to be decompressed, you need to get them to the operating room. Pediatric ATLS is just the same as adult ATLS. There are some differences in recognizing physiologic change. There are some differences in dosing of medications and transfusions and tubes. But for the most part, ATLS works in kids. So let's talk about a 7-year-old boy who was walking home from school. And while he was walking home from school, he was stabbed in the left chest right outside of his home. The mom picked him up and brought him directly to your emergency department by a private car. You might not be a pediatric trauma center, but the sign out front said trauma center, so mom brought this child to you. At triage, the patient is pale, he's cool, he's diaphoretic. Mom says there was a lot of blood on the ground at home, and the heart rate's 150, and his blood pressure is 133 over 113 with very thready pulses. And I would ask, is he likely to be bleeding significantly? And I think we would all say yes. This patient is profoundly tachycardic, cold, cool, and clammy, and mom told us there's a lot of blood on the ground. Probably significant hemorrhage. In the trauma bay, he continues to be tachycardic. His GCS is 14 without head trauma, so we're starting to see that compensatory mechanism for shock. If you see diminished GCS and bleeding, you really have to worry about malperfusion. An IV is placed and he gets a 20 cc per kilo crystalloid bolus. There's no active external bleeding seen at this point. And what should we do next? Well, again, I would argue, let's do ATLS. ATLS works for kids just like it works for adults. But more importantly, ask yourself, is this child staying at your center? And if not, start thinking about whether or not
you can get this kid out now via transport, or if he needs further stabilization so that he survives the helicopter or ambulance transport. So asking these questions early, is this child staying or not, is highly important. This is the first resource that I'll show today. There's a QR code at the bottom left of your screen that will take you to this. It can be downloaded for free from the internet. And this is the initial stabilization and triage algorithm that we've made. It starts with tips on pediatric ATLS related to airway, breathing, circulation, disability, and exposure. You will see that it references some additional resuscitation protocols that I will talk about next. There's also some tips about recognizing critically ill children. How do you recognize shock? How do you recognize respiratory failure? And how do you recognize traumatic brain injury? There are considerations to think about, like how are you going to dose these kids right? Use a length-based tape. Talk to the pediatric trauma center early. Perhaps you can get a phone consult and somebody can help you with your resuscitation and decision about whether or not you should transfer out. If you can't manage the injuries, you should not be imaging locally. You should transfer out and obtain CTs at the center that can provide definitive care. Finally, think about what you can offer at your center. Maybe you have surgical capabilities. If this patient has significant hemorrhage and they're bleeding to death and they need a thoracotomy or a laparotomy, perhaps you can provide that level of care, but you might not have a pediatric ICU to transfer the patient to postoperatively. So you might need to make arrangements for a transfer out after you take this patient to the operating room if you're not going to transfer them out now. Think about consultants, think about other things that might require transfer and other considerations, such as blood bank resources and other pediatric protocols. So we go back to our case. The airway's intact. The patient's on a non-rebreather. He has diminished breath sounds on the left, which is the side he's stabbed on. His GCS is still 14, but now his blood pressure is dropping to 101/90. I'll point out that diastolic blood pressure is very high. This is a compensating child who's very close to being hypotensive. His heart rate is 107. His respirations are 42. His point of care hematocrit is 31. And again, there's no active external bleeding. His abdominal fast is positive. The pericardial view is negative, and his chest x-ray is clear. He's intubated. He has a left chest tube placed, and a chest x-ray is obtained. The yellow arrow marks where he was stabbed. You can see the ET tube in good position and a chest tube in good position without any significant hemothorax. What size ET tube did you use in this 7 or here it says 9-year-old child? If you're doing math or looking at your little finger, that works. But I would argue that really you should have just-in-time resources in order to identify appropriate tube sizes and medication dosing. You can see here a color-coded chart that's based on the length-based weight tape. Also, you can have vital sign reference sheets, again, color-coded. You want to be able to recognize abnormal vital signs, and you can have pre-specified medication doses. This is available in a commercially made kit, so all this is pre-drawn up, or you can have a book with individual doses and volumes. You should always weigh children in kilograms. It makes your weight-based calculation of resuscitation fluids, blood, and medications much, much easier. So have a resource. Maybe you have a pediatric cart just like this, and you have a book on the top with the page for each of the colors. You have a length-based tape. You have a way to use in real time in order to tell you what size ET tube to use, what medication doses to use, and what size chest tubes to use. All of this is written down. You should not be relying upon your brain to remember this stuff. Here's an ET tube chart. This uses the age over 4+4 calculation. But remember, the age over 4+4 is for an uncuffed tube. In trauma, we always use cuffed tubes in children, so downsize by a half to accommodate that cuff. You can see here, ET tube size is on the color-coded length-based tape, as are many of the code dose medications in terms of milligrams and cc's using standardized medication doses. So have resources available to help you do these calculations and recognize tube sizes in real time. So back to my kids. Do you know how to transfuse them? Do you know how to recognize hemorrhage? What's going to happen if they come in with significant hemorrhage in your center? Again, remember, 5 cc's per kilo in a kid will give you the same response as giving a 70-kilo adult 1 unit. It should increase your hemoglobin by 1 gram per deciliter. So these 4 units, if you were to give me 4 units of blood, that's the same as giving either of these 2 children 20 cc's per kilo of red cells, right? So a lot of people say, oh, we gave them a 20 cc per kilo bolus of blood and their hemoglobin went up by 1. Well, it should have gone up by 4, right? So understand the expected response based on your transfusion volume so that you can recognize whether or not they're still bleeding. This is the hemorrhagic shock recognition toolkit, again, available for free on the internet. There's the QR code right there. I'll go through this one page at a time. So first, this is signs of recognizing hemorrhage. Don't wait for hypotension. Kids compensate, and they compensate dramatically. Tachycardia, altered mental status, impaired capillary refill are all signs of shock. If you get a blood gas early, you might be able to recognize that acidosis and need for transfusion sooner. If you think there's hemorrhage, start with 10 cc's per kilo of red blood cells. This is the same as giving an adult 2 units. Use the ABCD score or the critical activation threshold to recognize massive hemorrhage. I'm going to go through these in a little bit more detail in subsequent slides. But the ABCD score gives you a point for penetrating injury, positive fast, tachycardia, hypotension, or acidosis on the blood gas. The critical activation threshold is if you've given more than 20 cc's per kilo of blood product in any 1 hour, that patient's going to need a massive transfusion, and you should activate your massive transfusion protocol. So back to our case, the lab's in the trauma bay. We did get the blood gas, and he has a profound metabolic acidosis, 6.9 on 46, with a base deficit of 20 and a lactate greater than 15. His hematocrit is now down to 27, and his INR is 1.9, and his fibrinogen is down to 142. This patient has significant hemorrhagic shock with coagulopathy of trauma. He got 3 units of red cells, 1 FFP, and 1 platelet, all before these labs even came back. So the labs were drawn, but we didn't have the results. We started giving blood in the trauma bay per the massive transfusion protocol. He went to the operating room. He had an XLAP. He had a through and through splenic wound with no significant bleeding by the time he got to the operating room. His spleen was packed. He had a temporary abdominal closure, but what he was found to have was a lacerated intercostal vessel that wasn't bleeding in the trauma bay because it was so spasmed, because this kid compensated dramatically. So we did a thoracotomy, ligated his intercostal vessel, did a little pulmonary wedge resection, repaired an injury in the diaphragm, and he did great. But he required a significant amount of transfusion, 12 units of red cells, 8 units of FFP, 4 platelets, and a cryo, which is 150 cc's of total product. He was profoundly hemorrhaging when he came in. So recognition of shock is important. His blood pressure, however, was always normal. At triage, 130/90, and the ED, 101/90. After 1 liter, 133/113. I'll point out all of those diastolic blood pressures are way too high for a kid. This is a patient who is compensating. That's the catecholamine response. He's maintaining his blood pressure despite significant hemorrhage. So how do we recognize pediatric shock? Kids compensate tremendously. These are my kids. They look real happy, right? Well, sometimes they're not so happy and they scream. And every kid that comes to the trauma bay is screaming and screaming and screaming, which makes them quite tachycardic. Kids also are scared, which leads to tachycardia. They have pain. They bleed. All of these lead to tachycardia, and they often have an associated TBI, which actually that Cushing's response might blunt your tachycardic response and blunt recognition of hemorrhage. This is the ATLS shock and blood loss diagram that's been in every version of ATLS that I've seen for many, many years, which really shows the heart rate of the child going up, 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 and up. Systemic vascular resistance stays the same. Blood pressure stays the same. Your heart rate, your cardiac output eventually goes down with blood loss, and then eventually you fall off the cliff, which is when you get hypotensive, which is very close to cardiac arrest. So don't wait for hypotension, particularly in the patient who has profound tachycardia and profound peripheral vasoconstriction and cold hands. This is a picture of a cyanotic child. I've never been able to find a cartoon of a patient in hemorrhagic shock, but this is sort of showing the feet and the hands, and if you have profound hemorrhage, the whole legs will get splotchy, and what you have up here is this modeling of the extremities. So if you see delayed capillary refill and modeling of the extremities, you really have to be suspicious that this patient is maximally compensating for blood loss and that you have class 4 shock. You start to see mental status changes, and you start to see worsening tachycardia. These are all signs of impaired perfusion in a child. So if we can't rely on vital signs, then how do we know when we're going to activate MTP? I imagine all the blood bankers like stressing out because I'm saying, well, just activate for all these abnormal vital signs because they're not reliable. Well, not quite. When we think about massive transfusion, we got to think about those vital signs, but also the mechanism. Do they have mechanism for hemorrhage? What are the imaging findings, and what do the labs look like? And we really want to balance out delays in getting the products that are needed with unnecessarily utilizing or thawing blood products that are then going to get wasted. So this gets us back to that ABCD criteria or the critical activation threshold. Both are two different tools that can be used. This is a recognizing pediatric hemorrhage poster that I have on the wall in my trauma bay at my pediatric center, which really points out all of these risk factors for a massive hemorrhage: penetrating injuries, positive fast, tachycardia and hypotension, lactate, or base deficit. If you have, and you get 1 point for each of these, if you have 2 or 3 points, your risk of getting a massive transfusion is very high. So this is the ABCD score. It comes out of Colorado Children's in Aurora, Colorado, where they went back and they looked at 210 kids who had a full activation, 66 of which had a massive transfusion protocol. And they looked at sensitivity and specificity of all of these ABCD criteria factors. And this is what they found. This is the ABCD score: sensitivity, specificity, and accuracy. And I'll focus mostly on the specificity. Okay, so if you have a 2-point ABCD score, you have a 52% chance of needing an MTP. If you've got 3, you have a 78% chance of needing an MTP. And our patient had, I believe, 3, if not 4 criteria. And he was activated based on his ABCD score. So use this in real time. It will help you identify hemorrhagic shock and massive transfusion. Well, why massive transfusion protocols? This is a trauma audience. I won't go through all this, but the coagulopathy of trauma from consumption, dilution, acidosis, and hypothermia is real. It leads to the lethal triad of death, which coagulopathy leads to worsening acidosis, which leads to worsening hypothermia, which leads to coagulopathy, and it swirls and swirls and swirls until it gets worse, unless you break this vicious cycle. The data in adults is very strong. There's also data in kids. It's all retrospective. It's not as high quality as the adults, but this was a retrospective review of children who were massively transfused. And they looked at outcomes of these kids, and they found that mortality was directly proportional to ratios. Kids who had a 1-to-1 ratio did much better than kids who had 3-to-1. Now, there is some survival bias here. You have to live long enough to get balanced ratios. But this echoes the adult data that suggests that 1-to-1 balanced transfusions in massively hemorrhaging kids improve mortality. This is a single center review looking at their massively transfused patients. And they talked about using a protocol that they implemented. And they found after the protocol that death rates didn't change, but death from hemorrhage decreased. It's a very small sample, so it was not statistically significant, but this is more data that suggests that appropriate 1-to-1 ratios in children will help outcomes. Finally, this is Caden. I had the opportunity to present Caden's case as a trauma survivor. I took care of Caden. He was injured in a very rural part of California when he was run over by a tractor. This is not his stomach. This is his pulverized spleen with lots of arterial extravasation. And Caden was treated at a rural trauma center and initially was found to be in hemorrhagic shock. He was given 4 adult units of red cells, 1 unit of FFP and 1 unit of platelets. So transfused by an adult massive transfusion protocol, by which after 4 units, they start going 1-to-1-to-1. This is initial thromboelastogram, which is very narrow, very shallow slope. You can see his degree of acidosis, his INR, and all those red cells led to a hematocrit of 75. This is what happens when you use adult transfusion protocols with kids. Now, Caden got through this. He was operated on at this adult level 4 trauma center that saved his life and transferred to my center for critical care and resuscitation. And he had a completely normal neurologic outcome. But his case really highlights the importance of hospitals having pediatric specific massive transfusion protocols so that we have balanced ratio resuscitation. So this is the massive transfusion protocol that's part of the toolkit that I shared earlier. It gets weight-based, so 20 kilos, 21 to 50, or greater than 50 kilos, which is the same as adults. And this really argues for higher ratios in the earlier packs for the little kids. It talks about how to dose things. It talks about adjuncts and talks about not forgetting about calcium administration as you're giving these patients red blood cells. So these are the key points we talked about earlier. Don't wait for hypotension. Balanced ratios matter. 5 cc's per kilo of red cells in a kid is the same as giving an adult 1 unit. That's important. That's why I've said it 3 times. Without a pediatric MTP, you'll have unbalanced transfusions. Have a system to recognize hemorrhage and get the right tube sizes and the right medication doses in. And don't rely on your memory. Use resources. Okay, let's talk about another case in the final 10 minutes. A 7-year-old boy was riding the wave rave and he flew off when his seatbelt malfunctioned. He had obvious head trauma. and normal blood pressure initially, quite tachycardic with a GCS of 3, and is being transported to the closest trauma center, which happens to be an adult trauma center, and his blood pressure is now 67 systolic, and EMS gives 10 mics of epinephrine. Is this hemorrhagic shock? Is this all TBI? Well, I would say it doesn't really matter. This patient just needs resuscitation. They need their shock treated, and we'll sort out why they're in shock later. I'll ask, is this 7-year-old staying at your center? Do you have an operating room that can do a craniotomy or laparotomy on this patient? And if so, do you have an ICU post-op? If not, think about when you're going to need to get this patient out, and don't delay if you do need to transfer out. So what do we do next? Well, kids get brain injuries. And what we do is we prevent secondary injury. We want to prevent hypoxemia. We want to prevent hypotension. We want to maintain normal glycemia. We want to prevent seizures. And we want to make sure that the intracranial hypertension doesn't get worse. I would postulate that any trauma center should be able to get an endotracheal tube and blood into this patient, regardless if they're a pediatric trauma center or not. I'll also point out that kids are exquisitely sensitive to mannitol, particularly if they're bleeding. And mannitol in a bleeding patient often leads to refractory hypotension from that osmotic diuresis. And the Brain Trauma Foundation does not recommend using mannitol. We recommend using 3% saline in severe traumatic brain injury with signs of elevated ICP. This is the Brain Trauma Foundation's guidelines. If you'd like to read them, they were published in 2019, probably due for an update soon, but this is the most recent version. We've converted those Brain Trauma Foundation guidelines, as well as some other evidence-based guidelines, to a severe TBI and moderate TBI resuscitation quick guide. You'll see that on the front of this, there's a pediatric GCS score. I don't want you to remember that, but I want you to have a resource in real time that you can use to calculate a pediatric specific score. Again, this is available free online. In this particular patient, we're going to do high-quality ATLS. We're going to follow those Brain Trauma Foundation guidelines. We're going to probably call the helicopter early if we can't take care of this. We're going to consider getting a CT scan if there's going to be a delay. And we're going to consider going to the operating room if we have operative capabilities at our center. But we have to think about what we can do at our center and decide, are we going to keep this kid or are we going to transfer them out? Kids have big heads. That head swabbles all over the place and generally takes a lot of trauma in a car crash or a fall or getting thrown off of a ride apparatus at the fair. Kids get TBIs. You have to assume that they have TBIs, particularly with diminished GCS. The ribs are flat. They don't protect the intra-abdominal injuries. This top x-ray shows horizontal ribs in a toddler and more oblique ribs that come down further in an adult. These ribs also are not ossified. They're very floppy, they're very soft, and they bend, and you can get upper abdominal injuries quite easily. Kids get cold. If you don't keep them warm, they will get cold. Give them warm fluids, use active warming devices, and keep warm blankets on them. It's also important to recognize shock, as we previously talked about, because their circulating blood volume is quite small. Children should cry when you poke them with a needle. It's often misinterpreted that the child is sleeping, which is why their GCS is diminished. This is a pediatric GCS on the screen. It's on the first page of that quick guide that I gave you before. But if you can't do that, just use the AVPU scale. Alert, verbal, painful, or unresponsive. And these are responses to painful stimulus. You need to have a reliable way to quantify the mental status of a child so that you can recognize severe or moderate traumatic brain injury. So this patient came in and the full trauma team was activated. Upon arrival, the blood pressure was 120/80, but the patient just had epinephrine, really tachycardic, has cold, pale, and weak pulses. Hematocrit is 32. Patient got a chest x-ray and a FAST, which was positive in bilateral upper quadrants, and has a profound metabolic acidosis. So should we activate MTP? Well, the ABCD score of this patient is 3, which means there's a 78% chance that this patient is going to need a massive transfusion. So I would argue yes. The Pediatric Trauma Center was called as soon as this patient rolled into the emergency department. Again, this was an adult trauma center. They called the Pediatric Trauma Center and said, please send the aircraft. And they're starting to balance the benefits of resuscitation versus getting out to definitive care. This is a center that had the possibility of operating on a kid, but they did not have a pediatric ICU. Because there was going to be a 30-minute delay and the patient had responded to initial resuscitation, there was shared decision-making between the pediatric and adult center to get a whole body CT scan in order to define the injuries for this patient so that they didn't waste time when they got to the pediatric center. The patient had a grade 3 splenic laceration, also had a shear injury and a traumatic subarachnoid hemorrhage with some contusions on the head. Initial INR was 2.2, the LY30 was 4.5. And this patient had MTP activated, got 2 reds, and I believe got 2 cryos in the ED, 2 FFPs in the ED, also got TXA. The coagulopathy was treated, and the patient was eventually transferred out. Now, this is an adult center that has facility recognition for pediatric readiness. This is a center that, even though they don't routinely take care of kids, they had all of the protocols in place, including that pediatric resuscitation cart with a length-based tape and dosing protocols and transfusion protocols, everything for kids, even though they don't have an ICU and they don't plan to keep kids locally. This particular center, with all of these pediatric resuscitation protocols in place, activated the transport asset early. This is a partnership between an adult and a pediatric center. An adult center that's pediatric prepared, that has the children's hospital number on the wall, and they're planning to transport kids out rapidly that they cannot provide definitive care for. This patient had a great outcome because of high quality initial resuscitative care that was guided by pediatric readiness principles, length-based weight estimation, weighing the patient in kilos, using kilograms, using all of these predetermined doses, and a pediatric massive transfusion protocol. So in summary, for TBI, recognizing patients that exceed capability of your center and activating the transport systems early leads to optimal outcomes. Protect the brain from initial injury, administer 3%, prevent hypoxemia, prevent hypotension, prevent seizures. These kids should all get Keppra. Prevent hypoglycemia. Don't let the kids get hypotensive. Resuscitate them. Don't image it if you can't fix it, unless there's going to be a transport delay and the Pediatric Trauma Center wants to work with you to obtain appropriate imaging. Use imaging for dispo, otherwise in stable patients. So in summary, recognition of shock is important. Don't rely just on blood pressure alone. Hypotension is a late finding. Acidosis is a much more sensitive indicator of shock in children. Get a blood gas. Consider MTP activation if your ABCD score is 2 or greater. Each 5 cc's per kilo of red cells that you give is like giving an adult 1 unit of blood. That will lead to a 1 gram per deciliter increase in hematocrit. A 1-to-1 ratio seems to be ideal, particularly in massively transfused kids. And everybody, even if you're not expecting to take care of kids, needs to have a pediatric-specific weight-based massive transfusion protocol. There's one available on the website if you'd like to use it. It's downloadable for free. For TBI, neuroprotection is critical. Maintain normotension, normoxia, normocarbia, normothermia. Give some Keppra, prevent seizures. 3% saline if you have signs of elevated ICP. Don't give mannitol because it can make patients hypotensive. And don't delay access to neurosurgery just to get a CT scan. If you have a diminished GCS, the patient should be transferred out and imaged at the center that can provide definitive care. You can use delays in transport to get imaging if there's time, but don't delay transport out. Finally, have a system to recognize abnormal vital signs, guide your equipment sizes, and provide safe medication dosing in children. I'd like to thank you for the opportunity to share here today, and I believe there's going to be a Q&A session in a little bit. Thank you very much.
Thank you, Dr. Aaron. This is an excellent presentation and how to deal with the multi-system trauma patient in pediatric. Next, we'll move the next talk with Dr. To Cheng. To Cheng is a board-certified pediatric emergency medicine physician who held faculty of position at George Washington University, Children's National Medical Center, Washington, D.C., and now in the University of the Southern California, Children's Hospital in Los Angeles. He is the Vice Chair of the Education Department of Pediatric, Associate Professor of the Pediatric and Medical Education and Educational Scholar, and Keck School of the Medicine and USC, and the Medical Researcher Director of the Children's Hospital of LA, Mediterranean Simulation Center, and Faculty Division of the Emergency Medicine and Transport. He's the principal of the investigator and Stellar Node and the Big Calm Children's Hospital in Los Angeles. He will talk about very important digital technology in the emergency department. The mic with you. Welcome, Todd.
Hello, good morning, good afternoon. Actually, good morning. My name is Todd Chang. I'm a pediatric emergency medicine physician here at Children's Hospital Los Angeles in the state of California in the United States. I work in the University of Southern California network, and I'm here to talk to you about digital technologies in the emergency department. Thank you so much for inviting me to speak today, and this will be an interesting talk for you guys. The objectives for this talk include describing the current and past landscape just as a broad overview in the short time that I have with you. In the past landscape of digital technologies in pediatric emergency medicine, and some of the things that you may have already run into or you're likely to run into in the digital side. And then I have chosen several articles to just go over of what's currently written about in the literature in the 2023, 2024, and 2025, particularly in these three digital technology areas, which include telemedicine, electronic health record prediction models using natural language processing, and then, of course, everyone's favorite topic of the day, artificial intelligence. So let's start with this first one. And thinking about what digital technology means, we also think about what healthcare means for since the beginning of time. Healthcare was the ability for people to take care of each other, to either during sickness or in injury, or just preventing bad things from happening and maintaining good health, whatever that means in whichever society. And when we do that with the aid of digital technologies, again, what that means is essentially it's not analog. Then we get to a point where we now have quite a few elements of our lives that are dependent on digital technologies, where we no longer care for each other just through simple touch, simple speech, and things like that. So anytime that our human interaction is augmented by digital technologies, we call it an advance, and we get to talk about what's happening now. Digital, in this case, means that it's going to be recording or storing information in the form of binary code. So anything that requires binary code inside, even if you and I don't speak binary, it becomes digital. So this term digital was used primarily for data, audio recording, for example, videos, movies, music, speech. All of these data points became from analog, from tapes to digital storage, which is in the form of binary code. But nowadays, it's not just that. It pertains to something that's electronic. It usually pertains to computers. And then eventually it pertains to computers or the internet now that it's available. And then finally, right now, it pertains to either computers or internet or artificial intelligence. As the new technologies stack on, the term digital just continues to widen. So that when you and I talk about digital technologies, it means any of these things at this point. So thinking about digital technologies in healthcare and how we provide healthcare in pediatric emergency medicine, there's really three different ways that digital technologies really amplify our ability as physicians and providers to take care of our children as well as our families. The first is the actual communication. So we've already found out within COVID and in other pandemics in other areas where we can't physically be in the same place as another person, that the normal ways of communicating, whether it's by voice or written communication, or even just human empathy, where you don't have to say anything, but having somebody there is a form of communication. Digital technologies allow us to expand the ways in which we can do communication with our patients, families, and with each other. And so we'll explore a few of those, some of which you've already used right now, so one of which I'm using right now in terms of Zoom recordings. Second, in addition to communication, digital technologies allow us to diagnose. So this is gathering data, gathering information, sensing information that perhaps the human cannot find or human cannot detect, and really allowing the synthesis of different diagnoses. What is the problem? What is the problem that we have to solve, the diagnosis that we have to make? These are the questions that we can answer through digital technologies. One of the analog technologies that you and I know very well is the stethoscope. It's not digital, but there are now digital forms of it that allow us to use the analog form a little bit better. And then there's even more add-ons as we pile on new digital technologies, and we'll see how that works soon. And then on the flip side, the third side besides communication, diagnosis, is treatment. So digital technologies either allow you to treat differently, or itself is an innovative treatment by itself. Perhaps the digital technology is the treatment rather than the medium of how you deliver treatment. So telemedicine is one way to do communication, but then you can turn it into treatment by using telemental health or telepsychiatry. So all the digital technologies fall into one or more of these categories of diagnosis, treatment, or communication, and usually more than one as the digital technology gets more and more complicated or multi-layered. And I'll show you some of the examples of what I mean. Here's a very, very simple digital technology that we use all the time, and that's point of care ultrasound. Thanks to the portability of ultrasound and the ultrasound technologies, we're able to make diagnostic information and diagnoses with just the ultrasound technologies. It doesn't typically help with treatment necessarily. It's not a direct giver of treatment, and it's not particularly a communication enhancing device besides the fact that it gives you more images that you can show people. But its primary function is to enhance the ability to make diagnoses or increase the accuracy of diagnostic regimens. So that's an obvious one. Here's a he's not really a digital technology, but an electronic technology here. The intraosseous gun. This allows us to place an intraosseous needle more easily with a lot less effort and a lot less strength, and perhaps a lot less complications as well. So this is purely a treatment innovation. It doesn't help with diagnosing. It doesn't really help with communicating, I hope, but it does help with making a treatment that's already known, an intraosseous line, much easier to implement. And then as we start layering, you'll see that these most newer digital technologies start encompassing more than one of these three elements or one of these three domains. In the communications realm, this is on the background a Cerner screenshot. So your electronic health record, your electronic medical records, is a digital technology that enables a certain type of communication that usually is supposed to be easier, sometimes a little bit more difficult than the traditional versions, but in all digital technology is supposed to improve or augment our ability to communicate, again, with each other, with families and patients, with other allied health providers. And then what we're going to do is improve upon this technology by adding things. Before it was called clinical decision support. Now you have people calling it for what it is, artificial intelligence, and allowing to create more and more diagnostic capabilities, which we'll talk about in a little bit, and it even enhances certain levels of treatment. So adding new digital technologies typically expands the number of domains that a particular earlier digital technology and earlier analog technology can handle. So, and that's where we are in 2025 at the time of this recording, is that most of the time digital technologies are going to start expanding beyond just one of these domains. Whereas in the early days of when digital technology started appearing in pediatric emergency medicine, it was pretty much one of these things only. Here's a couple more examples. This is a diabetes management, which some parts we do in the emergency departments, other parts elsewhere. And each of these three domains was essentially three different parts of diabetes management. The diagnosis or the diagnostics part was the frequent blood sugar checks and monitoring so that you knew what your blood sugar was. On the treatment side, that's completely separate. Those are the separate insulin injections for type 1 diabetes. And on the communication side, people had to manually write down your blood sugars on a notebook or a piece of paper, and then look for trends so that the physician can actually evaluate them a little bit later when you talk to them for the first time and face to face. And that was pretty much how diabetes was managed. There were definitely digital technologies here in the form of a glucometer on the diagnosis side, but the other two domains really did not have any substantial digital technologies until more recently, where newer digital technologies now start combining those three domains into a single a set of devices or family of devices. So currently, the standard of care in diabetes type 1 management is to have a continuous glucose sensor, typically on the abdomen or the back of the arm. And that provided the green section, the green domain, the diagnosis, which was how high are your blood sugars currently. And because it was continuous and sensing, it was much more convenient, and that's the whole digital technology side. It then allowed for an insulin pump to calculate the total amount of infusions and to increase or decrease the basal rates or boluses as needed. And this actually linked the diagnostic to the treatment side, the green to the purple side of the digital technologies. And then it enabled better communication with the child, the family, as well as the providers, the nurses and doctors who take care of the diabetes, even before you even get to an appointment. So what we're seeing is that digital technologies now are meant to really increase the total number of domains that it can actually handle within one set or family of technologies. So it's not just an intraosseous gun anymore. It's really the whole family of collection of digital technologies that add together within these three domains to make pediatric emergency care better. And so we're going to see a couple more examples of how these domains start interacting with several examples that I'm going to present to you today. So let's go dive right into the literature. The first and foremost is the most common one that you've probably seen already, which is telemedicine. And in pediatrics and pediatric emergency medicine, this can get a bit tricky. It's different than many other telemedicine services that we have here. So I'm going to highlight a few literature-heavy telemedicine examples and show you what the literature currently looks like. Here's one using the term for diabetes, type 1 diabetes. Again, most of the time we're not going to see any of this in the emergency department, with the exception of hyperglycemic events and diabetic ketoacidosis. What we do know from the literature is that the use of telemedicine for type 1 diabetes, enabling communications between patients and families, and then the physicians and providers of care, and linking them with telemedicine actually increases care and decreases hemoglobin A1C levels. And important for us in the emergency department, it reduces hypoglycemic episodes and DKA episodes. It improves behavioral therapy between children and parents, especially for children who are not as compliant or have difficulty complying and following in complex insulin regimens, and they have a harder relationship with their families, so that telemedicine actually intervenes between them. But it does also increase the disparity for care, especially for those families and patients with poor access to telemedicine services because of their living situation, housing situation, or their economic situation with lack of connected devices. So when the devices are available, then care is quite optimal with telemedicine for type 1 diabetes, but it has begun to already accentuate the gap and disparity in care that many of our children face. Here's a different example called teletriage. We actually had done a study way back in the day in 2014, more than 10 years ago, when the self-sufficient robots were starting to be invented. But in addition, there's newer teletriage as well. So teletriage is unique to emergency medicine and pediatric emergency medicine, where a physician is behind the camera and allows for a little bit augmented triage instead of just having one nurse. So with teletriage, several studies show that there's relatively high satisfaction rates from everyone involved, including patients, families, and physicians. There are ways of ordering tests and getting more analyses, as well as re-triaging in case that they need to be up-triaged or down-triaged. And then concordance with final triage and resource utilization is actually pretty high, even with teletriage using physicians, even more so than in-person triage using nurses. This does require, of course, a physician to be free and doing triage very quickly amongst a large number of patients for it to be worthwhile. So there is a cost-benefit problem that you have to explore with teletriage, but with physician-based teletriage, this actually does improve several metrics. Telemedicine is actually really good for visual diagnoses and in particular dermatology. So there's a few studies that have already been done on pediatric teledermatology. Many of them do not have particular outcome variables that are studied, but they do look at the feasibility, which includes both synchronous, in other words, in an in-person, not in person, in an online version where the it's essentially like a regular Zoom call that you can actually see and talk to each other, as well as ask the child to move their rash or whatever their skin lesion is in different ways. And then there's the asynchronous version where videos or photos are sent to the dermatologist and they can answer at a different time. Of course, in an emergency department, synchronous is more likely to happen, but in terms of dermatology, sometimes an asynchronous model may be really, really useful and very cost effective and pretty simple. The good news is that within teledermatology, compared to in-person evaluations, the concordance of the correct diagnoses ranges from 70 to 89%. Not perfect, but probably okay for the types of diseases that you're going to see for the most common pediatric skin disorders. So here's another way of using digital technologies to really increase the efficiency and output of a busy emergency department, especially for children who are not in a critical state. Moving to a completely different organ system is telemental health, especially when the number of mental health professionals is actually getting lower. For pediatrics, this may actually be a very good adjunct. What we do know about telemental health now, but written in 2025, is that about half of the pediatric emergency departments throughout the United States use some sort of telemental health within the emergency department. This may be phone only, but typically are video-based ever since 2020 and COVID. Almost all of these surveyed provided some sort of suicide screening, which is the most common reason to use telemental health, and then prevention resources within evaluation that's done online. There's quite a few barriers and challenges that are described on implementing telemental health. Number one is the ease of use and implementation of the ED setting, the emergency department setting, which is very different than a typical mental health or office setting. Medical health record integration is actually very difficult in using these telemental health services, especially if they're third party or provided by someone outside of your institution. So those are challenges that has to be solved. And then because they are often done in a private conversation in the room, it's difficult to regain that communication with the mental health provider and the emergency department providers as well to complete the cycle of care. So that level of operations needs to be really thought about and solved before implementing telemental health. But it is common, and even in pediatrics and adolescents, this is an extremely viable way of delivering mental health care in places where there's actually relatively few specialists. A couple more, telefollow-up. So this is the idea of having a patient follow up with somebody in the emergency department instead of their primary care provider for very specific diagnoses. So for example, a respiratory diagnosis like bronchiolitis or asthma that is likely to be okay on discharge, but probably needs to be followed up in 1 to 2 days. And this was a particular study in Canada in a tertiary pediatric center in which it was very routine to invite patients back to the emergency department several days later for follow-up. And that actually accounted for almost, in this study, 0.5% of all ED visits, which is not a small number when you think about the total number of emergency department visits. So in this study, they introduced the idea of virtual visits. The treating emergency department physician was allowed to select virtual or in person before they discharge the patient. And then most of them were respiratory diseases to make sure that their respiratory status did not get any worse. And only 5% of the virtual visits required actually calling them back into the emergency department. So this was an excellent choice of keeping a lot of the kids at home if they were recovering and nicely. So this is a great program to think about implementing locally for those patients who have difficulty following up their primary care providers or have certain diagnoses that primary care providers are not comfortable following up. And finally, teleconsultation. This is the idea of two physicians talking to each other with the ability of the consulting physicians to see as much as they can or hear as much as they can the patient and the family. This was a study done in Northern California where they found no difference in medication errors, which was the primary outcome, found with teleconsultation versus regular telephone consultation in which you could not see their faces. There's further study that needs to be done, but that's about the level of evidence that we have for telemedicine in pediatric emergency medicine, that it tends to be feasible, there are challenges, and there are specific outcomes that it can improve, and it's something to think about in implementing in your local institutions. Okay, let's dive into artificial intelligence. We're going to talk about two of the three artificial intelligence levels as it gets more complex. And so the first level is predictive. These are things that artificial intelligence algorithms, natural language processors, deep learners, or machine learners rather, that parse through large amounts of data that are not human possible and create predictive algorithms. There's the generative artificial intelligence, which then generates new ideas based on their previous experiences. This includes the ChatGPT systems. And then there's the sentience artificial intelligence level where they're really blurring the line between like really being self-aware. We're not going to talk about sentient artificial intelligence today. Number one, because I don't have the time, and number two, it's kind of scary. So let's just start with predictive. What are the ways that we can use artificial intelligence so far in predicting things about pediatric emergency department visits? First, I want to go over how predictive models work on an overall concept. There's the use of predictive models using structured data, which is something that we've all trained with, especially in statistics, where if the data are all structured in a particular way, for example, everyone records the temperature at triage, that's structured data. And that can be harvested and put into a predictive model with no AI involvement. But then if you have unstructured data where it's just free-form information, either by human speech, human text, just typing, images, videos, or sounds that are not particularly formatted or structured, those kinds of data can still be useful, but it requires artificial intelligence or at least machine learning, natural language processing, and those processors to actually develop a predictive model. So here's a prediction of emergency care algorithm that was developed using natural language processing. And this was done in Korea, where they had several 87,000 cases of notes on pediatric emergency visits, of whom some of them were deemed emergencies and others were non-emergent, basically went home, but with maybe a prescription, and that's it. And the question that these researchers asked was, how feasible was it to teach using a bilingual natural language processor in both Korean and English of using unstructured data to predict whether or not a child needed emergency care? So this is one of the things that they introduced in the article with deep learning, which is a little bit moving towards generative AI for predictive AI, where they fed a whole bunch of patient charts to the deep learning algorithms. And in part A, which is the top version here, this is a human that highlighted things that made them, the human physician, think that this child needed emergency care. A lumbar puncture, a blood test, some sort of stat medication. And then in part B is the deep learning algorithm analyzing different words that also flagged for emergency care versus non-emergency care, where the darker the blue, the less likely they needed emergency care. So what deep learning is doing is that using all of these patient charts, it's now able to parse out very in fine detail exactly the probability of needing emergency care or not, based on what the language is showing here. So just saying 86-day-old, this big red one in B is probably the biggest kick, right? Again, under 3 months of age in an emergency department, we usually get more nervous than, say, a 5-year-old, right? Here's another way of using predictive models. So this group looked at 27,000 pediatric ED visits, of which 30% had imaging. And they wanted to decide whether they could predict the use of an X-ray or CT scanning as soon as the patient visits the emergency department. They were able to show that with unstructured data, remember this is when regular medical records with human text are being written and analyzed, adding unstructured data increases the ability for an algorithm to, of a predictive model of the AI to predict whether or not an X-ray or CT was needed. And so just using structured data only gets you a 0.7 on the C statistic, which is not bad, but then it can increase it by adding the unstructured data or just using unstructured data by itself. In other words, there's something about doctors documenting their thought patterns that makes it easier to tell whether or not they are looking for an X-ray or not. Here's one for us in the emergency department for return to spontaneous circulation. And this was done with 8 million EMS, emergency medical services, pre-hospital records. Of these, 70,000 were on cardiac arrest, about 1,800 fell into the pediatric age range, and they found complete data that were analyzable in the 1,700. And with this, they were able to show both structured predictors. So with structured data, if the defibrillator was turned on, if the age was between 5 to 13, those two known predictors increases the odds of return to spontaneous circulation after cardiac arrest. On the other hand, if you were only on the scene for 5 minutes or less, and if there were epinephrine doses more than 3 times, then your odds of getting to return to spontaneous circulation was actually poorer, which makes sense. And these are the regular structured predictors, no AI involved. When they used the natural language processors to look through the rest of the EMS notes and looked for particular words that seemed to be associated with either getting to return to spontaneous circulation or absolutely no, or very unlikely to have return to spontaneous circulation. And what happens, again, is that adding unstructured data using natural language processing still improves precision and recall for the return to spontaneous circulation prediction. And then these natural language processing models do improve prediction beyond a priori chosen key terms. So it's not just the physicians deciding which words like pulse, not looking good, or whatever the words may be. It's that the actual natural language processor model found these words for us, and it was better at finding the correct keywords than it was for humans. So now that the machines are learning, they are now generating things. So this is when we summon or generate AI determined items and predictions, and then put it into the actual to the clinical care. So here's audio recognition, and then you'll see visual recognition later. So can an AI recognize certain lung sounds, and can it actually tell us what's going on? Again, this is the diagnosis bleeding into the treatment realm. So within this particular scoping review, there are 7 pediatric studies as of 2024 published some sort of AI module that allowed for discernment between certain types of lung noises, wheezing versus normal, crackers versus normal, wheezing and growls versus normal, but there are none of which had external validation studies. All we know that it can tell the difference with fairly surprising accuracy, but no one has actually validated it against some external items besides just the physician listening to it. So it's going to be coming to a day when generative AI has the ability to listen to the lungs for you and generate a treatment plan, but it's not yet as of this particular talk in 2025. Here's image recognition with intussusception. These are Korean scientists who then mapped out different ways of using grayscale ultrasounds, point of care ultrasounds, or formal ultrasounds for intussusception, for it to detect intussusception given a whole bunch of grayscale images. And with this particular algorithm, the AI models split the entire image into all of these micro quadrants or micropixels, if you will, and then started calculating the odds of finding intussusception based on any combination of these pixels. And then finally proposes a composite, which is the bottom right, of detecting intussusception or not. There's still false positives and false negatives, but what is creepy and amazing is that the area under the curve, or the ROC curve, of sensitivity to 1 minus specificity was pretty much 1. They literally missed 1 patient out of every out of the 300-ish in this study. So what's interesting is that this algorithm, using a training data, was able to then start predicting intussusception correctly and ruling out intussusception correctly in almost all cases. This is far better than a human, by the way. It's for point of care ultrasound intussusception. This is assuming that the image quality and image procurement is good and optimal, but still, this is actually encouraging for AI, a little bit disturbing and interesting for us as humans. And then finally, there's some generative AI discharge instructions. We know ChatGPT and generative AI is really good at generating text. And so this team asked the ChatGPT 4.0, which is multilingual, to create discharge instructions in a variety of different formats for pediatric diagnoses at what's called a 5th grade level. So what is that, 11 years of age of students, and 8th grade level, maybe 13, 14 years of age reading level in Spanish and English, because Spanish is our second highest language in the United States. When ChatGPT was prompted to do these for 6 different diagnoses, all of these were then scored and reviewed by multiple humans. They found that the readability was actually very, very appropriate for all languages. And then when the humans scored all completeness, in other words, did the discharge instructions have all the items that all the human specialists with a Delphi process determined to be necessary and complete, did the AI actually use all those points? What we did find was that the secondary language, Spanish, which ChatGPT has less experience in, had slightly less completeness than in English, 62%, still not great. What this means is that as the GPTs become more and more multilingual, this is pertinent to all the patients that you take care of, certain languages may perform better with the GPT engines than others for a variety of different reasons. And these language disparities may start disappearing over time as the GPT engines get better and better. Great. So here's the percentages. So here were our objectives. I hope I had a decent, quick overview of the landscape of things, including telemedicine, electronic health record prediction models, and a few examples of AI. If you have any questions, please don't hesitate to send me an email, and hopefully we'll get to see you in person sometime in the future. Thank you very much.
Thank you very much, Dr. Todd, for this interesting talk. And hello, can you hear me? Hello? Thank you very much, Dr. Todd, for this interesting talk. Our next speaker is Dr. Christopher Amato. He's an associate professor, Department of Emergency Medicine and Pediatrics, Sydney Kimmel Medical College, Director of Pediatric Emergency Medical Fellowship, Medical Director, Pediatric Advanced Life Support in Atlanta, attending physician, Pediatric Emergency Medicine, Morristown Memorial Hospital, Goreb Children's Hospital, Morristown, New Jersey. Dr. Todd will talk about new advances in asthma management. You can start, Dr. Chris.
care of the asthmatic, and what is the latest literature that we can utilize to help improve our care in the emergent care of the asthmatic patient. So let's start with a 13-year-old, and this is my story, to be frank. 13-year-old presents with 3 days of cough and worse with activity, shortness of breath. No one smokes inside the home, and I'm using that funny gif there just because I just think it's funny. No one in my family smoked. Nonetheless, the rest of my family had a very significant atopic history, right? Both of my siblings, my sisters, were eczematous. I don't know how my brother got away with nothing, but that generally is how that happened for him. There is a strong family history of atopy. I, of course, was the only person with asthma and with severe life-threatening nut allergies. And in the 1970s, there was no nut table, no nut-free table. I was the nut to be spoken of. So this child is presenting now with afebrile, respiratory rate in the 20s, 90s for pulse, 94% tachypnea, but no apparent distress. He's awake, has an abnormal breathing, normal circulation. Vital signs are as follows, with the tachypnea 42 now. And again, he doesn't seem to be any distress. In grade school and high school, I was not voted most likely to succeed. I instead was voted most likely to suck wind. In the 1970s, gym teachers were not known to be very PR or kind even. My nickname growing up was Leather Lungs. Hey, Leather Lungs, are you going to be doing the mile with us, or are you sitting down again? So, nonetheless, his airway is patent. He's tachypnic without retractions. You do not hear any wheezing. And I hope that that's making the little hairs on the back of your neck start standing up, because that is very concerning, right? When we don't hear any wheeze, that's not a good sign in these kids. That's potentially a fatal sign in these kids. There is a prolonged expiratory phase. Color is good, cardiac is good, disability is quick and dirty is normal, and there's no external signs of injuries. When we're talking about the asthmatics, there are a few markers that we need to identify as what's going to put these patients at higher risk for falling off that precipice much, much faster, with more morbidity and unfortunately even with more mortality. If they've had 2 or more admissions in the past year to the hospital, or 3 or more admissions to the ED in the past year, those patients are at higher risk for badness to occur. If they've been in the ED or admitted just recently in the last month, that is a kid that's going to fall off the curve. If they have been utilizing their short-acting beta agonists, their albuterol or the beta response medications, and they're utilizing more than 2 of those per month, we're having a bad problems. And if you remember back in the 90s, they had all these dramatic pictures of children holding onto their albuterols or their Ventolins, whatever it was, their short-acting beta agonists, and they were dead. They have a history of rapid progression of their symptoms. They have a history of either requiring some kind of ventilatory support, be it high-flow nasal cannula or non-invasive, or being intubated. They have had a prior history of seizures or loss of consciousness. Maybe that actually wasn't related to a vasovagal or a neurologic issue, but maybe that was actually a hypoxic issue. That's what puts them at higher risk. They've ever required any PICU admission ever, and the 2025 update from the GINA, from the Global Institute for Asthma Care, is basically focusing, saying that if a patient's ever required admission to an ICU for their respiratory issues, we need to be aggressive with them, okay? So moving away from history and focusing on the disease components, there's a concomitant use of illegal drugs or even cigarette smoking. It is amazing to me that there is actually more than 50% of asthmatics in the United States actually use tobacco in some way, shape, or form, typically with cigarettes, but also can be electronic cigarettes. The psychosocial components are a big issue in terms of getting to care, getting themselves seen, and getting the right medications. Do they have other comorbidities that could worsen their outcomes, cardiovascular or other pulmonary disorders? Here's the biggest thing that most clinicians don't understand. I, as an asthmatic, am always breathing horribly, Okay, so when I was growing up, for the first 30 plus years of my life, I was breathing at 50% of predicted. I had no idea at that point what breathing well was. So it's very hard to actually get a gestalt that my breathing is getting worse. And yes, that's why we have peak flows to give us an idea of green, orange or red, that we're getting worse, because that's an objective way for us to do it. But I, as a patient, cannot discern, wow, I am breathing horribly today, because I was always breathing horribly. And it was only until I was actually finally on the right group of medications that I started to breathe pretty close to above 90 to almost close to 100% of predicted, and not at half of that. Non-compliance with medication. That is very common, and especially in teenage years. And that's actually what happened with me when I was 12 years of age, almost 13. I decided that I was done with this. I didn't want to be different from everybody else anymore. I did not want to take these medicines anymore. I did not understand. I did not have the mental maturity to recognize that these medications were making an enormous difference for me between being kind of crappy and being, oh my goodness, really, really bad. Lack of social supports, associated psychiatric issues, and that becomes the chicken or the egg issue, right? Am I anxious or depressed because of the asthma, or the other way around? And then lastly, we know that African American and Latino patients have a 4 times increased morbidity and mortality, often related to a myriad of all these things combined. So we are trying to focus on the patients in the emergent setting, okay? In the exam, and again, you guys all know this, and I appreciate that, we're looking for that seesaw breathing. Now, I spoke about in the upper airway disease process about abdominal distension, right? When we are breathing fast, when a smaller child less than 6 months is breathing fast, they are swallowing much more air. So the diaphragm cannot pull down to suck in a full tidal volume of breath. Subsequently, they're going to increase their respiratory rate to maintain that minute ventilation. But it is that seesaw breathing that they're doing when they're younger to indicate they are having respiratory distress. We can have head bobbing as well when they're getting to that point of getting close to respiratory failure. Intercostal retractions as we get older, more school age and double digits, because now we have the muscles in our thoracic walls to help us take a breath in. And then, of course, nasal flaring. Status asthmaticus is an old term. We are not utilizing that any longer. This is really just going to be considered a severe asthma exacerbation, okay? Now, I put the chunky cat there is because when I was growing up, I started with my very first asthma attack when I was about 5. And at that point, they thought more steroid was better. So I was on daily doses of 100 milligrams of prednisone for weeks to months at a time. And ultimately, as I said to you before, I am 5 foot nothing, but the rest of my family is 5'10". So that higher dose of systemic steroids closed my epiphyseal plates, and they stopped my growth earlier on. And then I was blessed with a very large appetite because of the steroids. So I put in the chunky cat there. But who doesn't like a chunky cat? What could we do? What did we do in the past? Well, in the bad old days, we would give asthmatic cigarettes because that was the right thing to do. In the top right corner of your screens, in the 1800s, they would write a prescription for a shot of whiskey. I will tell you that, and this is copyrighted, just so it's clear, when I retire, my plan is to open a bar across the street from the emergency department and call it discharge instructions. But nonetheless, no matter what we are doing, it has got to be something that actually has chemical confidence to affect the asthmatic change. Unfortunately, tea and dates will not do it, but coffee can. And again, in the bad old days, we had asthma cigarettes, we had ammonium chloride inhalers, which would only cause a chemical pneumonitis to add to the bronchospasm. When I was being cared for in emergency rooms when I was young, if anyone is old enough to know what Bronchosol is, that was the precursor to our current short-acting beta agonist. That was a non-specific beta agonist, so it would work very much like epinephrine and jazz everything up. And I would get not only a shot of epinephrine, but then that would be followed by something called suspirin, which is long-acting epinephrine that lasted somewhere between 12 to 18 hours. So you want to talk about a very jittery person? That was me growing up when I was being cared for with my asthma. So what do we need to do diagnostically? Do I need a chest x-ray in every first-time wheezer? No. But if I do get a chest x-ray, there are a few things that I should be looking for. Hyperinflation of the lungs themselves, which could ultimately lead to flattened diaphragms. But really, there's actually a nuance, something called peribronchial cuffing, which, if you can see, is this dark space, this white space around the blackness of the bronchi, okay? This is really pathognomonic for either a reactive airway component or a bronchospastic component or even a viral component. But if I see this on a chest x-ray in a child who's been coughing for weeks, then that's a good indication for me to start thinking about providing some kind of short-acting beta agonist trial to see if I can get them better. Diagnostically, what can we do? Absolutely. Give them a bronchodilator. I know that when we're dealing with bronchiolitis, somehow the trial of a short-acting beta agonist has become, the enemy. But the reality is that it might make some impression on that child, especially if they're from a very atopic family. Remember, please, that cough, not wheeze, is the number one symptom that we're looking for bronchospasm. Wheeze comes later. We are dealing with a bronchospastic response. So a quick and dirty way for you to get a child to help you determine whether this is a bronchospasm or not is have them take a deep breath in and blow it out hard like they're blowing out birthday candles. Any child over the age of 2 knows how to do that. And when they have that prolonged expiratory phase, which is equivalent to your forced expiratory volume 1, right, your FEV1, that's going to give you one of 3 things if it's bronchospastic or reactive airway. 1, there's going to be a prolonged expiratory phase. 2, in that prolonged expiratory phase, there might be the hint of a wheeze. Or 3, when they blow out hard, it is going to be followed by a bronchospastic cough. That is quick and dirty for you to determine on a child, hey, this is something that probably does need a trial of a bronchodilator. Yes, we can use the pre and post peak flows like we used to. In the adults in the late 90s here in the United States, they found that subjective improvement in the adult was equivalent to the pre and post peak flows. So as much as I used peak flows before and after breathing treatments way back in the 90s, it's passé at this point. If the patient says, yeah, I feel better, that's good enough. A lot of these kids, especially at certain times of the year, get determined as bronchitis. First of all, children are not typically chain smoking. There's not a lot of chain smoking toddlers out there. So bronchitis is not really a pediatric diagnosis, okay? And they will have the same response to antibiotics as if you would just shake a rattle over their head or dance the funky chicken. There is absolutely no reason to be giving these kids antibiotics. All you're doing is worsening the overall outcomes for this child because they're building up more and more resistance. So why are we using aerosolized medications? Well, it's straightforward and easy. We have this huge space that is basically begging to be absorbed, right? We have very thin alveolar epithelium with a very large surface area, and it's non-invasive. This medication is going directly to the sites where we need them to go. So aerosolized medication is absolutely crucial to the treatment of these kids. Do we need to use nebulizers in all of them? Absolutely not. But we definitely need to use a combination of both a short-acting beta agonist and the anticholinergic, ipratropium bromide. Typically, we're going to be giving those in a trial of 3 if we're using jet nebs, and we can use an MDI with spacer. We want to provide them steroids early on, and we want to provide that in the first hour because that will dramatically affect their outcomes, their morbidity and mortality. Oral, just as in upper airway and croup, oral is just as effective as IV or IM. And if I can do anything to mitigate the stress and the turbulence of that airway, that's what I want to do. Again, when we're comparing nebulizers versus MDIs and spacers, the MDI comes out at 60 miles per hour. When we are depositing it directly into a pharynx without using a spacer, it gets hung up on the pharynx by at least 50% and swallowed into the stomach as opposed to breathed into the thoracic cavity. The reality, though, is that when we are comparing nebulizers and spacers, they are actually equivalent, with some advantages to the spacer and MDI compared to the nebulizer. But please make sure that the patients know how to use their MDIs, because you'd be shocked at what they think that they know. And in fact, literature will tell you that within 2 weeks, the education that you provided is already gone. Spacers versus nebulizers, no difference in admission rates for your patients. There is decreased length of stay in the ED for children, not for adults, but there's decreased tachycardia and tremor in pediatrics when we're utilizing the MDI and spacer. Please, please, please don't just stop at 2 puffs for all ages and all sizes. Each spray is approximately 108 micrograms. So if we were to equate a 2.5 milligram neb to puffs, we would be talking about almost 23 puffs. Now, we are not expecting them to be given 23 puffs because we all recognize that more than 50% of our albuterol neb is out in the world and not in the patient. But we should be giving them at least 8 puffs, and we'll get into that in a second. When we compare the expensive one-way chamber versus an empty water bottle that you can actually cut a hole in either the back, or much easier, just make a small slit in the side and push the MDI in there, they are also equivalent. So rather than spending a lot of money on an expensive one-way valve chamber, we can get away with a $1 water bottle that's been emptied. Please make sure you empty the water, because that's a whole different aspiration event. This was also looked at again in the 2019, and it was also again found to be completely equivalent. So again, how many puffs do we need? For less than 10 kilos, for an acute treatment, we need at least 4 puffs. And that's 4 puffs every 2 to 3 minutes. For 10 to 20, we need 6 puffs, and greater than 20 kilos, we should be giving 8 puffs. So for our teenagers and adults, please don't send them home with just 2 puffs every 4 hours. Their tidal volume is huge comparatively, and we should be treating them accordingly. And if you look at all the different guidelines, the global initiatives, the Saudi initiative, the Scottish intercollegiates, all of them are saying the same thing. We need to be giving more beta agonists to these patients when they need it, and even in just general treatments, right? After discharge, yes, less than 5 years, which is approximately maybe 20 kilos, 2 puffs every 4 hours. But 5 to 12, 4 puffs every 4 hours. And then greater than 12 for adults, 6 puffs, okay? And the way that I suggest that we do it is 2 puffs, wait 2 to 3 minutes, 2 puffs, wait 2 to 3 minutes, and then if they need another 2 puffs, we wait another 2 to 3 minutes. That just buys us more and more open beta receptors for that medication to hit. If they're in our emergency room for a 3rd time this year and they're not on an inhaled corticosteroid, we really should take it upon ourselves to prescribe them an inhaled corticosteroid. That is going to make the biggest bang in terms of their morbidity, certainly for long-term scarring of those lungs. When we're dealing with more of the severe asthmatics, we can actually make more difference in them, starting with a continuous neb versus intermittent nebs. And there's more data that says this. We have reduced hospitalizations in those with severe asthmatics, right? So when we're looking at these trials, and this is a meta-analysis of this, the number needed to treat was 7 for severe asthmatics. So I need to treat 7 severe asthmatics, and I can send 1 of them home. I don't know about you, but we have a big issue with holding patients in my ER, and the quicker I can get someone either out or upstairs, the bigger the difference is when I can see the next person coming in, okay? Now, the problem is that the longer they're exposed to these beta agonists, the more side effects, more tremor, more tachycardia, decreased potassiums, and even actually we can start seeing cardiac injuries with troponins, but we'll talk about that in a second. The benefits now of not necessarily providing them nebs, but changing the one thing that we have all done the same way for the past 50 years is a vibrating mesh neb. What this does is takes the same medications and microsizes it down to 1 to 5 microns. This then also minimizes the rain out. So when we're using our regular compressed air or compressed oxygen, or it's called a jet neb, we typically wind up having 1 mil left of the 3 mils that we put in there. Using a vibrating mesh, I am using up 3 of the 3. So I'm getting more medication. I'm microsizing it so it's going into the smaller airways, which is where I need it. So I'm getting more in and more bang for my buck. It is not heated. It is a cool mist. So in my experience for the last 3 years that we've used it at my institution, it has made a dramatic difference in these children. They are not bothered by it because there's no noise. It's silent and it's cool. It is not making any vibratory noise. And there is, again, minimal residual volume left, okay? So I'm getting way more from the same treatments, and I'm actually utilizing less drugs. So let's bring you through the literature on that. When we're looking at it just from a colorimetric point of view, the jet nebulizer versus the vibrating mesh, we have dramatic more medications distributed throughout the lung. That is a good thing. In 2018, Dunn and Short looked at children less than 2 to up to 75. In 2019, we had about almost 1,200 patients, 2 to 18, looking at, again, the dosing of 2.5 milligrams versus 5 milligrams and how long it took between the doses being given, how long they needed before we started giving them an hour-long treatment. And then in 2019, this was including adult asthma and COPD patients. In 2020, this was a single dose of short-acting beta agonists via vibrating mesh versus jet neb until they had an improved asthma score or they got discharged or admitted, whatever their disposition was, whatever came first. Overall, if you look at all those studies, we had 6 times more medication was given to the lungs than compared to the old-fashioned jet neb. We had less albuterol given. Most of these patients actually improved with a single 2.5 milligram instead of the typical 3 back-to-back, which is 7.5 milligrams. They also had reduced number of needed treatments with the vibrating mesh as compared to the jet neb. And overall, the vibrating mesh was associated with, again, a decreased length of stay. Only about 0.30 minutes, so like 32 minutes-ish or 20 minutes, but less is more in my world. That means I got more patients in during that time. We cannot treat these patients alone with beta agonists. We absolutely need the ipratropium bromide with a decrease of 30% of hospitalization using both of them, okay? The anticholinergics are opening up other airways where there are open beta receptors waiting for that Ventolin or that albuterol to go in. Ipratropium bromide does not work in a single dose. It needs multiple doses. Number needed to treat was 12 for all your asthmatics, but 7 in your severe subgroup. Steroids are absolutely imperative for all of our asthmatics. We need to provide them earlier on in these kids. So the number needed to prevent 1 admission is 6 in all your asthmatics. I get 6 asthmatics treated with steroids in the first hour. I get to send 1 home. These are great numbers needed to treat. Again, IV, IM, oral are all equal, but inhaled or nebulized is not, okay? Higher doses of steroids have not been proven superior, so less is more as it comes with almost everything, as it is in art, as it is in medicine. Systemic corticosteroids, IV versus oral, all are equivalent. Steroids in terms of return rates, we have not had any major issues with relapse rates, but when you look at dexamethasone as a single dose, you have dramatically less amount of vomiting. And again, we're utilizing our intravenous formulation, which is 10 milligrams per 1 ml. I use a 12 milligram dose max. There are some studies that use 16 or 18. So at most, we're using less than 2 milliliters of dexamethasone. It is very difficult to vomit 2 milliliters of steroid up, as opposed to the amount of prednisolone that you would do otherwise. When you're looking at single dose oral treatment with dexamethasone, there was no difference in pediatric respiratory assessment scores at day 4 or requirements for readmissions or return to the EDs. There was definitely more associated with vomiting with prednisolone. Again, this is the study that I did way back when. It's hard to believe it was a decade ago. But if we look at the oral dexamethasone, IV versus oral, we had similar pharmacokinetics, okay? And the same thing on this curve here. Magnesium is absolutely crucial when we're dealing with the very sick asthmatics. It is a smooth muscle relaxer. And when we're dealing with the 45 to 50 milligram max dose, we don't have to worry about hypotension. When you're dealing with the 75 milligram per kilo dose max, yes, you will start to have that because smooth muscle relaxes around all the blood vessels, and subsequently they will have the vasodilation and hypotension. It also inhibits the degranulation of mast cells. It also decreases the release of ACH. So it is helping out in a myriad of ways. IV magnesium, again, you can also think about IV versus continuous IV, but not nebulized. Number needed to treat with a dose of IV magnesium is 5. We're dealing with really great numbers needed to treat. We get 5 patients treated with magnesium, and they don't need to be admitted just because they got magnesium. If you monitor them and space them out to 4 hours, they can absolutely go home and be cared for at home. Other adjuncts. There are a bunch of other things that we're going to talk about quickly. Beta-2 agonist intravenous. There is really no advantage of IV over inhaled alone, okay? When we're dealing with intravenous and added to beta agonists, maybe there's some mild benefit in children. There is no benefit in adults, but there's significant amount of side effects. Tremors, troponins, hypokalemia. We really need more studies on this, but at this point, if you're trying to pull out all the stops before you intubate, absolutely start pulling this out. But overall, it really doesn't have much benefit. Adding aminophylline, really no change in admission rates, length of stay, or ICU use. Dramatic side effects, and I can tell you from personal experience that I had major issues with therapeutic dosing of this because it is a very narrow therapeutic window. It can make you feel very, very sick. What about helium oxygen? Again, what it's going to do is try and change that turbulence into a laminar flow and act as a lighter gas where the albuterol and the ipratropium can kind of go around those turbulent airways. This is basically a bridging technique. What their clinical lung function is before you start the Heliox and after you start it, unless you're doing something else in between, it's exactly the same. But if you're adding the magnesium, if you're adding other modalities, this can help and minimize the patients that we intubate. There are perceived benefits to it. Ketamine, unfortunately, there is no benefit. Is it the drug that we'll use to intubate with? 100%. Is there going to be any catecholamines left for them to intubate with, or for the response to ketamine? Probably not, but it is absolutely useful in the intubation scenario, but not primarily for sedation alone. Fluid boluses, and this is the really important thing, is that the more fluid we give these kids, the more they're going to develop pulmonary edema. So less is more when it comes to pulmonary fluids, okay, providing extrarenal fluids. BiPAP should absolutely be the way that we are utilizing it. It improves the delivery of bronchodilators, it decreases fatigue and workload, and it prevents hypercarbia. These asthmatics are not tiring out. It is not a muscular issue where they're so sleepy because of that. It's just they've got so much CO2 built up that they're becoming CO2 narcotic, not muscular tiring, okay? In terms of the cons, though, you can have increased hyperinflation, which could lead to pneumothoraces. You can have increased intrathoracic pressure, and of course, the higher your pressures, the more it affects your preload in your heart. Non-invasives absolutely are going to be the standard that we're utilizing before we think about intubating. Has a lot of pluses, and of course, in the adult ICU and the PICU, it again has improved outcomes. There was just an article that came out this past week looking at high-flow nasal cannula. And yes, there are some downsides to it, but as a staving off while all your other interventions are taking place, it has a place for it in the acute treatment. Intubation, it should be the last thing that we do. These patients are persisting, worsening despite our treatments. We are getting more lethargic, more altered. They're increasing their CO2. We should be cognizant of utilizing this only when absolutely necessary, because 50% of all the things that go wrong happen once we intubate, and that includes mortality, okay? Please remember that we want to have as big of an I to E ratio as possible to allow for that expiratory time so we don't stack those breaths. We want to decrease the pressure, decrease the hyperinflation and the airway pressures. So we want to potentially think about a smaller tidal volume in these kids and go down that pathway. You need deep sedation so that they don't buck the vent. And again, a prolonged I to E. This is just something that you can print out and have in your pocket. So essentials are going to be beta agonist therapy. Vibrating mesh is going to be dramatically better than our old-fashioned jet or compressed air. Anticholinergic therapy, not just a single treatment. Early corticosteroid therapy, oral is equivalent to IV or IM, but not to NEBs. Use of magnesium, absolutely. And then last but not least, consider sub-Q, airway support using non-invasive positive pressure, and then think about the airway when we have to. Thank you so much. It's been my absolute pleasure to bring this to you, and I look forward to any questions you might have as we move forward. Be well.
Thank you very much, Professor Amato, for this very interesting presentation. I really enjoy it, and I'm sure most of our audience enjoyed it. Now we'll go to the next speakers. As our next speaker is Shane Fox, Professor of Emergency Medicine and a Professor of Pediatrics. He's the Director of Emergency Medicine Residency Program, Carolina Medical Center, Charlotte, North Carolina. Dr. Shen will talk about mastering procedure sedation and analgesia in the emergency department. Dr. Shen, you can start, please.
Hello, everyone. I'm Sean Fox from Carolinas Medical Center in Charlotte, North Carolina. It's an honor to be invited to discuss several pediatric topics with you over the next several days. What I would like to explore right now is ways to improve our sedation and analgesia with respect to children in our emergency departments. And essentially, it's a way for us to mitigate anxiety and pain. And hopefully, when you encounter your patients, they don't all look like this, but certainly this level of apprehension is not unexpected. Obviously, coming into the emergency department alone is a frightful event. And if you're a child, the emergency department certainly is filled with lots of strange people, strange noises, and potentially terrifying instruments. So I understand the level of anxiety could be high just by coming to the emergency department. But now you layer in the fact that they probably do not feel well or actually have something painful. And now that anxiety actually can compound their pain, and their pain can then further increase their anxiety. And that tornado of swirling anxiety and pain can really get out of control. So hopefully what we all will be able to do at the end of this conversation is be better at mitigating both the anxiety and pain so that it makes not only them more comfortable, but our jobs more easy. Now, obviously right now, all of you are like, hey, this is a very simple solution. It's called ketamine. Yes, ketamine is a great solution. We'll talk about that. But I would also like to go beyond ketamine, maybe even before ketamine. But hopefully today we'll be able to have the whole spectrum covered from before to beyond ketamine and above. So how are we going to do that? Well, we're going to first start off by talking about some alternatives to ketamine and in addition, some adjuncts to ketamine, and then put it all together in a roadmap of mitigating anxiety and pain. Now, sadly, on the road to mitigating anxiety and pain all too commonly, we fall off the cliff. We actually do not do a good job. And this is well known. There's literature out there that actually from large quaternary children's hospitals where the experts are to deliver the best care in theory to children exist. They have been studied in the setting of having children present with obvious long bone deformities. And all too often, what we find is that we don't take care of those patients appropriately, to the point of the fact that almost 60% of the children who presented with obvious painful long bone deformities, almost 60% didn't get any pain medication. Now, clearly, you and I can agree that that is not optimal. That is definitely below the standard by which we would like to practice, but it's a common theme. And some of that is because we underappreciate children and their pain, but also sometimes we misconstrue their anxiety as pain or pain as anxiety. And what I want to do today, again, is kind of appreciate both and address both while we're taking care of the patients. Now, through the roadmap, we're obviously going to have different mile markers and checkpoints, but we already mentioned one of the more substantial off-ramps, and that is ketamine. We all love ketamine. I certainly have delivered a significant amount of ketamine in my career to children to hopefully and successfully mitigate their pain and anxiety. Now, why do we all love ketamine? Well, it is effective, it is safe, it's quick, and it is consistent, that we are familiar with how it responds, we are familiar with patients' response to it, and we know it to be reliable. And what it does really well is it both treats both their pain as well as their anxiety, and it doesn't affect in a negative way their respiratory status, which is lovely. In fact, we really don't even require that much monitoring. Now, I'll be honest, in my emergency department, clearly I'm going to have the patient on a cardiopulmonary monitor. I'm going to have end-tidal CO2 monitoring, all of the bells and whistles and all the safety mechanisms. But let's be honest, if you can administer ketamine to save children from a flooded cave via scuba, you can use ketamine anywhere, right? If you aren't familiar with this story, I suspect many of you are, but if you've become less familiar with it, I urge you to become reacquainted, just even from the medical side, not even from the heroic side, but from the medical standpoint of what was achieved here is phenomenal. And we essentially were able to save these children using scuba, which they'd never done before, swimming them out through murky, muddy water and keeping them comfortable using scuba gear by intermittently dosing them with ketamine. Now, there is probably no more austere environment than that I can think of. And therefore, I know it's a very safe and effective tool to have in our armamentarium. In fact, it's so safe and effective, the World Health Organization says it should be an essential medicine in all of our emergency departments because of its wide range of applications and the ability to apply it in a wide variety of settings, from the battle zone to the ICU zone, and sometimes our emergency department is in fact both. So we know that we can use ketamine effectively and safely in children, but it's not perfect. Nothing is perfect. The moral of the story is always nothing is perfect. It does lead to some increased secretions. Usually that's not substantial enough to cause significant problems, but it's something that we need to keep in mind. It usually causes nausea and vomiting. We need to, anticipate that, and many times can avoid that by pre-treating with an antiemetic. The big concern is the rarer concern of laryngospasm. It does happen. You need to be ready for it. You need to be prepared for it. If it does happen, you don't want to be caught off guard. What would you do if this patient that you just gave ketamine to all of a sudden had laryngospasm? Well, you would take your finger and you would apply pressure in the laryngospasm notch. It's actually in the anesthesia literature, and that notch is located right in front of the mastoid process, right behind the auricle. Essentially, you're trying to put your finger medially almost into their ear canal through the back of their ear canal. Yes, it seems like it would be a little uncomfortable. And in fact, that's probably what helps kind of resolve the laryngospasm. If that's not working, jaw thrust, bag respirations obviously are our next step. Hopefully you never have to utilize this tip, but have it ready in case you do. Probably more commonly, you're going to encounter some emergent reactions. Seems to be less of an issue with younger children, kind of more your teenagers and young adults, or even older adults will see this, and sometimes requires a little bit of a benzodiazepine to help bring things down. But I would say the one thing that makes me not want to use ketamine the most is sometimes it's just too much. I don't need to do a full procedural sedation if I've planned appropriately, if I've taken appropriate steps to help already anticipate this patient's anxiety and pain. So let's talk about that. When I say alternative, I mean, what are our other strategies? Not just therapies, but strategies. And probably the most important one is being prompt, right? So I already said that I know when the kid comes to the emergency department, they are going to be apprehensive. They're probably increased anxiety because their parents are also apprehensive. And then the way that that tornado of apprehension and anxiety spins up with pain and how each kind of crescendos the other, if I can break that cycle early, then hopefully I can make my job later easier, meaning maybe I don't need to do a full procedural sedation to be able to get this foreign body out of their ear canal if I'm able to quickly address their anxiety and pain. Now, we all work in very chaotic environments. We all work in environments that we're being pulled in 900 different directions. That's part of our job. But anytime I'm able to try to intervene early in the patient's encounter to help deliver some modicum of reduction in pain, then I think I'm going to make my job easier later. Clearly, there's got to be some other offerings of ways to mitigate their pain. And what can we do? Well, certainly topical applications, which are not going to be fear-inducing because there's no needles involved, right? Right when I come at a child with a needle, the apprehension increases. And even if I deliver pain medication, sometimes I've lost trust. So if I can help reduce their pain without doing something scary, like applying a topical lidocaine, or in the utilization of a needleless system such as the J-tip, what I can do is actually inject lidocaine without a needle. And we find that this method is as effective as some of our other topical applications, such as EMLA or LMX or the LET. Now, there is another mode of giving pain medication without a needle, and that is through the nose, right? That nose is obviously full of significant vasculature that's going to bring all that medication directly first pass and bypasses the liver, and I'm able to have a good analgesic effect. We know that using the nose, in fact, is a wonderful way to administer medicines in the pre-hospital environment, such as Versed, if someone were having a seizure. So I implore you to actually use that same technique that some of our medics are using in your emergency department right when the kid presents. Say they have an obvious upper extremity deformity and you know that they're in pain, all right? It's not a question. And I would like to give them an analgesic, but I would need, I'd like to give them IV morphine, but I don't have an IV yet. Well, I can use intranasal fentanyl and it'll be as effective as IV morphine. And now the family is on board with the fact that I am taking their child's discomfort seriously, and hopefully we're able to get the child's discomfort reduced to the point where their anxiety also starts to spin down and everybody is able to take a breath and be a little bit more calm. And now my nurses can put an IV in a more calm environment. We can get our x-rays with the patient actually having analgesia on board. So now a couple tips for delivering intranasal medications. We need to, as with everything, choose the right approach for the right patient. Not every patient is going to be a really good intranasal candidate. Maybe they're super snotty. Maybe they're just going to fight you for everything. And we're talking about relatively small aliquots of fluid. So if, as I'm squeezing the syringe, they're going to jerk and I squirt the medicine everywhere else, I don't have a whole lot of volume to be dealing with. So I need to be able to deploy it reliably. So I need a cooperative person. But I also need a medicine that's cooperative. I need it to be concentrated because I have to use a small volume, and I need it to be lipophilic. So what are our options? It just so happens to be the things we love, right? Fentanyl, IV morphine, and intranasal fentanyl have been shown to be equivalent. So I can give you similar pain control with intranasal fentanyl. We know intranasal Versed. We use it very commonly for disrupting seizures, aborting seizures. But sometimes I just need to bring someone's anxiety down. I'm going to use obviously a little lower dose for that. But also we can use intranasal ketamine and intranasal dexmedetomidine. We're going to save a conversation about dexmedetomidine in a minute. We'll circle back on that. Having other tools is always useful too. Now, some of these tools aren't going to be for everybody. But if you have them, I know that you probably love to use them. And if you don't have them, sometimes it's worth investigating whether you can convince your bosses to get them. One thing that I would actually advocate all of us using more would be laughing gas, nitrous. Dentists have been using it for a millennia, and it's become more commonly used in our emergency departments, both our adult and our pediatric emergency departments across the country. But it also is a medicine that is often thought of as just being a fun party trick, but in fact is an analgesia, an anxiolytic, and an anesthetic. It does all three things. And what's perfect about it is very quickly on and very quickly off. It's almost ideal in that, because once your procedure is done and they start to breathe room air, or you reduce the volume, the percentage of nitrous, now they awaken and the medicine is gone with very minimal side effects, maybe a little nausea and vomiting. So it's almost ideal in that way. Once you're done your procedure, the patient is able to be discharged. You don't have to wait for them to recover. Now, it won't work if they won't inhale it. So if the kid won't keep the mask on, there's a nasal mask and a full face mask. If they're vigorously crying and you only have a nasal mask, well, they're breathing through their mouth, so they're not inhaling the gas. So it won't work if they don't inhale it. It does work if they do. But you can't use it on everybody. You can't use it, let's say I have a patient with a pneumothorax and I was going to give them some sedation and analgesia for the chest tube placement or the pigtail placement. I can't use nitrous because the nitrous will go into the pneumothorax. It'll diffuse in there more avidly and actually cause expansion of that closed air-filled cavity. Similar if you had a patient with small bowel obstruction. I'm probably not doing a procedure on a small bowel obstruction patient in an emergency department, but you get the picture. Another contraindication is if the patient is pregnant, or also any of the providers in the room, because some of the nitrous might not be scavenged by the system, and nitrous is a teratogen, so you don't want to expose any of your staff or your pregnant patients to it. Now, how about milk of amnesia, the lovely propofol that we hopefully have access to? There is one issue with propofol in that it can occur in children, and it often leads to us being reluctant to use it for procedures in the emergency department. We'll get to that. But it also is a very excellent medication because it does activate those GABA pathways to lead me to become somnolent, and it inhibits my MDMA pathways. It is really quick on, and it has a relatively short duration, right? We can reliably anticipate the patient waking up relatively soon after the deployment of the propofol. It's known to be safe and effective in the emergency department. I can titrate it, but what sometimes we forget is that it's not an analgesia. It has no analgesic properties. So if I have a gnarly extremity that I need to reduce, this is maybe not the best option, or if you're going to use it because you like the muscle relaxation it gives, it's not to be used by itself. You need to give something in addition that would cover for the painful stimuli that you're going to be inducing. Here's what often leads people to be apprehensive about propofol administration, and it's propofol infusion syndrome. It's rare, but it is deadly. It will cause end organ damage and failure. So we shouldn't look past it, but it doesn't occur in the patients that we're administering it to because it requires a prolonged duration of administration. Hopefully, you're not doing propofol sedation for 48 hours, or hopefully you don't have a patient in your emergency department who's on sedation on a ventilator for that long. Hopefully you've been able to transfer them to a more appropriate environment. So we shouldn't encounter it, but it often leads to some misunderstanding about the potential issues with propofol. So I would not administer it to anybody in the emergency department if I thought they were going to remain with me for 48 hours. Additionally, I would stay away from maybe the patient that I know has an inborn error metabolism, because that can lead to some complications such as propofol infusion syndrome. This then leads us to another tool to keep in mind, and that's dexmedetomidine. We mentioned before that you could administer this intranasally. What is it though? Unfortunately, probably most of us don't have access to it because it is very expensive. But if you do, you've probably encountered several opportunities to improve patient care through its use. It's an alpha-2 agonist. It is an anxiolytic and a sedative. It has some analgesic properties, but I wouldn't consider it a significant analgesia medication. And it doesn't really reduce my respiratory depression, even though it is a sedative. It almost induces just like sleep. So unlike our medications that affect GABA, like propofol or benzos, it doesn't make you like groggy and kind of altered. It just makes people calm and then kind of go to sleep. So its application is best in scenarios where I just need you to calm down, and you will then be able to tolerate what we're doing. So we're not going to, if I kept stimulating you with something painful, dexmedetomidine is probably not the best option. So not great for like a both bone forearm reduction. But if I needed you to say tolerate your humidified high flow nasal cannula so that we could avoid being more aggressive at airway management, such as intubating you, then this is a great option. It does have some alpha-1 effect, but it's mostly alpha-2 and therefore has more sedative properties, but it's not always perfect, right? There are always issues that we need to counterbalance. The one thing to really keep in mind with dexmedetomidine is that it can cause a reflex bradycardia. It is usually not an unstable bradycardia, meaning they don't become hypotensive with their bradycardia. They usually are able to have the bradycardia resolve with some gentle stimulation. Again, they're just kind of asleep. And if you stimulate them, usually the bradycardia resolves and you can move on. The biggest downside that makes it not a perfect agent is that it currently is very expensive, and that likely is limiting its access for us in the emergency department. The ICUs and the other environments upstairs likely will have it. So it is something to keep in mind though. Now, again, when would we use it? If I'm trying to avoid mechanical ventilation, if I'm trying to avoid intubating you, I think it's a great option if I think, hey, this person will do better if they would just kind of relax and allow the non-invasive ventilating techniques do their job, and we're just fighting them too much. And if I could just get them to relax, dexmedetomidine, give dexmedetomidine, they will then just kind of relax, allow the non-invasive ventilating method help improve their aeration and ventilation, and then we can get to the point where hopefully we're able to stave off and avoid intubation. Another common application is I need someone to really just take a nap through this imaging modality, particularly an MRI. Dexmedetomidine is a reasonable option for that. You can give it intravenously, intramuscularly, intranasally, we'd already mentioned. Now, how about I don't need to systemically treat this person? Their pain is all in their hand, or their pain is all in their face. They have a facial laceration. Can't we do something different? Of course, we can target that area. We can do a regional block. Sometimes we forget there are steps before procedural sedation, or there are alternatives to ketamine. And some of those are some of my favorites, such as landmark guided facial nerve blocks, infraorbital blocks, supraorbital, mental, or even a hematoma block for a cooperative teenager who has a radial fracture. Do a hematoma block, maybe add nitrous with that is a really great way to help mitigate both the pain and the anxiety. The facial nerve blocks are really nice because part of the challenge with repairing facial lacerations is lining up all of our landmarks well. And if I have the ability to make the whole surface of the skin go numb without distorting it with injected lidocaine, it's a really great opportunity. Now, we know that we can also improve our regional blocks if we use ultrasound. Just like we use ultrasound to place central lines, we can use ultrasound to improve our regional blocks. And ultrasound-guided regional blocks have a higher success rate and decreased complication rate and decreased time to performing the block. So it is something to keep in mind. Here's an example of a radial nerve block being performed by two of my colleagues. This is Dr. Rivera Camacho and Dr. Belishev, and is courtesy of one of my ultrasound gurus, Dr. Fraga. And essentially, they are targeting that radial nerve and are going to be able to make that be the only thing that's affected. So if I use my ultrasound, I'm able to avoid any significant complications, such as intra-arterial injection or LAST, and I'm able to have great success. Sometimes adding two therapies together is the best way to counteract one's potential side effects. An example would be dexmedetomidine and ketamine. Ketamine will counteract dexmedetomidin's bradycardia, and the dexmedetomidine will potentially counteract ketamine's potential emergent reactions. It is an opportunity to have two things add together to be better than one. Similarly, and you can administrate it both intravenously and intranasally. Similarly, we've done propofol and ketamine. We know that the combination is both safe and effective in our emergency departments. And ideally, the ketamine will help reduce the hypotension that can be seen with propofol, and propofol will, again, help reduce the issues of emergent reactions that you can see with ketamine. The application, because I'm using both, allows me to use less of both and ideally make it so that my recovery is even faster. I personally like to give them separately, not as a single syringe, because I like to be able to still then tailor the therapy based on what is in need of being delivered in the moment. So maybe I feel the patient needs to have a little bit more sedation and relaxation. We'll do propofol. I feel like maybe the stimulation is causing more issues because it's painful, so I'll give more ketamine. So using both kind of at the same time during the administration, but alternating or using one over the other based on what I think is in need based on the current clinical scenario. So as we kind of think about deploying all these on our roadmap of mitigating anxiety and pain, we first start off with what is, the main issue. And I want to address that issue early to help prevent that tornado from spinning out of control. And I can use my topical applications, my intranasal applications. I also have access to specialists who help me assess children based on their age and their developmental milestones and the unique personalities each one has to help determine what the best strategies are. I hope that you have similar specialists in your operations as well. And then I ask myself, what does a patient need as an individual? What is he or she in need of? Are we in need of more anxiety or analgesia? And then I ask myself, what does the procedure need? Is this a simple, straightforward, quick procedure? Is this something that's more complex? Is this something I need them to hold precisely still for? All of these will help generate, ideally, in the setting or counteracting any of the potential oddities that I might encounter with the patient's individual characteristics. Maybe they have got, underlying lung disease or what other comorbidities they have. All of these things come together and help us develop our plan. And then within that plan, we obviously know we have to follow our hospital protocols. While each of us know that the literature would support us doing away with the NPO status requirements for sedation, if your hospital protocol says that you have an NPO status requirement, you need to abide by your hospital protocol so you don't get in hot water. But then I would encourage you to circle back when you're not working clinically and help rewrite or resolve that issue in that hospital protocol, because NPO status is not something that you and I should have to abide by in the emergency department. And then ask ourselves, what's available? Do you not have dexmedetomidine? Well, then that's not an option. If you do, think about how you can deploy it. And then my last question is, does all of this equal a full procedural sedation? And if it does, can it be done in my emergency department, or should it be done elsewhere? Should it be done in the PACU, or should it be done in the OR, because the complexity of the repair or the complexity of the procedure kind of would warrant that? So hopefully all of those considerations help us figure out how to best mitigate anxiety and pain moving forward. And I look forward to answering any of your questions. Hopefully this was helpful for you. Have a good day.
Thank you very much, Dr. Chen. Our next speaker, it's my pleasure to present Professor Richard Cantor, who is a professor in emergency medicine and pediatrics, retired director of pediatric emergency services and director of fellowship program in pediatric emergency medicine, emeritus medical director of the Upstate Poison Center, Syracuse, New York. Professor Richard will talk about challenging cases in toxic ingestion. Welcome, Prof. You can start, please.
Greetings. My name is Dr. Richard Cantor. I'm a PEM attending and a toxicologist in Syracuse, New York. I want to thank you for taking the time to attend this meeting. The faculty in Saudi Arabia has done a tremendous amount of work for this, and I'm very happy to be a participant. This next half hour, we're going to talk about 4 cases that illustrate toxidromes and toxins that I think you need to have a working knowledge of. Talk landscape, the first case is called A Good Girl Gone Bad. The second is This Could Be Serious. Third case is Bad Night to Be on Call. And then the fourth is this another simple febrile seizure? Now, these are my cases over the years, and some of them had some mistakes, nothing serious, but something to learn from. So with that in mind, let's start. It's about 11 in the morning on a weekend day. You always remember the day in the room and where you've seen patients, which is amazing to me. And the parents bring in this young girl who they claim was normally a happy, normal American child with no medical issues, who woke up one morning as if she was basically possessed by the devil and was acting out with an amazing amount of strange neurologic events. The history here is simple. It's a 15-year-old adolescent girl who claimed that ever since she woke up, she's behaving as if she was possessed by the devil. These are the words of the parents. She had an active case of chickenpox and varicella, but had been doing quite well. She reports no fever, stiff neck, nausea, vomiting, or new rash. It's 4 or 5 days into it, and she was in good shape. On exam, though, we've got trouble. She's got a temp of 40. She's febrile with tachycardia and a little bit of hypertension. Number two, she's extraordinarily combative and very profane and very, very unappealing. Was just screaming and cursing her mother out. It was very sad, and very disturbing. If you took a look at her carefully, her pupils worked, but they were quite dilated. We'll get back to that. Her pharynx was dry. She had a neck that was supple. Her chest moved well with good air entry and clear lungs. Her belly, unfortunately, at the bedside had a suprapubic mass and absent bowel sounds, and we'll get back to that as well. On other parts of her exam, neurologically, she was non-focal. She kind of postured when stimulated. I don't know why at this point. And I went over her very carefully cutaneously, and there were no infected varicella-form lesions. There was nothing unusual. In fact, most of her lesions were dried and healing nicely, and she was at the tail end of the illness to begin with. So the initial problem list was fever, altered mental status, dilated pupils, a bit of posturing and hyperreflexia, and this suprapubic mass, which is disturbing. Investigations. Now, you know, and I know in your heart that this child has an encephalopathic presentation. So we're going to focus on the brain, but the metabolic brain as well. And the critical thing here is to treat what's treatable and fix what's fixable. The normal labs that came back on her were CBC and electrolytes. She had a normal ammonia. We always check that with encephalopathic children, and normal liver functions. We tapped her. Now, she took an extraordinary amount of sedation to be tapped. Extraordinary amount of Versed to take her down. It's an older case. If I had to do it again, I would use propofol or some other really effective titratable sedation. But took a while to really nail and get sedated. And the tox screen was negative. Now, tox screens, as a toxicologist, we're not big fans of those, but you can have some use, specifically to test for cannabinoids and bezylcognine, the metabolite of cocaine. But there's a million other results you can get that aren't very helpful. But anyway, that's a fact that not all encephalopathy is infectious. What about the pupils? And they were strikingly large, but they worked. They worked, and that's a good piece of news. And we did scan her, and she didn't have anything dramatic. Could she have an anticholinergic toxidrome? And the classic one is the following. They red as a beet, warm, dry, flushed skin from dilatation, dry mouth, you don't have salivation, dry as a bone, mydriasis, blind as a bat, and mad as a hatter from Alice in Wonderland, and delirium. This is classic, and she fit like a glove. Okay, the autonomic nervous system, it's hard to believe you knew this perfectly well at one point in your medical training, but it's a battle between the parasympathetic and the sympathetic divisions. Now, I can give you 20 slides on this, and it wouldn't be very helpful, but they have some concepts that are easily discernible, and we'll get into that. Now, if you take a look at her, she does fit anticholinergic symptomatology. What are the drugs out there that can give you anticholinergic effects? And there's a myriad of drugs, and this is not complete, but real. Antihistamines, which I'll talk about, antipsychotics, Thorazine and the others. Antispasmodics, there's a brand named Lomatil. It's a traveler's diarrhea drug, which is a combination of an opiate as well as an anticholinergic. So your bowel activity is gone. So that's anticholinergic. And then muscle relaxants like Flexeril. And last but not least, the dreaded category of tricyclics, which nobody should be taking anymore, but we do have to deal with them. So I don't know how she got here, I mean, with these anticholinergic effects. A word on antihistamines, H1 receptor antagonists. In ODs, they mimic anticholinergic poisoning. This is a very important pediatric concept. An H1 blocker in overdose basically mimics, for lack of a better term, atropine. They equal anticholinergic poisonings. And kids are much more sensitive to the toxic effects of antihistamines than adults. So keep that in mind as well. The treatment of anticholinergic syndromes, number one, most cases only need supportive measures. Only need supportive measures. They get better on their own. Number two, You might think of charcoal or lavage, but in this crazy 15-year-old, I wasn't going near her. But it's always there. Remember, the bowel is paralyzed by the anticholinergics, so the toxin could be lying there in wait. It's another discussion point. And the antidote is called physostigmine. The brand name is antilirium. It's been around since the 20s, 1920s, if you can believe it. And it's really named nicely. The brand name actually matches the activity. It's antilirium. As a pop quiz for my audience, what is the dumbest named drug in the world? Go lightly, and I'll let you figure out why. It's only indicated, Physo, in patients who are delirious or have unstable vitals. And you would never give it without talking to your poison control center. However, it's a well-time-tested antidote, and it's also diagnostic as well for reversing the anticholinergic syndrome, okay? Okay. So moving along, case progression. She got IV Physo, and she completely became normal. She stopped screaming, cursing, kicking, fighting. All her belligerence resolved, and she was a charming 15-year-old girl who didn't know where she was and was crying a bit. How in the world did she get this? And it turns out that at her bedside was a drug called Caladryl lotion. Now, Caladryl used to be called calamine lotion. It's an antipyretic. Calamine is inert. It's an aloe prep. It's soothing to the skin. But then some fool, quite frankly, from a tox standpoint, put an active drug, namely Benadryl or diphenhydramine, in it, either in a clear format or the regular color, which is sort of a pinkish, fleshy color. And this young girl, left to her own devices, was spending the week rubbing this, because she felt better, over her active varicilliform lesions, and she had poisoned herself with diphenhydramine and presented with an anticholinergic toxidrome, mostly with delirium. So the take-home point here is most encephalopathy in kids is infectious in origin, so you don't want to have that. When you combine it with measurable autonomic abnormalities, pupils, bowel sounds, salivation, and whatnot, I want you to think of ingestion. And thank goodness that a suprapubic mass was only a distended bladder from anticholinergic activity. A clean case. I spent a lot of money and did a lot of tests on this kid who got better with a $10 drug, and diagnostically became quite obvious. Okay, let's keep moving. This is one of my most embarrassing cases. It's called This Could Be Serious. The history is simple here. A nice 2-year-old girl presented to my facility for for mid-morning irritability and acting strangely for 4 hours. In the morning, she woke up fine. She had breakfast. She went to play in the backyard with her older siblings, but she returned home acting quite strangely. On exam, it's kind of odd how she presented. Her vitals are not helpful. They're fine. However, she's sleepy and she's irritable when you stimulate her, but she's 2. She's not going to love you. And her pupils are anisocoric but reactive. I could not see her fundi. Please be truthful about this in your medical records. Fundi are difficult to see, but I couldn't see them. And to take a look at her pupils, that's what we're looking at here. Now, I asked the mother if she had ever noticed anisocoria in the child. 12% of children have anisocoria, meaning it's unequal pupils, but they work. Big difference from Paris pupils. And the mother said she had never seen that before in her child. Other physical examination. Neurologically, she was quite disturbing. She was hyperreflexic on the right. She was weak on the left. She had asymmetric pain response. And so now I have a focal deficit in an altered kid who was unobserved in the backyard, who has no past history. There's no secrets here. And what do? The problem list, she's altered. She's unequal pupils. She has focal motor deficits. Frankly, sociologically for me, the most depressing problem was the fact that I was going to have to call neurosurgery to discuss her case. And I don't know what goes on in the Middle East, but the American neurosurgeons are not fun people to call because they never think it's neurosurgically possible. They think it's something else. Well, I digress. All right. So in one of my other talks, I talk about lethargy and altered states in kids. And these are the progressive causes that you cannot, and I repeat, miss. There's mass effects of bleed or cerebral edema in general, meningitic effects, opiate effects, although you don't get combative, and hypoglycemia. And you got to figure this out and you got to deal with this right away and you got to get on it emergently. So what do you do for these? They're quite simple. For the mass effect, you're going to have to get a scan. Just do it. Done. If they're tappable, they're treatable with antibiotics and you can put the tap off for hours and take care of it. Now, Narcan, I told you, the only person who doesn't like Narcan is someone who's habituated to the drug. And I don't think a kid in this age has an opiate habit, but I give Narcan a lot more than I should, but there's really no downside to it. And sugar must be checked with the finger stick. Now, there are other non-progressive causes that are sort of like lab workups, like 30% of diabetics, 30% of new onset type 1 diabetics in peds present in DKA. They lie in wait at home until they get super sick. Sugar, salt, hypernatremic salt kids, you got to wait for the labs. Encephalitics are going to declare themselves. Postictals, unusual. And then, of course, toxidromes, like we talked about with the first case. It doesn't really fit this. Okay, you got a little time with this. And then I keep showing you this mnemonic. Excuse me for a second there. Okay. The mnemonic is AIOU tips. It's very useful. Hold on a second here. I'm trying to get rid of it. Okay, I got it. And the one thing I always harp on is intussusception, but she's got focal deficits, so let's move on. All right, the lab results came back. Scan was normal. That's good news. The CBC, I don't know what I was looking for there, was normal. The TAP, completely benign. However, her blood sugar was 10. We rechecked it, right? You always recheck a crazy lab, and it was 10. So we repeated a finger stick, and it was 0. So further history, grandma lives in the home. Now, I love grandparents. I am one. But we take some sketchy medications. Grandma's a type 2 diabetic who takes glyburide, oral hypoglycemic, and some of her sugar pills were missing. So this child who I did not do a finger stick on, who came in because she was focal, I gave her some D50 and she got completely better. We watched her overnight. Her hypoglycemia resolved after 24 hours. Now you're saying, what the hell's going on here? We got a metabolic abnormality causing a focal neurologic deficit. Well, guess what? Sugar can do it. And my point, I scream this from the rafters. Always get a sugar in any sick kid or infant and child. They don't have glycogen stores. You don't want to miss it. It costs nothing and it fixes everything. There's a lot of reasons to get it, okay? Now, the point here, my recommendation, and I've changed my practice model, is when I'm doing ABCs on sick kids, my ABC ends with a D. Airway, breathing, circulation, chem strip, or dexter stick, whatever you want to call it. And this, to me, is critical. Now, when I did my tox fellowship at NYU from Dr. Goldfrank, who's the smartest tox guy in the world, it turns out that hypoglycemia is the great clinical imitator. It's also the only metabolic abnormality, sodium, calcium, none of those do it, that can give you a focal neurologic deficit. And that was what this child had. Again, I spent thousands of dollars and a lot of pain and suffering on this poor kid, and I fixed him with $1.50's worth of an antidote. So get the sugar, get the chem strip. You'll look like a genius when you do it, and there's no downside to trying. Okay, so we did the anticholinergic child, we did the hypoglycemic child. Let's take a look at something that's even more bizarre. This is a child, sorry for this image, but I love this look. Don't worry, this child didn't grow up with a drug habit. The history here is a 4-month-old who's been pooping all week and vomiting, but now he looks sicker. He poops 15 to 20 times a day. He's probably got neurovirus, and in the old days, he would have had rotavirus. It's foul green, no blood. His emesis is sporadic. Others are getting better, but not him, 4-month-old child. Over the past 12 hours, his parents don't like his color. His Tmax was 38, nothing much there. No rash or cough. They can't tell you if he's peeing a lot because he's pooping all day, all night. And his birth and past history are completely normal. So there's no secrets here. He got sick and he's getting sicker and he doesn't look right. Well, he isn't right. His vitals, he's got a mild temp and tachy. He's breathing at 60. His pressure is okay. His cap refill is okay. His sats are 88% in room air. 88%. Okay, let it sit for a minute. In general, he's tired, lethargic. His chest, he's got no murmur, and his PMI is completely normal, and his lungs, are completely clear. He's breathing quite well. So he passes A, B, and C, to be honest. His pulses are strong. His extremities work. His neurologically, he's a little tired, and his skin has good refill. So I didn't know what was going on here. I have a hypoxic kid who doesn't have much else to measure here. What's the symptom complex? He's hypoxic, he's pale, no murmur, clear lungs, diarrhea. Who puts that together? Where is it going? All right, so what's the framework for investigation? Number one, everybody's septic until they aren't. Just give him cultures and get antibiotics. Is he compensated shock? I don't know from what, but if he was, worry about volume replacement. He's blue. Yes, he is. Cyanotic. I'm going to think of his heart. I'm going to think of his lungs, and I'm going to think of other reasons to be blue. Now, my prior lecture on the sick baby went over this, but you got to keep thinking about cyanosis. So here's what happened. We gave him room air. I said it was 87%. We put him on 100%, no dice, nothing got better. Chest film was normal. We gave him 100% O2, and we got a gas, and the gas made the diagnosis. His PO2 jumped to 300, but his SAT was 88%. So basically, he can dissolve the oxygen, but he can't carry it. In other words, he's got a hemoglobin problem. It's not a heart problem because he dissolved the blood with oxygen. Now, what happens to hemoglobin? We know it's iron. We know that it carries oxygen, but can something mess that up? And I put this up, this is a petri dish to show it, but we spilled some blood when we drew his blood on the stretcher and on the sheet. His blood turned brown. And what this is a case of methemoglobinemia. And if you've ever seen it, you'll never miss it. Methemoglobinemia happens. It's out there. You make methemoglobin every day from oxygen stress. But you have an enzyme, methemoglobin reductase, which just negates it. You have no effects from being exposed with methemoglobin. But babies can be overwhelmed. They don't have a lot of methemoglobin reductase. It's when you convert iron from +2 to +3, from ferrous to ferric, and it can't carry oxygen. It's not carbon monoxide where it overbinds to that. This is a no can carry problem, and there's a nice picture of the hemoglobin molecule. Etiologies of methemoglobinemia, nitrates. Amyl nitrate is a dilator, nitroglycerin, as you know, and we'll get back to infectious diarrhea in a minute. Topical dental anesthetics like benzocaine and lidocaine, notorious for this, can cause methemoglobinemia. Sulfa causes everything. It's the #1 antibiotic. And then mothballs or naphthalene can do it as well. The treatment is you treat blue with blue. Generally, you don't do anything. You put some O2 on them. It won't work, but they can hang around that SAT for a while. But you treat blue with blue, and I've given you the doses here. And it works beautifully. Now, since it's a global world we live in, you have to consider G6PD as an underlying disorder in a lot of the people you take care of. And it would not be good to give them methylene blue. And I leave it to the Poison Center to work through that with you. But you don't want to get involved with that. But meth blue works. The case progression, his level was 30, it should be 2. He got blue over 88 hours, and his stool grew out rotavirus at the time. Now, what the hell? How do I connect the dot between an infectious diarrhea and methemoglobinemia? Well, the connection is based on the bacterial or viral overgrowth in the large bowel, and you produce nitrates in the large bowel, which is like nitroglycerin, and that produces methemoglobinemia. This only happens in young babies. The take-home message, I've said to you before, the secret of mammalian oxygenation is simple. You breathe it, you pump it, you carry it, and use the hyperoxia test. And if it's a SATs in the 80s, consider methemoglobinemia. And there's my favorite chart again, the hypoxemia chart. Let's finish with this case. I'll move quickly for the sake of time. This is 8 o'clock Sunday morning. This was a very strange case. In comes this child is 3 years old. His parents say that he seized at home, and that's okay. Nobody's perfect. He just said the seizure was generalized, lasting less than 2 minutes. There's nothing in this kid's history. He had no illness during the week. Past medical history is negative for trauma, developmental delay, or any drug exposure. Nothing. And there's no family history of seizures. We're getting nowhere here. On exam, his vitals, stop the presses. He's febrile, tachy, hypertensive. Okay, I don't know what's going on here. It generally is combative, no focality. His pupils are dilated, but he's postictal, sleeping in mom's arms. I don't have a source for his fever on his head and neck exam. His chest is perfect. His belly is perfect. There's not much to talk about here. His pulses are normal. Extremities are normal. Neurologically, he's non-focal, and he has sweaty skin. All right, he had a seizure. He's postictal. Now, the American Academy of Pediatrics will tell you, with simple febrile seizures, your job is to find out the cause of the fever. We know the fever caused the seizure, so we don't have to spend a lot of money on these kids. So what do? We parked them. We gave them antipyretics. Sugar was good. We watched them, because often these kids wake up when their temp comes down and they're basically doing higher math, and you don't need any big workup at all. Simple febrile seizure, right? He's old. It was generalized, non-focal. He had no bad history. We bet on that. An hour later, I went in the room fully expecting him to be, watching cartoons and smiling. However, not so good. He's still agitated. His pupils are huge. He's hypertensive still. Is this still a simple febrile convulsion? It is not. So what's my framework for investigation? If it was a simple, I told you, I'd obs him and work up the fever. Is it a CNS infection? Well, it's in the game. He's febrile and altered. I'm going to tap him and maybe image him at some point. And is it an exposure to a toxin? I don't know, but it's in my head. All right, define the complex or toxidrome. With the anticholinergic young girl, we knew what you're going to see. So take a look at sitting here. Now, off the cuff, if I asked you, does this look like an anticholinergic event, or does this look like a sympathomimetic event? And if you want to make that a little more understandable, think of a battle between atropine and epinephrine or cocaine, all right? Like a battle, like a Marvel comic battle. So take a look at that. So let's go through this carefully. There's a mnemonic, it's called AAAS, about things that dilate your pupils. We talked about this in a prior case. But how do you tell the difference between an anticholinergic and a sympathomimetic? They share certain findings. Number one, they're both hyperthermic. The anticholinergic is hyperthermic because they can't sweat. So that's the end of that mechanism for dissipation of heat. The sympathomimetic is sweaty because they have a turned on metabolic rate. They're speeding their brains out, for lack of a better term. They're both tachy and hypertensive. The sympathomimetic for obvious reasons, the anticholinergic because it blocks the vagus. They both have dilated pupils. The anticholinergic paralyzes the constrictor, sympathomimetic stimulates the dilator. But what the tiebreaker is here, and I'll hold to this, is this kid was sweaty. If you have diaphoresis, you do not have anticholinergic exposure. It ain't happening. Sweat breaks the tie. Also bowel sounds, but sweat. So my restating it one more time, the presence of diaphoresis favors sympathomimetics and essentially rules out anticholinergics. And why do I care about this? Because it has other implications. So what is out there for stimulant abuse and exposure? There's cocaine, there's amphetamines, including ice, which is smokable, ADHD meds. In the States, Adderall, Ritalin, pick a drug, methylphenidate type stuff. They're everywhere. And these kids can abuse them because they are stimulants. Make no mistake. You can sell them on the street. And then there's weight loss products. There's phenylpropanolamine and caffeine. And then, of course, over-the-counter caffeine. And who is not drinking a cup of coffee right now? And then, of course, bootleg products. There are people in the New York area that'll sell fake speed sympathomimetics that are really theophylline, an oldie drug for reactive airway disease, or Synthroid, or steroids. They'll put anything in it, but those are the products. Cocaine, I could lecture for days on it. It inhibits catecholamine reuptake, stimulates. You can smoke it, shoot it, snort it, eat it. I don't want to get into that. Classic CNS presentation. You get a speed effect, you feel good about a world, and then you can have all sorts of overdose activity with rigidity and hyperactivity. They do seize, but they're usually self-limited and brief, like our kid. That's good news. And what about kids? How do they get cocaine? There's placental transfer, which is very sad. There is breast milk contamination, which is even more bizarre, but real. Just because the child is being healthily fed with breastfeeding doesn't mean the mom doesn't like to have a little fun once in a while. And then secondary sources with passive exposure. There are amphetamines out there. Methamphetamine is smokable. STP, MDA, MDMA. There's a lot of stuff in the States. Pseudoephedrine, which people think doesn't work, is a decongestant. You have to sign a piece of paper to get this drug. It's over the counter because it is a precursor to methamphetamines, and they want to monitor that. But I could buy heroin quicker than I could buy Sudafed, but there's other speed out there. So what did I do with this kid? Now I'm thinking, all right, he's speedy. Remember, we tapped him, scanned him, we did all the fun stuff. I got to know what's going on. His labs are normal, you can tell. But his urine tox screen was positive for benzocagnine or a cocaine metabolite. All right, we got to talk to these parents, right? And it turns out the parents have a coke habit, and they left it out, and the kid ate it, just gummed it, and they absorbed it and had a sympathomimetic toxidrome. And that was a simple case. We called social services and protected the child, obviously. So in summary, drug-induced encephalopathy may respond to physostigmine. Think about it. Hypoglycemia, I keep harping on it, but just get a chem strip. And then hypoxemia, that oxygen doesn't help. I want you to think of methemoglobinemia and recognize the sympathomimetic toxidrome. Now, the good news is I think we made it on time. I have many more cases to do, but I wanted to give you these 4. Tox is fun. Obviously, as a toxicologist, I love it. But it's an organized approach to many medical issues. And toxidrome should be part of any differential diagnosis. And with that, I bid you a fond farewell, and I want to thank you for tuning into this and giving a lot of attention to the health and well-being of children. So I'm going to sign off and wish you all the best. Thank you.
Thank you very much, Professor Richard Cantor, for these interesting cases that you had present. And I'm sorry, because of the technical problem that we faced this morning, we skipped the break time, and we are now back to normal, hopefully. And this is our last lecture before the lunch break and prayer break. It will be presented again by Shane Fox, who will talk about the critical priority of priorities in pediatric resuscitation. Dr. Shane, you can start, please.
Hello, everyone. Again, I'm Sean Fox from Carolinas Medical Center in Charlotte, North Carolina, and it is once again a privilege to be joining you. This time we're going to be talking about critical priorities in pediatric resuscitations and highlighting some of the pitfalls that we can anticipate and hopefully avoid when we are in these critical moments. 3 main things we want to take away with this conversation today is the positive actions that we know will have a positive impact on our patient outcomes. So not all of the things that we have been taught have the ability to demonstrate consistent positive impact on the outcome of a medical resuscitation, particularly in the pediatric population. We're going to highlight only the ones that we need to focus on to aim at positive outcomes. Additionally, there are plenty of pitfalls that I certainly have encountered many times, and I'm sure you have as well. We're going to highlight them, hopefully define them so that we can then ideally avoid them. And then I'm going to review a set of strategies that we deploy that hopefully you all can utilize as well to help coordinate and organize your team, because that's so critical when we're managing these truly life and death scenarios. So another way to think about it is, hey, life is super complicated. Let's not overcomplicate saving it. There's obviously pitfall management that we need to attend to, and then we're going to focus on the team. So first and foremost, what I want you to do is picture this child. I remember this child vividly. He was diaphoretic. He was very apprehensive, had severe respiratory distress, was sitting on the edge of the stretcher. He was so diaphoretic, trying to apply the cardiac monitors to him was difficult because he was just too sweaty. He had a face mask on, was still hypoxic, and was literally pulling at it, was combative and confused, clearly had significant tachycardia, and his cap refill was just very prolonged. He was very ashen. And of course, we know what's going on. This kid's got severe respiratory distress. We don't know exactly why, but we know that there are things we need to do now to address the severe respiratory distress. Thinking it's probably asthma, so we're going to throw the asthma therapy kitchen sink at him, meaning we're going to give him all the bronchodilators we can. We're going to get steroids in, anticipating needing to give some ketamine so that we can have him become more cooperative with non-invasive ventilation. And I'm barking all these orders out to my team. And in the midst of that, we all know we're in kind of a tough situation, but we're all pretty confident. We know we've been in this situation before. We can manage this. Unfortunately, he decides just to become apneic, becomes horrifically bradycardic and pulseless kind of within milliseconds, it seemed like. So now we have a different strategy altogether, right? Now we have to deploy pediatric advanced life support techniques, right? And this is when the tidal wave of anxiety and apprehension kind of floods into my brain. And I'm like, which strategy am I using? Do I need to get my resuscitation card? And which page do I turn to it? Was this a bradycardic arrest? Is this a PEA arrest? Is this a respiratory arrest? All of those things I'm trying to decipher. Medical arrests, cardiac arrests are fortunately relatively rare, but they do occur. Certainly in the United States, we see in-hospital arrests more commonly than out-of-hospital arrests. And we know that even in the best scenarios, that our outcomes are not ideal. Certainly out-of-hospital cardiac arrests have the worst outcomes. We see that, between 6 and 11% survive to discharge. And that certainly is worse for the youngest. Gets a little bit better as children become a little bit older. But some of this is not in our control. But there are obviously things that we can do to help optimize and kind of lean towards improving these scores and improving these metrics. First and foremost, I think we need to define a couple of things. We need to acknowledge that the no-flow state, where their heart's not beating, is the biggest problem. Obviously, we want this to be as short as possible. That's why out-of-hospital cardiac arrests are usually worse than in-hospital cardiac arrests, because they don't necessarily get the prompt basic life support that they need. And we know that bystander CPR leads to 2 times the chance of survival. So really important for us all to also not only optimize their in-hospital care, but make sure that out-of-hospital people are also familiar with BLS, basic life support, because we can make a significant impact on the survival of children who are at risk or have succumbed to out-of-hospital cardiac arrest. The other thing we need to focus also on is many times we will hem and haw about whether there is or isn't a pulse. Unfortunately, we are not so good at determining whether there isn't a pulse. You would imagine that this would be the easiest thing for us to do. If you imagine the course of someone's medical illness, adults are usually we're more easily able to define their blood pressure diminishing, their pulse worsening, and their cognitive functioning worsening, and we can kind of anticipate when they're going to have an arrest. Pediatric patients love to keep that blood pressure and up until the very end, right? They compensate so well, and then all of a sudden they fall off that proverbial cliff. Well, when they're on the ground after that fall, you would anticipate we'd be able to discern that point pretty well. We'd be able to figure out they don't have a pulse. It's been studied and we're not good at it. We're very good at confirming there's a pulse, but we're slow at deciding that there isn't a pulse. And unfortunately, we falsely identify the presence of a pulse when there isn't one 14% of the time. How do we know this? This study was actually kind of interesting. They took fetal pigs and put them on bypass, and they stuck their little fetal pig arm out a curtain and had us, medical providers, determine whether there was or wasn't a pulse. The patient that was on bypass was alive, but they didn't have a pulse, but we identified a pulse 14% of the time incorrectly. Moreover, when we did accurately determine whether there was or wasn't a pulse, it took us too long. It took us 30 seconds, right? Here, seconds really matter. So err on the side of being aggressive, err on the side of teaching your colleagues and your young professionals that are working with you to be aggressive. Take action within 10 seconds. If you think there's no pulse, take action. If the patient sits up and smacks you in the face because they do have a pulse, congratulations, you've defined them as having a pulse, and now we can move on. But I'd rather be erring on the side of being aggressive here, because when we aren't, the consequences are dire. Once we start compressions, we're in the low flow state, right? Our goal here is not just restarting the heart, but it is cerebral perfusion. So it's return of spontaneous circulation and cerebral perfusion. We want to do both. Unfortunately, again, when we study this, medical professionals, you and me, we do chest compressions and basic life support activities suboptimally 90% of the time. Now, sometimes it's small details, but still, we can't afford any room for error here. What do we need to focus on? I like to break this down into very core concepts. One, I need to deliver high quality CPR. What does that mean? I need to make sure I'm delivering the appropriate depth, which means I need to have a backboard or something hard, a firm surface that I'm pushing against. Otherwise, the child just gets pushed into the bed. I need to make sure that my whole compressive team is organized so that he or she knows that it's the appropriate depth, the appropriate rate, and the appropriate recoil. You have to do the recoil, because if you keep leaning on the chest, then we're not allowing the ventricles to fill again. And we need to have that whole cycle continue. Obviously, if we have a shockable rhythm, we need to shock as expeditiously as possible. Don't let anything interfere with that. And we need to administer epinephrine early, particularly in children. This has been proven to be beneficial. Well, that means I need access. And more often than not, we do like to, allow my very skilled nursing team to get IV access. I like to have peripheral IVs, but here's an occasion where I just go ahead and put an IO in. If we're doing chest compressions, I'm going to anticipate that the peripheral IV is not going to be easy to do, because getting an IV in a normal child is difficult, and now the child has no peripheral perfusion, so it's going to be even more difficult. If I get an IO and a peripheral IV, kudos to us, wonderful, but put the IO in. I need to be able to give epinephrine. And then next, this is the part that we often fall into the main pitfall, and that's, while it is a pediatric arrest, and while this case I just presented to you was a respiratory-induced cardiac arrest, when the heart's not beating, we don't need to intubate the patient. We need to manage their airway. We need to do basic things like good positioning, bag valve mask ventilation, or even better supraglottic device ventilation, and control the respiratory rate so that we're not hyperventilating that patient. Because all of those things, if I try to intubate this child, I'm going to cause interruptions in my high quality CPR, and I must avoid that, right? That's the biggest issue. Unfortunately, we know that when we study how good you and I are at delivering the aforementioned high quality CPR, we are very variable. So that's a significant pitfall. We need to dedicate ourselves to being diligent and vigilant about delivering the high quality CPR. We know this is important because when we do this, it generates real blood pressure. That real blood pressure is not going to just help me start the heart again, but it's going to help perfuse the brain. It's the cerebral perfusion that I want to encourage as well. So doing high quality CPR allows us to generate a real blood pressure. And that, again, high quality CPR helps improve survival from my emergency department and from the ICU. The fact of the matter is also that high quality CPR is difficult to do. Even when we're dealing with pediatric patients, it should cause the person who's doing compressions to become fatigued. And often we let our own machismo and bravado get in the way, and we'll ask, hey, you person doing the compressions, you okay? And they'll say yes, because they're not going to say no. They don't want to let the team down. We should not ask, are you okay? It should just be a defined thing. After 2 minutes, after the 200th count of a compression, right? We're doing 100 compressions a minute. So after the 200th count, that person is not asked whether they're okay about doing more compressions. They are expected to move over so the next person who is fresh and ready to do the next 200 is there, because even the strongest person in the world will fatigue, and what will happen is we will diminish our efficacy of high quality CPR. You'll see the same rate, you'll see the same depth, but they will start to lean on the chest. They won't allow the chest to fully recoil. And without recoiling, we're not sucking blood into the ventricles. And now we're not pushing new fresh blood out to the brain. We're just squishing empty ventricles, which is not helpful. So I know more often than not, the adult patient will have a shockable rhythm, but it does happen in children that they will have a shockable rhythm. And what we don't want to do is prolong the period where we're not delivering the appropriate electricity. So if you get the pads on and you notice there's a shockable rhythm and you're not at your full 100, 200 cycle, it's okay. Stop compressions, defibrillate, and then resume compressions right afterwards. Yes, after you deliver your electricity, resume compressions. We're going to do some assisted chest compressions to help revive the heart after it's been appropriately defibrillated. I mentioned access is critical because delayed epinephrine in children specifically leads to worse outcomes, leads to lower rates of return of spontaneous circulation, leads to lower rates of survival to discharge from the hospital, and leads to lower rates of survival with good neurologic outcomes. So we want to administer epinephrine expeditiously, which means I need to get access expeditiously, which means I'm probably going to favor an IO. Now, I mentioned before that children are more likely not to have a shockable rhythm. That means they're more likely to have a PEA arrest, as the patient I was describing before from that medical arrest. Here's where things can get certainly complicated, because we start to ponder what all of those possible things on the differential that would lead to a PEA arrest, and the H's and T's, which is a terrible acronym for me. I can't remember any of the H's or any of the T's. We think about it this way. When I look at the monitor, if the QRS complex is narrow, that means the myocyte of the heart is healthy. It's trying to do what it's supposed to do. In fact, it's probably realizing that its cardiac output is low, so it's going to increase its rate. So you're going to see a fast, narrow complex, but no pulse. That makes me think of things that are external to the heart that are not allowing it to function. The pump will be obstructed because of tamponade, because of pneumothorax, because of giant PE, thromboembolic disease, or we don't have any fluid in the heart, right? It's hypovolemic or hemorrhage. If, on the other hand, that QRS complex is wide, that means the myocyte has been poisoned. Has been poisoned why? Well, it's been poisoned from toxins like a TCA overdose or cocaine overdose, cocaine in general. Or it's been poisoned by endogenous things like hyperkalemia. Now, certainly, as time goes by, if people have been, deprived of oxygen long enough, and they become acidotic, regardless of what the cause was, it'll become wide and ugly. So I like to focus on, is it wide or narrow? If it's narrow, I'm thinking about mechanical things that are obstructing my heart. And then I might be able to administer different strategies, whether it's decompressing a pneumothorax or pulling fluid off the pericardial sac or thinking about PE. But if it's wide, I'm going to be giving it empiric calcium to counteract possible hyperkalemia, and I'm going to think about empiric bicarbonate to counteract TCA overdose or sodium channel blocker overdoses. I like to keep everything simple because I'm not that smart. When it comes to airway management, here's where, again, as an emergency physician, we often love to jump right to let's intubate. We can cause more problems when we do that, though. We're going to talk about this more explicitly, but we know there's an association with worse outcomes in pediatric cardiac arrests when we intubate the patient initially. So I favor, as my system favors, either doing good bag valve mask ventilation with appropriate positioning. Appropriate positioning here is incredibly important because how we position children really affects how their oropharyngeal and tracheal axes are aligned, or even better, using a supraglottic device to help with the respirations. We can use end-tidal CO2 to help monitor not only our quality of CPR, but also when can give me an indication of whether we get return of spontaneous circulation as well. So it's not all about putting an endotracheal tube in the patient. We can, as I said, if we do have a supraglottic device or an endotracheal tube, we can make sure that it's positioned correctly because we're using end-tidal CO2. But the end-tidal CO2 also gives me some feedback as to how well we're doing with our chest compressions. And if all of a sudden we see a jump from our target of 10 to 15, if we see it jump up another 10, we probably have return of spontaneous circulation. We're going to continue with our chest compressions, but that's going to give me some positive reinforcement. We're going to make sure that our respiratory rate is 1 breath for every 2 to 3 seconds, which is essentially twice the rate that we would use for an adult. That's probably the only real difference that we have in the process between adult care and pediatric care. Also favoring early epinephrine in pediatrics is a little different. After we are successful and we get return of spontaneous circulation, before we high five all of each other and give kudos and congratulations to one another, we have to realize that the patient is still in dire straits, right? They still have significant issues that we're going to have to deal with, that our ICU is certainly going to have to deal with, that post-cardiac arrest syndrome. What we can do to help give them the best benefit upstairs or in the ICU later will be preventing hyperthermia, preventing hypotension, and avoiding hypoxia. Certainly, we don't want to cause hyperoxia, but we would like their SATs to be, above 90%, and ideally maintaining euglycemia and normal carbia. Anticipating seizure activity is good. Wouldn't necessarily empirically treat it, though. So hopefully this checklist will help you making sure that we're delivering not only high quality CPR, but not getting in our own way and ensuring that we're doing all the appropriate steps to optimize our possible outcome. But pitfalls do occur, and these have been studied. Several really elegant studies have looked at deviations in what is recommended. And when we see that, what we find primarily is couple themes. One is not being ready for the sick child and not understanding how to appropriately optimize their airway alignment by simple positioning like a shoulder roll, or not just smushing the bag on their face, which can easily obstruct their airway instead of opening it. We also forget in the heat of the battle that patients of this age, pediatric patients, are little metabolic monsters, and they will chew through all their glycogen stores. They don't have a very large quantity of glycogen stores, so they become hypoglycemic very easily. And then again, delaying epinephrine is a significant problem. Another significant pitfall is thinking it's all about the airway. We mentioned this already, but while intubation is cool, it's not the main priority right now, particularly when the heart's not beating. Yes, I know the patient had a cardiac arrest because of a respiratory illness, but putting an endotracheal tube in there is not going to make their heart beat. So we need to focus on high quality CPR. After we get return of spontaneous circulation, we will have to intubate them, but that's something we get to later. Lastly, like I said before, celebrating too early. We need to make sure we back up after we've got return of spontaneous circulation. We want to make sure we're keeping them away from hypotension And so we're going to start pressors, even if their blood pressure is fine right now. We just gave them a boatload of epinephrine. I'm probably going to want to start them on a vasopressor and then confirm that I'm able to maintain their blood pressure and then dial it back from there. And then start thinking, why? What happened? Use my ultrasound. Is there an intervention I need to deliver right now, such as decompression of the chest, or do they have fluid in their belly and I'm worried maybe they have hemorrhagic shock from occult trauma? I need to think about what else is going on. And probably the thing that we all need to do better of is practicing it, even just cognitively thinking through these processes, because you never are going to be alerted to when it's going to happen. It just usually happens. You need to be ready for it. So use simulation, use courses to help optimize your own ability to be facile and quick to deliver this care. But also, hopefully, when you do that, you do it with your team. Now, I would love to have every team that I am involved with look like this, but when it comes to pediatric arrest, more often than not, they look like this. Everyone comes, but there's too many people and no one really wants to help. They're just there to look. And what I want to do is be able to organize things. Here's what we recommend. We kind of have our respiratory therapists, compressors, and nurses and physicians all aware of where they're supposed to be so they're not in each other's way. And we have defined roles for everybody so that if you were to have to step into someone else's role, you know exactly what you need to do. The respiratory therapist or the person at the head of the bed is understanding they're not going to hyperventilate that patient. The compressive team knows the appropriate rate and depth and recoil and knows that they count out every 20th compression. So the whole team knows exactly what's going on. So you hear a count of 20, then you hear a count of 40. And then when you get to 180, we're going to take action and we're going to actually charge our defibrillator in anticipation of when they say 200, we're going to switch compressors. And in that time, we're going to do a pulse check. And if there's a shockable rhythm, we're going to deliver the electrical dose at that time. If there's not a shockable rhythm, we'll dump the charge. And either way, we will resume compressions expeditiously. After that, we have also people at the more distal end of the patient being in charge of palpating for that pulse, also accessing access and assistance with that. Our team leader is going to be the one coordinating all of this and helping to ensure we're minimizing interruptions in the CPR and analyzing the rhythm and calling out whether we are delivering the electricity or delivering epinephrine. Also, I like to point out, this is usually my role. I'm usually at the foot of the bed, and I usually focus on the patients that are adjacent to the patient, meaning the family members. It's just a reminder that it is important for family members to be witnesses to this activity, even if we're not successful, because it can really help in their grieving process and help in their own healing. Now, all of that coordination, if done well, actually affords you the time later. So you make sure that all of the basic things are being done with precision, and then you're going to buy yourself time because every 200 count takes time. So you're going to have about 2 minutes for us to start pondering other things. Do we need to do an intervention? Is this patient someone who would benefit from emergent utilization of ECMO? Clearly not something that everyone has, but this is when we ponder it. It's not up in the first 2 minutes, not in the first 4 minutes. It's after we get everything kind of organized and we're making sure we're going in the right direction to optimally ensure the basic things are done well. Then we can get to advanced tools and tips. So hopefully with that, we all know that we don't want to overcomplicate saving lives. We want to prioritize the high quality CPR. We want to defibrillate as soon as possible. We want to get access now so that we can give epinephrine now. And then we don't want to mess with the airway. Even if it was a respiratory arrest, we're going to do basic things, align the airway, do good positioning, and then ideally put a supraglottic device in so that you can optimize that ventilation and oxygenation. But a bag valve mask ventilation is appropriate in this clinical scenario as well. We're going to avoid getting in the way of success by intubating. We will have to intubate after we are successful. After we get return of spontaneous circulation, we will have to go back and intubate the patient. That is 100% certain. They're not going to wake up and start talking easily, probably. But we don't want intubation to interfere with high quality CPR. We want to make sure that we're getting access expeditiously, as we said. So don't fear putting that IO in, even if you have an IV being started, put an IO in anyway. We need more access ideally. And then think about ways that we as a team can coordinate and practice, and then figure out with your team how to make sure that you're staying coordinated and practice together. You should ideally know what everyone is going to be doing, and maybe even be able to change positions at times based on what your resources are. You might not have a cadre of compressors that are ready, willing, and able. You may have to alternate providers to be able to keep your compressive team fresh. Remember, after a count of 200, that person is exhausted. They need to get out of there. We need another person to do that CPR. Hopefully that was helpful for you. I think it is critically important that we focus on those basic strategies so that we can optimize the possible outcomes for those really critically ill patients in pediatric cardiac arrest. Thank you very much.
Thank you very much, Dr. Shane, for this very interesting information regarding the pediatric resuscitation. I would like really to announce now we can go over a question and answer. We'll leave it later. I think we can have a break now till 1 o'clock. And we will put the question and answer, we will plot it and put it in word sheet and present it on the screen. Okay, and thanks God, we reached this stage now, and Alhamdulillah, we will start again at 1 o'clock. See you soon. Thank you very much.
بسم الله الرحمن الرحيم والصلاة والسلام على أشرف الأنبياء والمرسلين سيدنا وحبيبنا محمد عليه أفضل الصلاة والتسليم. Welcome now to start the afternoon session. Inshallah, we have exciting lectures about emergency medical service for children that speak about modules and challenge. Our speaker is Dr. Mohsen Saeed Najad. He's an MDA and MS, MBA, FAAP. He's a professor of emergency medicine and pediatric from David Geffen School of Medicine at California, Los Angeles. He's also director of Institute for Health Service and Outcomes Research, also the Landquist Institute for Biomedical Innovation at Harbor in California University at Los Angeles. He's also a director of pediatric research and scholarship at Harbor University of California at Los Angeles Medical Center, Department of Emergency Medicine, Torrance, California.
Hi, everybody.
We can start the question.
I hope everybody is enjoying the conference so far, and I'm very happy to be part of it and speak with you today. I'm going to start my screen with you, and see if I have. There you go. I think I should have my slides go forward for you. So, hi, I'm Dr. Saeed Nishad. I'm a professor of emergency medicine and pediatrics at the David Geffen School of Medicine at UCLA. I also work at the Department of Emergency Medicine at Harbor UCLA Medical Center. And it's my great pleasure to talk to you today about the emergency medical services for children and models and challenges. And in terms of disclosure, because the Emergency Medical Services for Children is a federally funded project, I have to give the disclosure that this is supported by Health Resources and Services Administration of the U.S. Department of Health and Human Services as part of an award that totals $2.74 million with 0% finance with non-governmental sources. And everything I say here is solely my own opinion. I'm speaking on my own behalf, and in no way I'm representing either the HRSA entity, the Health and Human Services, or the U.S. government. So just to give you the learning objectives is to review the history of emergency medical services for children program, to discuss the impact and structural model of EMSC, describe some of the components of the EMSC network and the services that they offer, and to then finally discuss some of the challenges in engaging and sustaining pediatric readiness and quality improvement in low resource areas. So let's start with an example of a patient who lives in a major city near a pediatric hospital. And let's say they're not feeling well. This is Raya. She's been having a fever. She's been ill. She's not eating. And she has tummy ache. So she lives in a community that is close to a pediatric hospital. The ambulance comes and picks her up and takes her directly to a pediatric emergency department or directly to a children's hospital where all of the expertise that she needs are available. She has all the subspecialists. She has people who train specifically in pediatric emergencies, and therefore she can be treated and she can go straight home. As you can see, the hospital has all of those things. They have the right equipment, they have all the right training, they have all the right protocols, they have quality improvement. They're constantly working on how to improve their system. They have the right administrative structure, and they have plenty of opportunities to do things in a timely fashion. Now, Ray, on the other hand, lives in a rural area. His community has an ambulance that takes him to a community hospital ED, where sometimes they have the right equipment, sometimes they don't have the right equipment. There's some concern about safety and simple things like, for example, if your scale is reading not in kilograms but in pounds, your medication dosing may become an error. So right now, the way it works that there's no arrangements, no agreements to take this patient from the rural area and bring him to pediatric specialists. So eventually they will get there, but there is quite a bit of delay in getting appropriate care. So this is where the Emergency Medical Services for Children was developed. So this is a program that was developed to ensure that no matter where a child lives, the healthcare system in their area can provide high quality, appropriate pediatric care. So that means if you need to have access to a subspecialist, you can either do it through a telehealth program, or you have some kind of an agreement that you can contact by phone or some other way to get your expertise. We also know that more than 80% of children who are ill or injured, they don't actually go to a pediatric hospital. They go to a community hospital, emergency medical system, where a lot of the clinicians aren't comfortable managing pediatric cases. They see very few. They see less than 10 pediatric patients in a given day. So therefore, they're extremely uncomfortable managing these children. So it is very important to address these gaps and how to standardize best practice so Raya and Ray have similar patient care outcomes, regardless of where they live. So the MSc program was developed to ensure community and pediatric departments have proper resources, equipment, and training so they can care for children. They also make sure that access to pediatric specialists is available to these hospitals whenever they need it. So that means sharing of resources, regionalization of care model, to ensure that even if they don't have what they need, that it's going to be easy to transfer the child to a high level of care. So they have prearranged agreements that if we need this, this is the children's hospital that's going to come and get the patient. There's this ambulance service that's going to come and get the patient. And everything is already pre-planned so that you don't have to start making phone calls at the time that a real emergency occurs. Now, with the situation that EMSC is created, now Ray is going to have better chances, right? He has EMS bring him to a community hospital. There is arranged interfacility transport, and if the distance is too far, there's a helicopter transport that takes them to the pediatric ER, which is similar to what Raya had, which gets all the resources there. In the meanwhile, their community hospitals also now getting more and more involved in quality improvement projects. They are more involved in telehealth. They have more safety planning, and they are more likely to have a checklist with all the proper sized equipments, proper dose of medication for pediatrics. And this is how the EMSC program helps address the gap in healthcare based on geography. So the EMSC program initially started a while back. So US Congress first passed the Emergency Medical Services Act in 1973. And since that was enacted, the adult patient's care starts improving quite a bit. But then the pediatric patients weren't getting the same kind of resources that the adult patients had. So it was finally in 1984 that the chief of the Hawaii, president of Hawaii Medical Association, Dr. Sia, was the first person to advocate for the healthcare system's infrastructure to help build emergency medical services that can respond to children. So this was not to create a brand new EMS for children, but to have EMS be able to have children capabilities. And this was Congress enacted legislation in 1984, which became public law, and it was supported by the Health Resources and Services Administration after it was supported by two senators and the U.S. Senate, Senator Hatch and Senator Inouye from Hawaii. So since 1984, the EMSC program has been developed. So in the 1980s, the EMSC offered the first four grants. Four states, Alabama, California, New York, and Oregon, were the ones that were given grants to start creating the EMSC in their states. And then eventually all the other states started joining. In 1990s, there was a resource center that was developed at Children's National and a National EMSC Resource Alliance, which is at my institution, Harbor UCLA in Los Angeles. That was the very first structured, organized way of creating EMS for children, parameters, protocols, and policies. And then in 2000s, specific research, high quality national research in pediatric emergency medicine started forming with the emergence of the Pediatric Emergency Care Applied Research Network, also known as PCARN. And the EMSC program started measuring quality, developing guidelines. And in 2010s, the National Pediatric Readiness Project started, where we actually had the opportunity for each hospital to do a readiness assessment, get scores on it, and find areas where there was gaps so they can improve their pediatric readiness. So the concept of being ready to take care of children was something that never happened before. Now the goal is for every hospital to have readiness to care for children. And in the 2020s, the EMSC Innovation and Improvement Center developed where there was a big emphasis on quality improvement and quality collaboratives and dissemination of best practices into the community hospitals. And this is, again, a 40-year history of EMSC since 1984 with all of the different things that got involved. So the data center was developed, the targeted issues grants, the state partnerships where each state got a certain amount of funding from the government to develop pediatric readiness in their state. There was also readiness in a pre-hospital that developed much later so that the paramedics felt more ready for caring for children, since some of the paramedic agencies, they had very few pediatric transports. So it was difficult for them when they had a very sick child. They were not well equipped and they didn't have practice for it. So it was very important for them to use programs like simulation and hands-on training to be able to stay comfortable and confident in managing pediatric cases. So these are all the different elements of the EMSC program, as I can go through these. So the targeted issues grants, these are grants that were offered, one per state. They are either grants to improve emergency department readiness for pediatrics or pre-hospital. There's also the state partnership program that I told you about. Each state has, each state and territories, there's 57 of those. There's the 50 states in the US and 7 territories of the United States that each have their own funding to help make improvements within their state. Their Innovation and Improvement Center, as I was mentioning to you, starting in the 2020s. Then PCARN, the Pediatric Emergency Care Applied Research Network, started in 2003. And the data center, which is instrumental on keeping track of all of these quality improvement projects and supports all the PCARN research and state partnerships and pediatric readiness assessment. That is where all the data is housed at the EMSC data center. So I'm going to go through a couple of these one by one. The state partnership program, as I mentioned, supports 57 states and territories and jurisdictions, helps them identify needs of children in their communities, within the emergency care system, their hospital needs, their pre-hospital needs. And they are not only working on strategies that they develop locally on what works best for their state, but they also have performance measures such as pediatric readiness score, and they actually share with other states some of their findings and some of the ways that they have addressed challenges and barriers. Their goal is also to develop resources that can be shared with others and opportunities that other states can also learn from to be more pediatric ready, and not only pediatric ready, but to have an impactful improvement in pediatric care outcomes. This is an example of a state partnership grant that was offered back in 1986 for the state of California. And as you can see, the goal was to continue integrating EMSC into the state emergency medical services system and to complete the requirements of all performance measures of the national provide appropriate pediatric care and assure that both the basic life support and advanced life support patient care units have the essential pediatric equipment and supplies. Back in 1986, this was a very, very big deal because ambulances didn't carry proper pediatric equipment. And as a result, pediatric transports were always difficult for paramedics. So as you can see, many, many years back, to this 1984 law that went into effect calling for pediatric level of emergency medical services, that these grants were possible. There's also another element I spoke to you about before, the targeted issues grants. Currently 5 of them are wrapping up right now. I believe 3 of them are emergency department based and 2 of them are pre-hospital based. And they basically look for unmet gaps in pediatric emergency care. And their job and their goal is to, through research, through education, through policy, through quality improvement and collaborative efforts to help improve care of the patients in those states. And many of you guys already know about pediatric research through PCARN. This was developed in 2003, the multi-center research network. Most of these studies are 20 to 40,000 patients in it, so it's very, very easy to generalize their findings. The goal of PCARN is to perform meaningful and rigorous multi-institutional research into prevention and management of acute illnesses and injuries in children across the continuum of emergency care. It's very beautifully said. They are currently 7 nodes of PCARN, and one of these is a pre-hospital node, and the other 6 are ED-based, but they all have EMS affiliates within them. This is again the list of the nodes at PCARN. As you can see, there's 7 of them, and there's also the EMSC data center that's responsible for all of the research data that is being collected through these studies. This is some of the examples of outputs from the PCAR network. There is the one about the trial of the anticonvulsants that I spoke about in my seizure talk, or I will be speaking with my seizure talk. There is the PCARN contribution that for bronchiolitis, steroids are actually not useful, and not to use steroids. There is the new algorithm about managing diabetic ketoacidosis. It used to be that you want to avoid fluids so that you avoid cerebral edema, but this study found that patients actually do need to get relatively normal amounts of fluids, and a 20 cc per kilo bolus is not causing them any harm. There's also the very, very famous pediatric head trauma decision support from PCARN, and most recently the C-spine imaging decision tool that was published by PCARN. And these are all very, very strong evidence-based with thousands of patients in each study. So these are some of the contributions from PCARN. The EMSC data center, their job is to support all the different entities that I mentioned about. To the right, there's the infographic and their brochure that they publish about the work that they do. They manage readiness assessment surveys, which is really great, of both the EMS agencies and the hospital emergency departments. There's currently a assessment of readiness of all pre-hospital agencies that's going on. There's about 15,000 of them, and a recent one of all the 5,000 emergency departments recently completed as well in 2021. So their goal is to make sure they have improved survey responses, and they really are a very, very vital element of the evidence that's generated through all these programs. And then the MSc Innovation and Improvement Center, also called the EIIC, it was formed formally in 2016, which really heavily is based on quality improvement science. And the idea is that we learn from each other, we share our knowledge, and we share our practical experience. The mission is to outcome improve with children across the emergency care continuum by using quality improvement methodology and science in a multi-system and multinational collaboration. I'm saying multi-centered and national collaboration. This slide, I think, is a little blurry to me, but this is the structure of the EIIC. As you can see, there are these vertical domains of disaster preparedness, trauma, pre-hospital, hospital-based, state partnerships, and research. And then there's a cross-cutting domain, which all of these domains are involved with, and that's knowledge management domain, advocacy, analytics, etc. And that's the structure of the EIIC. And EIIC works with several national professional societies, such as the American Academy of Pediatrics, the American College of Emergency Physicians, the Emergency Nurses Association, American College of Surgeons, and National Association of EMS Officials, and also most recently, the Children's Hospital Association has been one of the partners as well. In terms of learning resources, one of the very important contributions of the EIIC is the Pediatric Education and Advocacy Kits, which is a comprehensive collection of best practices. The QR code that I have up there takes you to the pages for that. But if you can't get the QR code, just type in EIIC. And then when you get to EIIC, just go under Resources and click on Peak. These are all evidence synthesized using a lot of subject matter experts in the field, and we have several of those already out and more being in development. So these are examples of 6 of them. The peak status epilepticus, I used content from there in the talk that I'm doing or did on seizure management in children. There's also an agitation module in there. There is a series of different platforms in there. So if you like infographics, you can see just in time, really one-pager infographics. There's webinars, there's podcasts, there's interactive learning modules. So whatever your preference is, there is resources that you might find useful. We just recently published our Peak Multisystem Trauma and managing critically ill child with sepsis and septic shock will be the next one that's coming out. Finally, the last couple of things I wanted to talk about pretty quickly is the National Pediatric Readiness Project. This is a quality improvement initiative that is aiming to improve the readiness of hospitals to take care of children. It helps hospitals to be pediatric ready in their emergency departments. This is also part of the EMSC program. It is developed in partnership again with our professional society partners, the American Academy of Pediatrics, American College of Emergency Physicians, and the Emergency Nurses Association. And it offers free resources and open access for people to be able to participate in processes that help them address their gaps and get opportunities to improve their pediatric readiness assessment score. And pediatric readiness is extremely important. It's very meaningful because if you are a pediatric ready hospital, which is in the fourth quartile, ranging from 88 to 100%, you actually are doing better. So this number is a score of 0 to 100, the higher the better. And we know that highest quartile pediatric ready hospital emergency departments have better pediatric care quality outcomes. So in general, the pediatric readiness assessment that was just completed in 2021, the national median score for EDs was 69.5%. But if you were in a score of 87, greater than 87, meaning 88 to 100, you had 76% lower mortality rate among your ill children. You had 60% lower mortality rate among your injured children. And with readiness of the highest quartile, we estimate that about 2,140 patients were saved each year through pediatric readiness. And it is important to note that it doesn't cost that much to be pediatric ready. Somewhere between $0 to $11.84 per child by state, if you look at it by state. But here is another way of looking at that number. So only costs between $4 and $48 per patient, depending on where they live, to be pediatric high level of readiness. And as we say, highest readiness of pediatrics is associated with quality improvement outcomes that are so much higher than pediatric non-ready hospitals. So one of the factors that most directly correlated with being able to be highly pediatric ready is to have that person in your hospital that is a champion for pediatrics, the pediatric emergency care coordinator, as they call it. Also, having a pediatric quality improvement plan where you're constantly trying to look at your processes and trying to improve plans, and also having physicians that are board certified either in emergency medicine on pediatric or pediatric emergency medicine was also associated with highest chance of being pediatric ready. One quick word about quality collaboratives. There's several of these that have either just recently completed or continue to complete. The idea is for hospitals to work together towards a common improvement goal. For example, one goal was to initiate suicide screening among all patients that come to the emergency department. One was around pain reassessment, making sure that a patient gets a pain reassessment 30 minutes after a dose of IV medication or 1 hour after dose of oral medication. And then these hospitals work together to see how each other overcame barriers. and they do this plan, do, study, act PDSA cycles to develop their projects. And this QR code that I have here takes you to the pages that directly speak to the collaboratives. And collaboratives help you reach your clinical practice goals within 3 to 5 years instead of an average of 15 years. So with working with each other, you actually shorten the amount of time that is needed in order to reach your goal. In terms of challenges, children have very unique healthcare needs. The infrastructure for pediatrics is still not as robust as it is for adults. Many ED clinicians who see kids don't see a lot of kids per day, so they're uncomfortable with kids. Most paramedics are uncomfortable transferring kids. Many EMS professionals and hospitals lack the proper pediatric equipment still, and many healthcare organizations still spend most of their money and most of their attention on adults. So problem is that also pediatric ward space is decreasing. Less and less hospitals are keeping their pediatric beds. Pediatricians also don't like to work in the community because of the pay issue. Subspecialist licensed mental health practitioners cannot meet the demand for the pediatric emergencies. There's just not enough specialists for all the sick kids. And most of the children, as I said in the very beginning, are seen in hospitals where there's small volume for pediatrics, and where most of the resources actually concentrated in the pediatric hospitals. Most of the children are going to where the resources are not. So there's a big mismatch between where resources are and where the needs are. And more barriers, problem is that regional resources might be adequate, but local resources usually are not. Access is hard to achieve and sustain. So once you actually have interaction between hospitals, you're most likely to have turnover. You lose your pediatric emergency care coordinator, so some of your progress is going to get lost. ED collaborations are very sensitive. They can happen for a little bit, but then after a while, you may lose those. As I mentioned, personnel turnover, funding and support is still not there. And sometimes the landscape is just very demanding and difficult because it changes all the time. Hospitals are trying to keep resources where they make money off of, and honestly, pediatrics doesn't pay nearly as well as adults. So if it's a financial decision, a lot of these hospitals will increase their adult infrastructure and decrease their pediatric infrastructure. Just as a summary, the MSc program has made great differences in improving pediatric readiness. Adoption of best practices and improving care is still very challenged and can only become overcome by continued support and engagement by all partners and collaborators. So you need people who are passionate, you need funding, you need infrastructure, and you need to be able to have policies and processes that stay the same even if personnel changes. So what you want is an institutional culture that starts warming up to the idea of improving pediatric care. And that's the end of my talk. And thank you again so much for listening to my presentation. And please feel free to reach out to me if you have any questions or require any clarifications about anything that I've said.
Thank you so much, Dr. Martins, for great lectures. We would like to go to a second lecture for afternoon session about confronting respiratory failure in children, strategies for success. we will be the speaker is Dr. Shane Fox. Dr. Shane Fox is a professor of emergency medicine and professor of pediatric. He's also program director at the emergency medicine residency at Carolina's Medical Center at Charlotte, North Carolina. Welcome, Dr. Shane Fox.
Hello, everyone. Sean Fox from Carolina's Medical Center in Charlotte, North Carolina again. And once again, I come to you to discuss some important pediatric topics. This one obviously is in the front of our minds all of the time when we're dealing with children because respiratory illness is so prevalent, and the concern or the fear that a child who is in significant respiratory distress induces in all of us is also substantial. So we're going to talk about some strategies that hopefully will help us manage these children expertly. And another way I think about it is, what kind of fun toys do we have to help us manage children? What are the toys for tots, if you will, in our satchel that we should be carrying around that will help us be successful? Now, I should have mentioned before, if I didn't, I apologize, but I have no financial disclosure with any of these apparatuses that we'll be discussing. I do create some online educational opportunities, but they are free, and the only conflict of interest that usually generates is between my wife and myself, as she's not really sure why I spend all the time doing that. But nevertheless, we're going to endeavor to do three main things. We're going to first and foremost discuss how the anatomy of children and its differences from adults matters, and we need to account for that. We're also going to talk about how basic strategies, basic methods are always best rather than trying to get too fancy. And then discuss the subject of, or the thought of, a supported airway. So let's get into it. Anatomy matters. Now, usually in a pediatric talk, there's usually an iteration, an utterance of this phrase that kids aren't little adults. What I want us to do is recognize, one, that that notion comes from a good perspective. It is designed, or was originally said, to highlight the fact that children do have different anatomy and physiology that needs to be appreciated, needs to be weighed and measured differently than our adult counterparts. But unfortunately, what all too commonly it does is it engenders some apprehension in our providers. It causes us to consider children to be an alien population. And they're not aliens. They are, in fact, human, and they just have distinct anatomy and physiology. So instead of engendering fear and apprehension, I'd rather empower everyone. And the way we're going to do that is by highlighting the fact that they are a unique population. They're a special population with unique features. And the words we use matter. And when we classify and describe children this way, it hopefully will encourage all of us to always be looking for ways to optimize our own management of these children. So what are some of those unique features that we need to keep in mind when we're dealing with children? Well, again, there's three main things I think about. One is that regardless of what anyone has told you in your life, size always matters. Kids are super flexible, which is fantastic, but it does come with its own consequences, and they can be little metabolic monsters. So let's take each in turn. With respect to airway management, obviously, the adult airway is a big giant tube, and the pediatric one is a small one. And if we're dealing with neonates, it's barely appreciable. So the actual target that I'm going for by placing that endotracheal tube is just physically smaller, and that has consequences, not only in challenging me more, but it also can be more easily obstructed with a little bit of edema or a little bit of blood or snot, right? That's essentially bronchiolitis. Is there's just a little bit too much edema, a little bit too much snot, and all of a sudden children have trouble breathing because they have smaller airways. We also know that their airway physically, their glottis is more anterior and more cephalad. And that means my approach and how I look at visualization of the glottis is going to be different. The other anatomic features that we need to always be considerate of is, particularly in the very young child, they have a relatively large head to the rest of their body. They have a relatively larger occiput to the rest of their head. And that means when they're positioned flat, they flex their head forward. And that, in addition to a relatively large tongue in their mouth, will also potentially cause airway compromise just by being poorly positioned. They also, because they have smaller airways, they have a smaller amount of dead space, a smaller functional residual capacity. And that's going to be something we're going to have to keep in mind as we go through this. They are very flexible, which is wonderful. They don't break ribs when they're in traumatic events, which is good. I'd rather not have a broken rib. The problem is the compliance of their rib cage means they actually have to work harder to breathe normally. They have to move their chest wall further to have the same change in volume. And that means that even when they're happy and healthy and having a good day, generate more cardiac output towards the work of breathing than adults do. Well, now they're ill, now they're injured, and their work of breathing is even greater, and that means their cardiac output is even more taxed. That flexibility also is demonstrated when we talk about how easily it is to occlude an airway, right? By, again, poorly positioning a child, we'll just compress their trachea. Or someone who's adjacent to you thinking they're helping you by doing backward, rightward, upward pressure or cricoid pressure is not helping you. They're just crushing the airway. Furthermore, that epiglottis that we like to manipulate by putting our laryngoscope into the vallecula and lifting, when we do that in a kid, the epiglottis usually will flop down in that omega positioning, which can obscure our view of the glottis. So we have to anticipate that. So flexibility is great, but it has compromises and it has complications. The one thing we can never forget is that they are just running hotter than us. Their metabolic engine is just cranked up all of the time. A way to measure this is how much oxygen we consume at rest. You and I consume, 2 to 4 mLs per kilo per minute while we're happy, healthy, doing nothing. Some of you may have fallen asleep, so maybe a little bit less. But children, when they're happy, healthy, doing nothing, are consuming 8 mLs per kilo per minute. Now they're ill, now they're injured, so they're north of that. So they're going to consume oxygen faster. Also, they're going to be burning glucose faster and don't store glucose well, right? Their glycogen stores are not very optimal because their liver is not very functional yet. So those things we need to anticipate that they're going to become hypoglycemic and they're going to become hypoxic, and that we need to put on the front of our mind when we're dealing with anyone with respiratory distress. They may not come in hypoxic, they may not come in hypoglycemic, but in the level of distress that we're dealing with, they may lead to those two situations. All of these things can combine and cause our patients to desaturate very avidly. We've all seen this. Why do kids desaturate very quickly? Well, size matters. They have a small functional residual capacity. Their flexibility is causing them to work harder to breathe, and they are chewing up oxygen faster than you and I do. Well, they're chewing up oxygen, consuming oxygen at a faster rate from a smaller reservoir, and therefore, even if we're giving them oxygen, they will consume it quicker, and therefore, once we make them apneic, desaturate very quickly. So we need to anticipate that. Many times on the adult side of the world, we'll think about what do we do with the standard airway and what do we do with the difficult airway. What I would propose to you now is that there are no easy airways in pediatric patients. You should consider all of them to be difficult. Okay, and why is that? Well, there's certainly methods by which we can look at to assess an airway. There's the Lemon rule, right? They have studied various ways that we can assess whether children we can predict will have difficult airways or not. And literature after literature, anesthesia literature after anesthesia literature has essentially said that we aren't very good at predicting which airways are going to be difficult in the pediatric population. And the only predictors that they've found so far were that they had a prior difficult intubation. All right, that's not rocket science. Or if they have obvious signs of respiratory airway obstruction. And taken across all comers, about 9% of cases were deemed to be difficult after the intervention. It's difficult to predict who will be difficult to intubate. Even if they had a prior easy intubation on the medical records, they could still have a difficult intubation. Okay, pediatric patients are just challenging. So there are some historic points we can look at if they're very young, less than a year of age. We kind of mentioned that if they have signs of upper airway obstruction, if they have congenital or anatomic abnormalities such as Down syndrome with a relatively larger tongue, or Pierre Robin with a small jaw, or cleft palates. Physiologic stress, well, I've not really met a child that I'm intubating who isn't physiologically stressed, and certainly many will become hypotensive, and they've had, the reason I'm intubating them is because they're having ventilation failure, correct? So those two things alone mean they're more likely to be difficult. In the end, don't anticipate any pediatric airway to be easy. Anticipate them all to be difficult, and then after you've intubated them successfully, you can then retrospectively say whether it is or wasn't easy or not. So anatomy matters. There are also some basic things we need to always recognize. I love vitoscopic laryngoscopes. They certainly have, I think, revolutionized how we manage airways across the spectrum of ages. As someone who teaches other people how to intubate, it certainly has alleviated a lot of my stress because I can see how I can help the person who's actually doing the intubation. We know that it's part of our armamentarium. It's part of our toolkit. We should definitely have access to videoscopic laryngoscopes, but we should also be very facile in direct laryngoscopy as well. Now, all of the tools that we need to have will help us be prepared. Our dear friend Marianne Gaucher-Hill and her colleagues with the Pediatric Readiness Program have gone through great strides to ensure that wherever kids are taken care of, they are optimally, they're placed in positions of optimal management, and essentially created tools for us in the United States to look at all of our hospitals and our emergency departments that take care of children and determine whether they have the tools they need. We know that when a hospital scores high on the readiness score, they have lower mortality in pediatric patients who present with critical illness. And what's fascinating is it is not difficult or costly to be ready. Many of the tools that we need are inexpensive and readily available. So while it's not costly to be ready, it's certainly costly not to be ready, and particularly for the children. What things are most often looked over that we need to make sure are in our emergency departments, and we have appropriate sizes for all of the various ages of children? We need appropriate nasopharyngeal and oral airways. We need appropriate supraglottic devices. We need appropriate end-tidal CO2 monitoring. We need appropriately sized McGills. Having McGills can really be quite life-saving, but if you only have adult-sized McGills, you're not going to be able to get that foreign body out of the pediatric airway. Having appropriate sized tracheostomy tubes, also critically important. This is kind of what our airway cart looks like. It's, you know, not super exotic, but it has everything I need in it, and it's portable. We can wheel it wherever we need. It's got all of our oral airways and all of our nasal airways. So I can manage a child's airway even if I don't think I need to intubate them. Maybe they came in with a seizure. I can help support their airway, which we'll talk about in a moment. We've got our end-tidal CO2 monitoring devices readily available there. We have our supraglottic devices. We actually have ones that are even smaller than these. These are just the first three I grabbed. And we have a variety of sizes of bougies, including one that's even smaller than the pediatric one. It's a 6 French neonatal bougie, which helps us, again, with anticipating that difficult airway in the pediatric population. I like to use a variety of flexible stylets based on the size of the endotracheal tube. It's important to have the appropriate sized one. And clearly, all of these things are geared so that I can be ready to deal with any situation that presents itself. And in the pediatric population, all too commonly, we're dealing with patients that are having respiratory distress and, as I said before, prone to become hypoxic. What do we do when we have someone who's become hypoxic? Well, in order to avoid that in the beginning, what we'd like to do is make sure we're positioning them correctly. Basic things are best. So while many times patients will be appropriately positioned at the beginning of a resuscitation, let's say, as the resuscitation goes on, our vigilance with maintaining that position sometimes becomes less. So it's really critically important for the person who's managing the pediatric airway and supporting it in any clinical scenario to really just be focused on that, because many times if we're doing bag respirations, over the course of the bag respirations, we start to push more on the kid's face rather than lifting their jaw to the bag, or we start squashing their whole head down, which then flexes their neck, which then occludes their airway again. So we want to be very cognizant of basic things, making sure the external auditory meatus is in line with their sternal notch and the horizontal plane is one of our cues to ensure that we are either doing a shoulder roll to raise the chest up to that level, or doing, elevating their head to do the same thing in opposite based on their age. I like to use oral airways and nasal airways anytime I'm supporting an airway. If the patient has a gag reflex, obviously not doing an oral airway, but nasal airways to help ensure we're getting past those soft tissues of the palate. I don't let anyone push on the child's neck before or during my attempts to manage a child's airway, because more often than not, they're just going to absent-mindedly occlude their airway. We obviously are going to do pre-oxygenation, but as I said before, once I make them apneic, their functional residual capacity is so small and their metabolic rate is so high that they're just going to gobble up all that oxygen that's in their small reservoir. So using continuous apneic oxygenation through a nasal cannula, high-flow nasal cannula that we have in place while we're intubating is going to be critical to help avoiding the desaturation. Once desaturation happens, usually chaos ensues and it becomes much more difficult to manage the child's airway after that. So it's best to avoid it in the beginning. What do we do when we have a patient who's difficult to ventilate? Well, the anesthesia literature would tell you there's very simple steps that you want to optimize your head position, basic strategy. We want to insert a nasal or oral airway, basic strategy, and ideally use a supraglottic device to help get past all of the soft tissue obstructive devices such as the relatively large tongue. So it's really important to have your supraglottic devices ready at your bedside. If that were to continue, they would say, hey, optimize your position and your technique, insert your supraglottic device. We might need to move to transtracheal ventilation / crike trach, depending on age. Usually the age cutoff is around 8, but you all have seen, small 9-year-olds and you've all seen large 8-year-olds. So it's really a size thing, whether you think you can actually put an appropriately sized tracheostomy tube through their, or an endotracheal tube through their cricothyroid membrane. But it's really important to always have transtracheal as an option. And then they say, you know what, if all else fails and you're having a hard time ventilating and oxygenating, just wake the patient up and cancel the case. But that's not something that we can do, right? That's really never an option for us. So we have to have a, game plan, a strategy in place that we may need to deploy. Hopefully we never need to deploy, but we have to have that strategy in place where we are able to deal with the can't ventilate patient after we've gone through those initial basic steps. And that, again, may lead us to doing a transtracheal ventilation or cricothyroidotomy. So those are the basic things, and the always focusing on how the pediatric patient being special population because of the unique anatomic and physiologic features. Now let's talk about how we can support an airway. And by this, I mean, not every patient that has an airway needs to be intubated. Not every patient that comes in with respiratory distress needs to be intubated. We certainly have come a long way in doing active management and expectant management. And we have new tools such as humidified high flow nasal cannula or non-invasive ventilation techniques that many times will help us in that active management of helping to reduce their work of breathing. And we then need to just be very mindful of how that is progressing. And we're going to always, again, focus on the basics, ensuring optimal positioning and avoid harmful activities such as really reflexive intubation, just because we are worried that the child has increased respiratory distress. There are three times when I think we really should pause before we reflexively intubate a child. One is during the active code. We mentioned before when we were discussing pearls and pitfalls of pediatric resuscitation that there are guidelines about pediatric resuscitation that you all know and love. And when we study where we as a collective group fall out of those guidelines, it is usually with intubating patients kind of preemptively when we shouldn't have. Tracheal intubation during resuscitation is not optimal management of these children. If they're getting chest compressions, we need to optimize high quality CPR, and endotracheal intubating interferes with that. So we'd rather use a supraglottic device because otherwise we're just decreasing their survival. So this is clearly a scenario where bag valve mask ventilation or supraglottic device is optimal management. And we'd want to support their airway until we get return of spontaneous circulation. And then we go back and we intubate. That one's relatively straightforward. The next two requires a little bit of conversation because the intoxicated or poisoned patient or the patient who's had a seizure often will have to deal with whether we need to intubate the patient because their GCS has become diminished, right? The old statement of GCS less than 8 intubate. Well, let's just explore that for a minute. The Glasgow Coma Score is a trauma assessment tool. We've kind of used it across the spectrum of medical ailments as well, but realize that's not what it was intended to do. And we know that from a trauma standpoint, that early airway protection when their GCS is low is beneficial because it leads to less complications in the traumatized patient. We kind of, again, widely applied that without validation. And it leads us to ask ourselves, okay, if you have a low GCS, what's the biggest concern? Well, the concern would be an aspiration risk. GCS is associated with aspiration, but it's not a linear association. And there are a number of patients that I deal with, particularly on the adult side, who are, let's just say, heroically intoxicated, that have a GCS that would be less than 8, and they do just fine, right? So the positive predictive value of a GCS of 3 in being associated with aspiration was only 16%. It's more important to know whether someone has a gag reflex, but even that is difficult to discern. It's led us to be able to say a GCS of less than or equal to 8 alone shouldn't be the reason I intubate somebody. It has to be taken in the context of everything, because gag reflex and GCS do have some correlation, but it's not in a predictive manner. We don't see that as GCS lowers that the aspiration or the loss of gag is specifically correlating. In fact, there are people that have a GCS of 15 that don't have a gag reflex, and they seem to do okay. So long story short is we need to take what else is going on in relationship to the patient's management. Were they a victim of a intoxication with GHB such that they have a really low GCS score, but seem to do well when we don't intubate and they just awaken and maybe would have done harm. So what I want to be clear is I'm not saying that we ignore the GCS in patients, and I'm not saying that no one needs to be intubated. What I'm saying is that GCS is a factor in determining who needs to be intubated, but it's not the only factor. So it's a point of color. And if we only zoom in on one point of color, we kind of miss the whole picture. So use your GCS wisely, but not as your sole determining factor as to why I need to intubate somebody. If I have a patient who's had a seizure and I've given them a bunch of benzodiazepines appropriately and their GCS is measurably at 8, I can support their airway. I make sure they're on an end-tidal CO2 monitor. I make sure they've got maybe some nasal trumpets in so that I'm protecting their airway. I'm able to monitor and ensure that their airway is appropriately aligned. And then I monitor them over the course of time. Now, maybe my resources don't allow me that amount of monitoring in my department. Maybe I don't have an ICU upstairs and I have to transfer the patient to a different city or a different facility, in which case I might have to intubate to protect their airway just because I can't care for them in my locale. And all of these things are different colors of paint on the mosaic of the picture that we're seeing. So the fact that we had to intubate a patient that had a seizure or who is intoxicated shouldn't be driven solely by what their GCS is. Ideally, when we're dealing with any of these scenarios where they've got altered GCS or they're in an active code, we're supporting their airway with nasal trumpets or better monitoring with end-tidal CO2. Hopefully all of those tools are in your bag and you can use them at your discretion and based on your experience. And then probably the most important thing is to continually monitor and reassess your strategy, because sometimes things change and we live in a very dynamic world and the patients that come to us are challenging. So we need to be very prepared and adept at making momentary decisions instantaneously. Hopefully that was helpful for you all. I really anticipate a lively conversation and questions following this. Please let me know I can help you. Thank you.
Thanks, Dr. Shane Fox, for outstanding lecture, actually. Thanks a lot for this. Now with Professor Mariana Goethe-Hill. Professor Mariana, she's a professor of clinical and emergency medicine and pediatric at David Geffen School of Medicine at Harvard University of California, Los Angeles, Medical Center, Department of Emergency Medicine and Pediatric. She's also Executive Director of Academic and Clinical Affairs, the Lundquist Institute at Torrance, California. Welcome, Dr. Mariana.
Hi there, my name is Dr. Marianne Gauchy-Hill, and I'm going to be talking about managing traumatic orthopedic emergencies, key insights. Let's get started. First of all, we'll start out with fractures of childhood, and then we'll move into other types of fractures and traumatic conditions that the emergency physician or clinician really needs to understand as it relates to children. Let's get started. And some of the principles that we need to consider is age and mechanism, because certain types of fractures occur with specific mechanisms. We always have to think about intentional injury. Unfortunately, child maltreatment is something that we need to try to be able to recognize as quickly as possible so we can mitigate any issues with the other family members. We want to consider soft tissue injuries such as, is it an open or closed fracture? Consider fractures involving joints or physes, as it were. Exam should include neurovascular function, always obtain 2 to 3 views. And I think this is what makes our orthopedic colleagues crazy when we don't do that. And again, consider x-rays of the joint above and below the injury. So you can see on the right some of the potential radiographs in terms of AP lateral or AP lateral obliques, depending on the area of focus. So some of the fractures concerning for child abuse, when we think about it, clearly children under the age of 2 typically are at high risk. But these are some of the things we would consider: multiple fractures in different ages of healing or stages of healing. Any fracture other than skull or clavicle, as you know, skull and certain types of skull fractures, especially complex skull fractures, are of definite concern. And then any rib fracture, we need to consider that both anterior and posterior. Humerus fractures, especially midshaft, humerus fractures, not supracondylar fractures. Fractures without trauma history are presenting with evidence of healing, so delay in presentation, and I think that's also critical. And these are some of the examples. You see on the left a femur fracture that's clearly been there for some time. There's a significant callus and healing. Complex skull fractures, so multiple simple skull, linear skull fractures are common in, we'll say, non-intentional injury. And then and you see rib fractures in the x-ray below. Midshaft humerus fracture, you can also see a healing radial fracture on the same view. And then others, what you see, either a bucket handle that you see in the upper right, and then also the chip fractures or metaphyseal chip fractures can be problematic. All right, let's move to green stick. It's the most common fracture pattern, about 50% of fractures in a young child up to adolescence. And it's really an incomplete fracture at the metaphyseal diaphyseal junction, as you can see, and the cortex remains intact on one side. Probably the most serious are the bowing fractures, and we'll get into those. And then some angulation are relatively common. This is a pretty classic green stick. This is generally it's higher up, but this is a metaphyseal fracture or the management includes for green stick is pain control. This would require some closed reduction, generally just molding at the time that the cast is put on, and then immobilization, of course, for 4 to 6 weeks. This is an example of a bowing fracture, and you sometimes how they clinically present is that the patient would have a very deformed looking forearm, as an example, in this particular case. But you don't see an obvious fracture line, and I think this is where comparison views can be really helpful. And for these are microfractures. These are difficult to reduce with closed reduction. So I would consult your orthopedic surgeon for operative repair. These are the most common. I love these little torus fractures, especially in the wrist. These are very, very common. It looks like there's just a little bit of a dimple or bump at the distal end, as you can see in the upper right and lower left, and the other 3. And this is from a compressive load. Generally, it's an outstretched hand, and these are really, really common in children, as you don't see them commonly in adolescents. It's typically toddler in that range. And for distal forearm, like you're seeing here, which is probably one of the most common, you can just use a removable splint, which is really nice because it's just so much easier to take care of. All right, let's move to Salter fractures. These are fractures through the physis, and they're important because they can have different healing complications. So as an example, the type 5, which thank goodness is the most uncommon of them. These have significant issues with either leg length problems or healing issues that are irregular to cause one area of the bone to actually lengthen while the other remains stagnant. So you can remember these by Salter. So split through the physis, that is, you see the normal, and then type 1. Now I have a feeling type 1 are a lot more common than we think. It's just we often miss them. And I'll show you an example of a type 1. These can be really tricky to diagnose. Type 2 are the most common, as you can see here. So through the physis into the metaphysis. And then type 3, which is through the physis and into the epiphysis, and then type 4 both. And then type 5, a crush injury. So here's a type 1. You can see on the left some widening of the physis, Salter type 1. And this is a kid that I saw with a humeral fracture, which was really interesting. And you can see where there's widening of the physis here. And it can be really subtle because this is anterior and this is posterior. Anterior, posterior. So this whole area of the physis is widened. Salter type 2, you can see through the physis and into the metaphysis. And, this is fairly obvious here. And they often, especially in the forearm, are associated with both bone fractures. And then we need to think of fracture dislocations. So we'll talk more about that in a bit. Here's a type 3 fracture through the physis and into the epiphysis. One of the issues is how displaced are they? If they're displaced, then they may, or there is a joint irregularity, then you may need to not just have closed reduction, but operative repair. So again, you probably need to consult, especially for these, I think, the orthopedic surgeon. All right, type 4 go through both the metaphysis and the epiphysis. These especially, this one is relatively non-displaced, a little bit of joint line irregularity here. You see the fracture line here. You can see it outlined in the circle. And again, type 4, I would consult the orthopedist to see if there's a need for operative repair. This is a crush. This is a Salter 5, and you can see there's bone on bone. So that really white cortical crush is bone on bone. And this and different areas of the bone could grow irregularly, leading to a problem in terms of arthritic complications in the future, as well as especially leg lengthening if it's in the tibia or femur for that matter. When you look at Salter-Harris, so what is this? So you go ahead and which is it? You can, this undoubtedly will need operative repair, but you can see really well here what it is, and this is a Salter-Harris type 4. All right, let's move to a case. This is a 16-month-old brought to the ED because the child refuses to bear weight on her left leg. She has no other medical problems, has not been ill. There's no history of a fall, which unfortunately you definitely see this not uncommonly. Now, what happens with children, is they begin to walk. They eventually, around the age of 2, they start running, and it may be a little before that. And so oftentimes they're going in one direction, they plant their foot and twist to go to another. And if you can, once you gain some speed, go fast enough to have a torsive force that is going to cause a fracture. And these are called toddler's fractures. And you can see this here. It may be quite subtle. Here it is. Delayed radiographs can be helpful. And sometimes, you look and you say, I don't see the fracture. And in which case you can follow them, bring them back to primary care, and they can re-x-ray them and look for signs of a callus. But here's some examples. Here you can see the one to the far right, I think, is a lot less subtle, but you can see the callus forming. And the other ones, the one to far left, I think, is subtle. But again, it's a oblique fracture. And it typically what we would do is pain control, like we would do for any type of fracture. Below the knee walking cast for 3 weeks, and then if unclear, 7 to 10 days, I would bring them back. Bone scan or MRI. I think the bone scan is a little bit much. MRI, if you can do a rapid MRI, otherwise you have to sedate. So repeat films is typically, and then obviously you have to think about the other areas of the lower extremity in terms of fracture. Well, let's move now to supracondylar fractures. This is a typical mechanism. A 7-year-old brought in by paramedics after a fall off his bike. He holds his right arm in slight flexion with the obvious swelling of the elbow, and you can see there. And I did this on a trampoline when I was young. I had a supracondylar fracture. Anyway, it's your elbow really, it tends to swell. And then the key thing here is neurovascular injury, which can occur depending on the type of supracondylar fracture. We used to admit all of these. We don't do that anymore. It's really the types in which there's displacement, particularly type 3, and Gartland type 3, we'll talk about that in a bit. And then trauma evaluation otherwise. So supracondylar fractures occur in the region you can see above where the condyles are, so supracondylar. And then, sometimes it's hard to distinguish these from epicondylar fractures, but you can see on the x-ray to the left, drawing the anterior humeral line, that it does not bisect the capitellum. You can see a large sail sign here, anterior sail sign, although an anterior fat pad is normal, and then a posterior fat pad, which is always considered normal. The other finding you see, and we'll go over this, is irregularity of this figure of 8 or hourglass you can see here posteriorly. So supracondylar fractures are fractures of the distal humeral metaphysis just above the condyles. The classic mechanism is fallen and outstretched hand, and our patient fell off his bike on an outstretched hand. And then posterior medial displacement is the most common. So nerve injuries can occur in 7% of displaced supracondylar. The non-displaced supracondylar fractures are type 1. Those essentially you can splint and refer. And then type 2 would be considered for closed reduction. And then finally type 3 are operative repair. So ischemic injury can occur when the brachial artery flow is compromised. So what happens for the supracondylar fracture is that you get the bleeding here on the right that can go into the olecranon fossa, which pushes the fat outward, creating this fat pad sign. Here's the anterior sail sign. So the anterior fat pad, the joint capsule can be distended with blood, causing the normal fat pad to bulge outward, and that creates kind of a sail. And then on the posterior, you can see a nice sail sign here. The posterior fat pad as I mentioned, lies in that olecranon fossa. So a positive posterior fat PET is always considered abnormal. It could be a non-displaced fracture. It can be dislocation. You can see them anyway, they can be very, very subtle just along the bone line. This one's obviously pushed out and with evidence, although you don't see much here, right? But again, there is a fracture, likely a supracondylar or a radial head fracture. One of the most important signs that you should remember now and always as an emergency physician or clinician is that the radial head in every view should align with the capitellum. So you can see this on ABCD. It aligns regardless of the age, okay, regardless of the view. So if you draw a line down the center of the radius, it should always pretty much bisect or align with the capitellum. All right, this is going to be important because we're going to talk about it later. I mentioned this on the very first slide when we're talking about supracondylar fractures. You can obviously see a posterior fat pad, anterior sail sign. You draw a line, it's called the anterior humeral line along the anterior humerus, and you can see that this distal segment is posteriorly displaced. The other thing you can see is a break in the figure of 8 or hourglass. Here's the anterior humeral line, and it really should bisect the capitellum. It does not, so there's definitely posterior displacement. So this would be a type 2 Gartland. Here's another anterior sail sign. Here's that teardrop. You can see how it should be just nice and uniform. Some call it a figure of 8, but there is definite displacement here. All right, these are how you classify a supracondylar fracture. This is really important because it makes a difference in terms of what you would how you would manage them in the ED. So type 1 are the non-displaced. These are ones in which you don't really need orthopedic consultation. You can just ensure good follow-up. And these can, long arm or double sugar tongue, should be splinted and referred, and they could be casted. And you like to do that pretty soon because fractures get kind of sticky and are more difficult if a closed reduction is needed. So generally we would do that in terms of days to a week. Type 2, again, you might see some kind of irregularity in that teardrop. And again, the anterior humeral line, you might see displacement posteriorly. Generally, these are going to be sedation and closed reduction. And then any type 3, they're anterior posterior displacement of the distal fragment. Both of these result in significant swelling and need for operative repair. So now that we've learned that, what kind of Gartland or what it would be the Gartland classification. Now, if I draw the anterior humeral line, it goes through the capitellum, but doesn't quite bisect it. There is a notch here and some irregularity in here. I think this is a type 2, minimally displaced. This is clearly a type 3, and this is a type 3A with the distal fragment going posteriorly. Okay, we talked about the radial head sign, and which of these is a Monteggia fracture? Okay, just give you a moment to look. This is it. If you notice, let me back up 1 second. If you notice, the radial head does not line up with the capitellum. So we definitely have a dislocation. So this is a fracture of the proximal ulna with a radial head dislocation. And I think these are subtle and really one of the things that can be missed if you're reading your own x-rays, and even the radiologist can miss it if it's subtle. So really important to understand this. Montasia injury, a fracture dislocation, which can result in significant morbidity if it is not picked up. So the radial head should always line up with the capitellum, and in this case, it does not. So a Galeazzi fracture is fracture of the, let me back up, is fracture of the distal 1/3 of the radius, distal 1/3, and then dislocation of the distal ulna. And you can see this is why two views are so important. If you look at the AP view, you can't see it, but again, on the lateral. So closed or open reduction is necessary depending on placement that you get with closed reduction. So let's see if you can name this injury. Is this a supracondylar fracture? What is it? And what you see here is the radial head does not align with the capitellum. So we have a distal ulna. The ulna, it's really subtle here, but there is a distal ulna fracture associated with the radial head dislocation. So this is a Montasia injury. It can be very, very subtle, as you can see. All right, moving on to other areas of the body, we're going to talk about the Toulouse fracture. This is fracture of the anterior lateral tibial epiphysis, as you can see in the diagram, and also in the x-ray here, and it causes an avulsion. And this is an important injury to not miss. Let me back up. Some of these require really operative repair, so I think it's something that you really need to understand, and there would need to be a consultation with your orthopedic surgeon in terms of need for operative repair. Here's a kid that I saw, 14-year-old, brought him for ambulance. He was kicking a soccer ball when he heard a crack, fell to the ground, and he really had difficulty bearing weight. His right lower extremity is normal except for tenderness to thigh and hip pain, and when moving the hip inflection or internal external rotation. And when you look at this, I like doing AP pelvis and then laterals. Typically, depending either frog leg lateral or true lateral, and I think both are important. So you may want to get 3 views of the pelvis. The other thing that I discovered with these is sometimes they're really subtle, and you may need to, this is where the fracture is located. If you can see here, it's an avulsion fracture. You may need to do inlet-outlet views if you suspect it. And the classic thing is, as we point out here with the mechanism, but there's different types of mechanism depending on, typically these are sports-related injuries. And so you can see avulsion fractures of the pelvis occur in children and adolescents involved in sports. Ours was an anterior inferior iliac spine. There can be an anterior superior, right? Pubis, ischium, lesser, greater trochanter, iliac crest. All of those can occur depending on the mechanism. You see it in gymnastics, you see it in soccer, you can see it in basketball, football, obviously, but here's an example like ours was down here, anterior inferior. See that here, anterior superior. Okay, and the muscle in it which is involved, and here hamstring, okay, and near where the symphysis pubis is. So management, it shows this fracture at the level of the apophysis. And really, it's pain control and weight bears tolerated. Generally, I say they can go back to sport when they can run without pain. And I think that's very important for these types of fractures. Okay, with that, I know we went pretty quickly. Let me back up here. You can send an email to me for questions. I at M. Gaushi Hill is where I am on social media. So thanks so much and really appreciate the opportunity to speak to you today.
Dr. Marianne, for nice lectures. Because of the time, I'm going to introduce again Dr. Christopher Amato, is Associate Professor at Department of Emergency Medicine and Pediatric at Sydney Cameron Medical College. He's a Director of Pediatric Emergency Medicine Fellowship, also Medical Director of Pediatric Advanced Life Support at Atlantic. He's also attending positions in pediatric emergency medicine, Morristown Memorial Hospital and Brave Children Hospital, Morristown, New Jersey. The lectures will be, inshallah, about evaluating the febrile child. So it will be a focus on infant under 90 days. I think this is, everyone is concerning about these lectures. Welcome, Dr. Christopher.
Good morning, afternoon, evening, whatever it is. You guys are probably sick of hearing from me at this point. Nonetheless, we are going to try and focus on only 30 minutes. And I normally give this lecture over an hour, but we're going to shove a lot of stuff into a small amount of time. Evaluating the febrile child, focusing under 90 days. All right, I have no relevant financial relationships. I'm not going to talk about any off-label or investigative uses. Sadly, again, I have no financial interest or sponsorship. Let's keep going. We're going to talk about the definition and tiny bit about the history of fever, myths and important conversations. We'll mix them in and out throughout the lecture. We'll praise the literature for clinical decision guidelines and considerations of what you should be doing potentially in the well-appearing child. Okay? Now, fasten your seatbelt. Here we go. When we are dealing with children, I want you to focus on this from your point of view. So we're going to take 3 cases, and I want you to think about what you would do with these cases in your own practice. So case 1 is a 23-day-old female, fever that started tonight of 100.7. The next question you should ask is, how do they take that fever? But we'll get to that. No significant past medical history for this 23-day-old. Full-term spontaneous vaginal delivery without any complications. The child is fussy but consolable and occasionally playful, whatever that means on a 23-day-old. 38.6, though, on your rectal temperature in your scenario. 146, 48, blood pressure is 85/45. No focus on this well-appearing child. Caretakers believe in a homeopathic approach. They're actively hugging a tree as you speak to them, but let's keep moving on. Case number 2, 6-week-old boy with fever for 1 day. No significant past medical for this child. Awoke with fever without any other symptoms or prodromal symptoms. Immunizations are up to date. And again, in a 6-week-old, that really just means that they probably have their hepatitis B in the United States. Again, they're fussy but consolable. A 6-week-old could be occasionally maybe be a little bit more playful. 39.2 on your rectal exam, on your rectal temperature, 136/28, and again, 85/45. No focus on exam. All right, so we have the 23-day-old, the 6-week-old. Now we have a 10-week-old female who was diagnosed with RSV yesterday and has continued with fever. Awoke with fever, fussy but consolable, occasionally playful, 39.2 rectally, 136/28, 85/45. Are you seeing some kind of consistency here? I thought so. No focus on exam other than a gooey nose. So, in terms of fever and its history, some housekeeping has to be done. According to Ricky Baraff in 1993, a fever is considered 38.0 Celsius. It has to be a core temperature and an unbundled infant. The most that an unbundling can cause is 0.5 Celsius, okay? But you will never reach 38.5 or higher from bundling alone. That's been shown out in other research that's been done. The child also cannot have had any recent antipyretics or recent immunizations, as those will affect your determination. Is this child have a fever or not? Does this child have a fever? Okay, when we are talking about SBIs or serious bacterial infections, we are speaking about specifically pneumonia, UTI, osteomyelitis, meningitis, or types of bacteremia, periorbital cellulitis, septic arthritis, cellulitis. The concept of bacteremia really went away probably in the late 90s and early 2000s, but we'll touch on that, okay? In general, fever on the most recent evaluation of the United States back in 2021, if fever accounts for almost 1/3 of all ER visits. 8 to 12% of young febrile infants will have a significant bacterial infection. Most of those are UTIs. That is really the key that this lecture is going to focus on. 1 to 2% of them can have invasive bacterial infections, specifically bacteremia or meningitis. Okay, so when we're dealing with SBI, it is usually UTI as the most common. When we're dealing with invasive infections, it is extremely rare for us to see this. So let's just talk about fever in general. Why is it our friend? The anterior hypothalamus says to the body, I need a fever, right? So we have the chill phase of that fever, which is where you're shivering and your teeth are chattering and you're getting blankets and sweatshirts and everything to try and keep you warm. But your anterior hypothalamus cannot cause a temperature above 107 or 41.6 Celsius. That is where we actually have denaturation of proteins, enzymes, and brain damage. Okay, so it would be a really bad genetic trait if we could actually kill off our host with our anterior hypothalamus. So when we're dealing with hyperthermia, really high fevers above 107, that is really consistent more with a child that's stuck in a car on a very hot day, or a malignant hyperthermia from anesthesia or something along those lines. But fever is generally not going to reach a detrimental temperature. We know that fever is beneficial. And in fact, actually, those creatures, those organisms that do not mount a fever are more likely to have morbidity and mortality because they do not have that response. White blood cells actually improve their ability to work between 38 and 40 degrees Celsius. They make more superoxide anion. They actually will certainly inhibit certain production of viruses, specifically polio and Coxsackie, at certain temperatures. So fever is my best friend. That is crucial that we recognize it. It is not a disease that we are trying to stamp out. It is a symptom of an illness, nothing more. When we look at, do I need to do something about this temperature? Do I need to further investigate because I'm concerned about SBI or IBI? We need to determine how did they take that temperature. And peripheral temporal artery thermometry is not going to be adequate. Anything other than core temperatures cannot be utilized when we are worried about a temperature that we need to respond to or investigate further, okay? So we had 75 studies looking at TATs or temporal artery thermometry, comparing the accuracy of this. And what they found was that it really was very minimal. That when we're looking at it, peripheral thermometries do not have an acceptable accuracy and cannot be used when we're looking at a body temperature that will influence our clinical decisions as clinicians. Okay, we're looking at temporal artery scanning, same thing, 5,000 patients. Pool difference was a minus 0.2 Celsius all the way up to a positive 4. And again, it is not accurate. You cannot replace invasive thermometry or core thermometry with a screening thermometer that is just scanning a vital part of the scalp or head. In 2023, this UK study came out that really brought this home, right? And this was looked at because of the COVID-19 pandemic that we all experienced. And it was looking at, can we actually utilize a scanning thermometry as a true screen? And again, when they looked at infrared thermometry in different locations, you had from a minus 0.2 all the way up to a 4-degree difference from core temperature. This is not acceptable. We are scientists and we need clear-cut data. Thermography, infrared thermography especially, is not adequate. Is it a good way for a family to maybe just screen, does their kid have a fever? Sure. Is it a good way to not wake that child up? Absolutely, because sleep is far more medicinal than any fever is at that point. But we as clinicians, if we're going to focus on this temperature means I have to look at this closer and determine if I'm worried about SBIs or IBIs, then I need to have a core temperature. Here's the real crux of the matter is that fever is our best friend as clinician, as parents, as caretakers. We don't need to get crazy about fever. And in fact, fever, again, helps get our child better faster. There is really no compelling reason to treat a fever except for two things. And this is a Chris Amato thing. One, the child is so miserable that they cannot drink or will not drink and maintain their hydration with sugar and electrolytes. Or two, the child is so miserable from the fever that they cannot sleep. So the two things that I need them to do to get better from this illness, hydrate with electrolytes and sugar and rest, they're the only times that I get worried about fever, okay? There is a dramatic amount of fever phobia in the United States. I'm not quite sure what it is in the UAE, but everyone, including clinicians and physicians, are afraid of fever. When I'm telling you, it is our best friend. A lot of families are worried that the fever is going to go so high that it's going to cause brain damage or it's going to lead to seizures. We also know that in certain clinical scenarios, specifically like the traumatic brain injured patient, euthermia is enormously important because an elevated temperature has a dramatic difference in outcome and neurological outcomes for these kids. So fever is my friend in illness, but not in all things, okay? Now we as clinicians need to abate that fear in everyone around us, including those that we are training. Fever is our friend. I showed in the last slide that 50% of parents are waking their kids up in the middle of their sleep to check their temperature and decide whether they need an antipyretic. Please do not let them do that any longer. There is really no value in alternating ibuprofen and acetaminophen. And in fact, the American Academy of Pediatrics came out against it more than 5 years ago. We have scientific evidence to not alternate. In fact, actually, there's higher likelihood of overdosing when we alternate these. And by telling a family that they should alternate medications, that increases their fear of fever, which we are trying to do the exact opposite. Fever is our friend. Please, all you need to do is choose whichever one works best for that child. My children only responded to ibuprofen. My niece only responded to acetaminophen. So whichever one works best for them, just stay with that. In general, fever, again, is going to hang out just as long as it needs to so that the body can get back to homeostasis and move on. Typically, most illnesses will be lasting less than 7 days, right? A third of them could last more than 5 days, but the vast majority of illnesses are going to be lasting less than 7 days. And in fact, a good portion of them can last within the first 24 to 72 hours. So they're going to get better fast. But we're not really concerned about height of fever. We're concerned about how long is it going to last for. Okay? So when we're looking at height of fever, even with hyperpyrexia of 106 or higher, the reality is that that does not indicate whether this is bacterial or viral in nature. You have a 50-50 shot with those kids, assuming that they look well and assuming that they are not immunocompromised and fully vaccinated. Okay, so those two corollaries really are important. But when it comes to, does the height of fever help us? It doesn't. It doesn't change anything that I'm going to do for that kid. When I was training in the early 90s, height of fever, the higher the fever we thought was related to a virus. But when you look at the literature, it's actually 50-50. Length of fever, how long they've been having that fever for, is much more important than how high it is. So if it's now 5, 6, 7 days, we're getting into that fever of unknown origin, and we're widening our differential from bacterial or viral, and we're starting to think about really bad things. Does a response to an antipyretic help us determine viral, bacterial, etc.? And the reality is no, it does not. All it can do, though, is make that child feel better, so you have a better gestalt about what that child looks like at baseline. And depending on your years of experience, that might be enough to help you determine, do I need to go down more testing? What's my pretest probability, and add more tests to that? Or no, I think that they're comfortable. I think that they can go and follow up with their primary doctor. Okay. The reality is, again, it does not, an antipyretic change does not indicate SBI versus viral versus anything else. All it does is can change your gestalt. There's been a lot of changes over the years, and I've been, I've read all of them because I've been doing this for this as long. And in 2019, the PCARN approach came out, and what they were concerned about was that for every degree or for every half degree of Celsius, our risk for SBI increased. Now, this was really more for infants, again, for younger kids, and looking at about 5,000 patients less than 60 days old. Please remember that when we're talking about these younger kids, this is a very important subsection of children that have a higher risk for infections, both SBI and invasive bacterial infections. So, the most common SBI was UTI. Let's go through this. When we're looking through that database, in older kids, a higher temperature did not really indicate one thing or other. Again, it depends if they are fully vaccinated, if they are immunocompetent, well, I can't even speak now. If they are immunocompetent and you have a gestalt that they're looking well to you. The child who is ill appearing, toxic appearing, or certainly has any, vast array of purpurifulminans, I am so sorry. Those are the kids that we're going to be much more aggressive about, okay? But the well-appearing child, it does not necessarily mean one thing or the other. So let's go through the basics. Again, the approach is age, ethnicity, how long their symptoms have been there, what time of year it is, because in the United States, at least in New Jersey, when we start getting towards fall and winter time, we have a higher likelihood of viral illnesses, and that actually can change my pretest probabilities for this kid. But again, for a physical exam, how does the kid look? What is their vital signs? What degree of fever are they reaching? And most importantly, how long have they had it? And then lastly, what is my exam telling me? Okay. And based on those, we're assessing our risks, utilizing our pretest probability to determine the need for labs, using the results from those labs to help us with our diagnosis, and that will ultimately lead us to treatment. We are absolutely going to pull out all stops, hydrating these kids, immediately getting antibiotics on board as fast as possible for the toxic appearing, for the immunocompromised, or certainly anybody who's been on recent antibiotics within the last few weeks for worries of potentially a partially treated meningitis or bacteremia, or even, an SBI like an osteo or a pneumonia. So we need to be cognizant of what's been going on before they showed up in our office or in our ER. But if they are toxic appearing, if they are ill appearing, and this child's got the evidence of petechia all on their face and on their trunk, purpurifulminans, then we know that we need to push out all stops. If they are tachycardic and they are hypotensive, we need to pull out all the stops, hydrate them aggressively. There is no endpoint until we get improved vital signs, and we are getting those antibiotics on board as fast as possible, whether it be intravenous, intraosseous, intramuscular. I don't care. The faster we get the antibiotics on board, the faster those kids have a chance to decrease the morbidity and mortality from this illness. Children also that fall into this high-risk category are the 28 days and less, especially the ones that look okay because they lie. So let's look at the literature. Now, I stole this from Dr. Cantor. He doesn't know about that. But over the years, there have been dozens and dozens and dozens of different approaches to dealing with the febrile child. So we are going to focus on the most recent, and I think the one that has brought all this evidence to bear, so we can start focusing on what we need to do to parse out which are the sick kids that need to be admitted, which are the ones that potentially can go home. Okay. Now, any of you who are old like me, you can recognize that in the bad old days, we had either the Boston, the Philadelphia, or the Rochester criteria for these children. And each of them had different approaches, and we implemented them based on our environment. The good news is that over time, with different studies that have been done, we have proven that the risk for these invasive bacterial infections, specifically meningitis, start to fall the older we get. So between 4 and 6 weeks, similar to what the Rochester criteria used to tell us, we actually have decreased risk for bad things like IBIs as their immunocompetency starts to improve. And that's whether they're being breastfed or not. Again, if you look at the incidence of significant bacterial infections, the overall rates start to fall by 4 weeks by almost half, and then again by 6 to 8 weeks by another half. So we know that the older the child, the decreased risk that we are dealing with these kids. So let's go back to our cases. So we had the 23-day-old with fever tonight of 100.7. By the way, that was a temporal artery thermometer. So you repeat it in your emergency department or your office, and lo and behold, you had a rectal temperature of 38.6. So this is a real temperature. Now, do we believe the parent who said that they took a rectal temperature and it was 100.4 or higher? We do. But the reality is that we have to ask, how did you take the temperature? Okay, so if we verify that it is a temperature of 38 or higher in our setting, then we are going to go down this pathway. And the pathway that we're going to follow is the one that we've been following for the last few years, is basically from 2021, looking at the care of children 8 to 60 days old. So these algorithms are going to separate basically 3 separate groups: 8 to 21 days, 22 to 28 days, and 29 to 60 days. And this is not an exclusive course of treatment. You still have your medical gestalt and management in there, but it is a way for you to help make that pretest probability more significant for you to make those decisions about what needs to be tested. So the publication basically had 21 key statements, again, 3 separate groups that they looked at, and they were looking at, again, the well-appearing child that was a term infant in these groups with a temperature of 38 or higher. All right. Now, why did they look at this? Why did they create this new approach, this new algorithm? Well, over the past few decades, we've had change in bacteriology, right? In the bad old days, we had Haemophilus influenza type B that it was the notorious killer, that they looked fine on hour 1, and then hour 4 or 5, they were dead. And I'm old enough to see that I saw that. Same thing I saw with pneumococcus, but our vaccination protocols have dramatically affected this in terms of what children are being exposed to now. There is predominantly a gram-negative infections that we are seeing in these younger children. We want to provide care that is cost appropriate to these children, and if we can avoid invasive testing or bloodletting and etc., we want to avoid so. We have improved our ability in the treatment or the determination of utilizing inflammatory markers, which is the IMs, as well as viral testing in these kids. And it has continued and utilized all the prior experiences and tried to basically use a meta-analysis approach in this research. So overall, we've had the changes of bacteriology with decreased pneumococcus, decreased group B strep, more gram-negatives, and we've also had improved hygiene, not only in terms of sewage, but also in food safety. So we have made improvements, and it would be inappropriate for us to use old approaches when we can have this newer data to help us. So again, they created by looking at multiple studies to risk stratified neonatal fever. They looked at that PCARN study, which had a lot of clear-cut data from it. That was 2019. And they recognized that there was a big difference between weeks 2 and weeks 3, as well as weeks 4, when we're looking at those older kids in terms of the risk for SBI and IBI. We still recognize that UTI is the most common SBI or significant bacterial infection that we're going to deal with. And this study, though specifically, again, passes out the premature, the focal infections, the immunocompromised, anything that had required any previous antibiotics, anything that would potentially put these kids at a higher risk for partially treated or more fulminant infections because of their ability to fight off infections. The inflammatory markers that they looked at with this study in 2021 was procalcitonin. Now, procalcitonin, and we'll talk about this in a second, is really important because it has the earliest onset of elevation. They looked at absolute neutrophil count, and they were looking at a cutoff of greater than 4,000. They looked at C-reactive protein, which shows up a little bit later than procal. They looked at temperature in and of itself as an inflammatory marker. And if you didn't have procal at your site, then you needed to have both an ANC and a CRP. So why are they utilizing these specific inflammatory markers? Well, CRP again shows up at 4 to 6 hours, but it peaks at 36 hours. So that really doesn't help us within the first few hours of illness, especially in these young kids. Procal, on the other hand, shows up in 4 hours and peaks at 6 hours. And that's what we want. We want something that's going to show up early and tell us, is this body inflamed or not, right? But if you're looking for sedimentation rates or things like that, those are late findings. So you have to be cognizant of what your inflammatory markers do and when they hit so that you can use them in the most appropriate time period. So just looking at that first algorithm for the 8 to 21 days, this is a well-appearing temperature of 38 or higher. We are basically going to be doing everything kind of like normal. Urinalysis, blood culture, we're getting the LP. You can get inflammatory markers, but it's not going to change anything. If we are concerned about HSV, and the most common presentation of this is going to be skin, eye, mouth. So we're looking for that dewdrop on the rose petal with a really high fever. Congenital HSV, herpes simplex, will have a really high fever, 102 to 104. And of course, they could have injected eyes, they can have an enlarged liver, and they can also have that dewdrop on the rose petal. Then we should absolutely be utilizing anti-HSV therapies as well. If we're dealing with the 22 to 28 day old, again, this is a well-appearing child with a temperature of 38 or higher. We're getting urine, we're getting blood, and we're getting inflammatory markers. Now, in this situation, if we have abnormal inflammatory markers, that is our decision-making on this tree, where we're saying if they're normal, we don't have to put them into the process to get an LP. But if they're abnormal, we should absolutely do so and admit accordingly. Okay, and this is the rest of that second group. The last group is the 29 to 60 day old. And if you remember, this is the lower risk group. So there's less for us to do. We definitely want urine because, again, the most common SBI is UTIs. We get a blood culture and we get inflammatory markers. If there's elevated inflammatory markers, then we can consider the utility of a spinal tap and getting CSF on those patients. My point of view, though, is that if I'm going to utilize any antimicrobial therapy, I would rather have all my fluids, be it urine, blood, and CSF, in my microbiology lab growing, rather than have a mixed bag by starting antibiotics without having all that going, okay? So these new AP guidelines, again, less than 8 days, same sepsis evaluation that we've always done, blood, urine, spinal fluid. 8 to 21 days, blood, urine, spinal fluid, plus or minus inflammatory markers, getting admitted for antibiotics. 22 to 28 days is where we add the inflammatory markers, which will help us decide, do we need an LP or not? And then 29 to 60 days is we're getting blood and urine and inflammatory markers and making our decisions based on our clinical gestalt as well as our numbers response. Hopefully I've blown your mind with that. So if we look at our cases, case one, our 23-day-old, this is nothing's changed really with this. We're getting blood, we're getting urine, inflammatory markers. But in this case, because they're in that second group, they're not 22 days, they're 23 days, we can actually use inflammatory markers to decide plus or minus with the spinal fluid. If we look at our case number two with basically a 56-day-old, a 6-week-old, we're talking about that this should be at bare minimum urine and blood and thinking about inflammatory markers. But we don't absolutely need to unless the clinical exam makes us concerned, okay? Do you need viral testing? Well, the reality is that there is a little bit of help if we know that they are viral positive, as we do with the third case, right? The third case is an older girl that has RSV. In my institution, the only value of viral testing is for cohorting them in hospital, in patient rooms. But the reality is that unless we're dealing with some kind of public health emergency like the COVID-19 pandemic, then that's going to be helpful. But otherwise, there's very few that we worry about that needs to be reported. We do have monkeypox that we had to deal with. We do have whooping cough or pertussis that we are dealing with. And of course, right now, whether you're not aware or not, we're having a measles outbreak more in the Southwest United States, but we've had cases both in the Northeast. So are you missing something? You're really not. In terms of pneumonias, if they are hypoxic, that is a pretty good increased test that can tell you basically they have almost a 3 times likelihood ratio for developing a pneumonia, or if they have an increased respiratory rate or work of breathing, that also should prompt you to think about getting a pneumonia. A few other things is that if they had URI symptoms for the first few days and then developed a fever, I would start off with an X-ray rather than blood work, or certainly viral testing. And lastly, if you have an elevated white count above 20 to 30,000, there is also literature to support getting a chest X-ray in those children, okay? The vast majority of clinical findings that you would normally find maybe on an adult are not applicable in a child. Even if you heard crackles in that child, your likelihood ratio is only 1.2. So it's basically the same as if you didn't hear crackles. The most common finding on a child with a pneumonia is a normal chest exam, to be frank. Urine. It is the most important thing we should be thinking about for these older children and about anything else. We don't want to test them unless there's a 1 to 3% pretest probability, but there are quick ways that you can obtain urine. This is the quick wee method. Basically, put pressure, do a Crede on their bladder, put pressure on their lower lumbar, and we have 86% successful urination without catheterization. There are some guidelines here that you can go back and look at. There is the importance of the UTI calculator, which really makes a big difference in these children. And again, interpreting really matters with how dilute or concentrated the urine is. And this is a study from 2021. For the child who has RSV, like our patient, there is really a dramatic difference. In fact, no elevation of bacteremia or meningitis in these kids who had influenza or RSV. So in RSV, if there is persistent fever, though, think about UTI. So looking at this girl, we have the UTI calculator that we utilize, and we actually have a probability of UTI of 5.3%. So we absolutely need to get urine and urine culture in this child. So coming down to the line here, I know I'm a few minutes over, but management of the 3 to 36-month-old with no source, as long as they're fully vaccinated, you really don't need to do anything. If they're unvaccinated, you could consider getting a CBC, maybe think about an inflammatory marker, specifically a Procal or a CRP blood culture, but that really depends on their ability to have follow-up with a primary doctor. Conversations, please avoid the alternation of Tylenol, of acetaminophen, and ibuprofen. Have them clear-cut follow-up instructions, have them follow up with their primary, and last but not least, keep abreast of the literature as it continues to evolve. Obviously, look at your own antibiogram in your own sites, and always be aggressive with the toxic appearing or the ill appearing child. He is the best physician that knows the worthlessness of most medicines. Thank you so much. It was my pleasure. I wish you all the best in the world, and I look forward to hopefully meeting you in person one day. Thank you.
Thanks, Dr. Christopher, for this outstanding lecture. I think this is one of the most exciting because most of our colleagues are always asking about the fever below 3 months. We'll go direct now to the last lecture today, inshallah. Now, our colleague, Dr. Abdessalam Shihri, he's an emergency medicine consultant physician. He's working at the Diriyah Hospital, Riyadh at Saudi Arabia. Welcome, Dr. Abdessalam. His topic also is very, very exciting for everyone here. It's about the medical legal principles to avoid medical lawsuits. Thank you. Welcome, Dr. Abdessalam.
Bismillah ar-Rahman ar-Rahim. Good morning, everyone. It's a pleasure to be here in such an international conference speaking about medico-legal principles to avoid medical lawsuit. My name is Abdussalam Al-Sheri. I'm an emergency medicine consultant at Al-Diriyah Hospital in Riyadh. And I'm going to speak briefly about the major principles that every healthcare professionals should abide by to avoid any legal consequences in medical practice. This statement is a famous saying in the law field. It's give a hint that always you will lose something in case of any lawsuit. Even if the case was dismissed, still you lose something. Maybe you lose some time, some money, or such thing. It's not necessary that you will lose the case at all. So as much as you can, try to avoid any lawsuit. Right, so let's start with the medical malpractice, or what's known as medical error, and start about its definition. Actually, it's any action or deviation from the standard of care when the healthcare professional, whether physician or other, deviate from standard of care, and this deviation cause a harm or injury to a patient. This is what we called medical malpractice. So here a question might raise, which is who decided the standard of care, or what is the standard of care? Actually, you cannot have the standard of care as a black and white in medical malpractice. Usually it will be estimated or evaluated by such expert people in the field, usually when they are in the same position of that healthcare professional when he faced the situation in similar environments, similar circumstances. Would he act to the best interest of the patient or not? So if you read the definition in the slide that I shared, it's mentioned that a reasonable, careful healthcare professional. It means that in the same circumstances and environment he was facing the event. It's not in the best environment or circumstances. So don't always assume that this healthcare professional was in the best environment, so he should be able to handle the situation as if he was in the best environment, or he has all the resources or such things. So always the action of the physician or the healthcare professional should be taken into consideration the circumstances that he or she was involved in. In professional liability, it's not only one type. Actually, it's three major types. Some countries has only two. Number one is the civil liability, or what we called tort or contract liability, sometimes they call it, but it's civil liability. It means that when the healthcare professional or the physician made a mistake, and this mistake caused the harm to the patient, so the physician here is liable, and he should pay for the compensation of the damages that he or she caused to the patient. this is what we call civil liability. There is another type of liability which we called criminal liability. Criminal liability meaning that the physician committed a crime. And when we say the crime, it's not, it doesn't mean that he killed someone or he was robbing or something like that. It means a crime in the context of medical practice. Like, for example, practicing medicine without license, practicing beyond his specialty and such thing. So when the physician or the healthcare professional committed such a crime, even if no harm or damages happen to the patient, still he will be liable. Number 3 is the disciplinary liability. Some people call it administrative liability, which is a violation that made by the healthcare professional, usually related to the ethical principles or some negligence. And here in this liability also, it's not necessary that damages or harm would happen to the patient. So you can be liable even if no harm happened to the patient. So civil liability is the only liability that there should be harm or damages happen to the patient to be liable. In civil liability, actually, 3 elements should be there. If any element of these 3 is missed or it's not there, so you won't be liable and the case will be dismissed. Number 1 is the malpractice or the error. The healthcare professional should commit a mistake. That's number 1. Number 2, this mistake should cause a harm or damage to the patient. Number 3, what we call the proximate cause. It means that the mistake of the physician or the healthcare professional is the direct cause of the harm that happened to the patient. Sometimes you will make a mistake and the patient will be damaged. However, the harm of the patient is not caused by your mistake. So here you won't be liable because there is no proximate cause between the error and the harm. So speaking about the law in Saudi Arabia, actually we do have a medico-legal law. It's called a law of practicing healthcare professions. It was issued in almost 2005, and there is an executive regulation or implementing regulation for this law. And we are going to speak about some articles of this law. Article 5, if you read it, it actually speaks about the general ethical principles in healthcare practice and how is it important for healthcare professional to stick to them. Why is this important? Why it should be mentioned in the law? Because usually the ethical principles or general ethical principle, if you violate it in general or in your normal life, usually nobody will punish you, even if this reach to the court. However, if it's mentioned in the law that violating the ethical principle is part of the law, it means that by violating the ethical principles, you are violating the law. So you might be liable by violating even simple ethical principles in medical practice. So do we have medical ethics guidelines? Actually, we do. We do have a code of ethics for healthcare practitioners or professionals issued by the Saudi Commission for Health Specialties. And actually, it's there in both Arabic and English, and it was stated in the implementing regulation of the law that this code of ethics or ethics guide issued by this Saudi Commission is applicable to healthcare practitioners. In Article 9, it speaks about the healthcare professional should work or should act in the best interest of the patient, and he shouldn't by any means practice beyond his capability or specialty. If we go to the implementing regulation to give the details of this article, it's stated here that you should not do anything to the patient which has no benefit for him, even if it doesn't cause any harm. Like, for example, asking for extra investigation or prescribing some unnecessary medications or admitting a patient with no reason. These things, even if it doesn't cause harm, you are violating the ethical principle and you might be liable. The second part is how would you practice within your specialty or capabilities, and it gives the details that you have to work within your privileges that is provided by the institute actually, and the guide is your registration and classification given by the competent authority, which is the Saudi Commission for Health Specialty. So, for example, if you are classified as consultant pediatric emergency, so the privilege should be within this scope, and it should be detailed enough to know your privileges, except in emergencies, of course. Article 19, actually, it's an important long article, and I just divided it into three different parts. Speaking initially about the consent, that nothing should be performed to a patient except with his consent, or of course his representative or the guardian. And this is, this is clear. But the second part or the exception is that in case of emergencies, or in case of you faced a critical event that you need to intervene immediately, and you cannot take a consent from the patient or any representative or legal guardian, the law give you the permission to act immediately, even without this consent. Keep in mind that some healthcare institute set some like guidelines or policies that you need to sign such consent by 2 or 3 consultants or similar things. Okay, it's like guidelines to execute this article. However, if you cannot find someone to sign with you, it doesn't mean that you are protected from intervening. No, because the law states clearly that you have to intervene once you cannot take the patient consent or his representative or legal guardian. And actually, we do have guideline for the informed consent. It's called the Saudi Guidelines for Informed Consent, and it's being updated frequently, and we are expecting update, inshallah, in the next few months. Who should give the consent? Of course, starting with the patient himself, provided that he's an adult competent patient, whether male or female. Then the agent, if this agent has a power of attorney of an adult competent client. Then the custodian of a child or of a child or an incompetent person, male or female. Custodian, we call it in Arabic al-hawan, of that child is the one who should decide for the treatment of this child or incompetent person. Then the guardian or the trustee, الولي أو الوصي, male or female again, and here it can be a natural or legal person. It can be a solo person or multiple persons even. So if you don't have an adult competent patient, you don't have an agent with the power of attorney, the custodian is not there, then the guardian or the trustee. Then if no one from the above is there, you will go to the relative according to the degree. And when we dig deep into some details of that, the civil transaction law in Saudi Arabia stated clearly that the adulthood age is 18 years according to the Hijri calendar. So if you decided that this is a competent person, he should be an adult, at least 18 years old of age, and he should have full mental capacity and not be interdicted. Regarding the custody or the child in custody, according to the Saudi family law, that one of the missions or the custodian of that child should do is taking care of him, raising him, looking after his interest, including education and medical treatment. And who should be the custodian? Actually, as far as the parents is still married, so both of them should handle the custody. So the father or the mother can decide for the child as the custodian as far as they remained married. And here there will be no problem. The problem usually raised when they are separated or divorced. So who should decide? The custodian. So if the custodian is the mother, she should decide. If the father, he should decide. Then the guardian, the legal guardian, usually assigned by the court, but it's stated clearly that the guardianship has no authority over the child except the authority that does not contradict the custodian authority. So if the custodian, for example, decided something and the guardian decided something else according to the law, the custodian should be followed. His decision should be followed, provided that it's for the best interest of the child or the patient subject to custody, of course. These are the degree of the relatives, of course, labeled in the implementing regulation of law of procedure before Sharia court, started from the first degree till the fourth degree. The last part of Article 9 speaks about the ending life of the terminally ill patient and it's forbidden by law. And the question raised here, does the DNR or allow natural death included in this article or no? Actually, there was a debate on that. Is it what is mentioned here the same meaning of the DNR or allow natural death till the national policy and procedure for DNR was issued by the Saudi Health Council, and it was approved by His Majesty the King. And this ended the debate around this article and the DNR. So the DNR actually can be practiced according to this national policy. Article 21 speaks about when it's allowed for the healthcare professional to break the confidentiality. So as a general rule, you should maintain the confidentiality. However, in some circumstances, you are allowed to break it. Number one, if you want to report a case of death resulting from a criminal act or preventing the commission of a crime. And you know, the reporting here should be to the competent authority only. Number two, when you want to report a communicable or epidemic disease, also to the competent authority only. Number three, if you want to defend yourself before the court or any competent authority, you are allowed to defend yourself, even if by defending yourself you break some confidentiality as far as it's before the this competent authority or court. Article or paragraph B also give the right to the healthcare professional to break the confidentiality if the concerned patient or his legal guardian or representative give consent in writing to disclose his information. And if the disclosure of this information is of benefit to the patient treatment, however, it's limited to his family only. So the law gives the healthcare professional the right to disclose the information to the patient family if it's of benefit to his treatment, his or her treatment, of course. Or at the end, paragraph C, if you receive an order by judicial authority to give the information of such patient, of course, you are allowed to break this confidentiality. Article 4112 of the implementing regulation, actually, it's mentioned something about the trainee, the physician trainee, and their liability in practice. And it mentioned clearly that the institute and the trainee are jointly responsible or liable before the third party if this trainee made a mistake. So if anyone, and this is for the trainee, whether a resident or fellow, if anyone told you that you won't be liable because you are under training, don't believe him or her. Still, you might be liable jointly with the institute if you commit any mistake. So at the end, don't practice defensive medicine, but evaluate patients and document in a defensible way, and always try to practice within the legal statements and ethical principles. That's what I have for today, and thank you so much.
Dr. Abdussalam, for your lectures. I would like to appreciate it. And please, if you have any questions, just put it in the questions area. We are coming now to the end of our first day, inshallah. Hopefully tomorrow, inshallah, we'll be meet here at 8 o'clock a.m. exactly, inshallah.
Believe there are two questions in the Q&A. I would like to answer them live if you allow me.
Yeah. تفضل.
One question is related to the divorced parents or separated, who should be the guardian or the one who decide to give the consent. The custodian is the one, of course. So if the custodian of that child is the mother, she should give the consent. If the father, he should give the consent. But if they are remain married, so any one of them can give the consent. The second question is related to the underage parents. Actually, some countries' law specified that clearly in their law that the underage parents can give the consent for themselves and for their children. In Saudi law, there is no clear statement for that. However, it's believed that as far as they are married, it means that they can make decision for their children and obviously for their self.
Another questions. Finish the first question.
First and second question finished. So I think one more question is there. Is it legal for the husband to consent for his mentally competent wife or mature daughter? No, it's not unless it is approved by the patient himself, whether the wife or the daughter. I know that we are practicing so usually, but in fact, the patient who is adult and competent should decide for him or herself. One more question is alternating. No, this is not related
This
to
is
my
for
talk.
Dr. Christopher. We already sent the answer, and we already prohibit you alternating using ibuprofen and paracetamol because the risk of poisoning and overdose, and maybe the parents not compliance to that treatment. Already he speak to that in the lectures, and we're going to send it inshallah with question and answer inshallah. بس في برضه question عندك what is the difference between the guardian and
And custodian. Okay, the custodian is in Arabic الحاضن, and the guardian is الولي. طبعا I don't know if Ms. Hiba understand Arabic or not, but the custodian usually for the underage children, the court will decide that the mother or the father, in case of separation, will be the custodian. It means he will take care of him as a person. Regarding the guardianship, actually, guardianship is of two types. Number one is the guardianship over the person himself, and the other is the guardianship over the over what we call the money or the status of that child. So the guardian of the person is the one who decide for him or have general supervision, but without contradicting the decision of the custodian. So custodian is having the priority
Is we still with Dr. Abdulsalam? I think there is problems with connection with the internet with Dr. Abdulsalam. We'll wait for him for like a minute. If he couldn't connect to the internet again, we'll end our session for today. So let's wait. Hopefully, inshallah, he will come back.